24. Now I request Dr. Neelam Mohan ma'am to kindly come on stage. Ma'am is Senior Director of Department of Pediatric Gastroenterology, Hepatology and Liver Transplantation and currently practicing in Delhi. Jaundice. Hyperbilirubinemia is a very common pediatric problem, but its management is not as simple as its diagnosis. To solve all the queries, I request Dr. Neelam ma'am to please come on stage, and the topic is 10 Commandments in Management of Jaundice. I also request Dr. Jagruti Bispute, Dr. Jyoti Pawar ma'am, Dr. Rahul Kopikar to be the chairperson for this talk. Please ma'am, Doctor.
Good morning, everybody, and I'm very grateful to the organizing committee to ensure that I was incorporated in the program. And doesn't matter the quantity, the quality matters. So I'm like very touched. Thank you so much for giving me this opportunity. And I have wonderful Dr. Pramod Jog here. Thank you so much for joining in. And आपका session तो सुनेंगे. So I'm pleased to introduce myself as Dr. Neelam Mohan. I'm a senior director at Medanta, the Medicity, where it was the first department started in this country on pediatric gastroenterology, hepatology and transplantation. And the topic, this is the first time I prepared for this because I gave a 10 commandments in neonatal cholestasis and Nashicon, and that was a big hit. And so I thought, let me make 10 commandments in jaundice. So this is a virgin talk which is going to be given in the Nashicon. So in the 10 commandments, first thing is when you start thinking about a patient, what the diagnosis of the jaundice is, the age matters. Because based on the age, I will decide if it's a newborn, then I'm going to think about a cholestasis. I'm not going to think much about the other viral hepatitis or anything like this. If it is a toddler, then the first thing that comes in the mind is the metabolic liver diseases or the genetic disorders or cholangitis, etc. And it's a little older child who comes to you. The first thing that you start thinking about is an acute viral hepatitis, metabolic and diseases, hemolytic disorders, cholangitis, etc. So now the second commandment, idhar dikhana, idhar dikhana. Next, idhar dikhana. इधर से नहीं हो रहा है हाँ नीचे दिखा देना. So the second commandment is a good history which helps you to decide what the etiology is, because if you get a history of a drug history or a prodromal history, then you're thinking more of a acute viral hepatitis, enteric hepatitis, malarial hepatitis. And if you get a past history that there was a previous history of jaundice in the child, then you start thinking, is it a chronic liver disease? Why was there a previous history of jaundice? If there is a family history, then again you start thinking of metabolic disorders, if there was a sibling or a family. And sometimes when cluster of cases are seen, again you start thinking of an acute viral hepatitis. The third commandment is the examination. Now in the examination, when you look for a patient with jaundice, it's very important to understand, is the patient obese or undernourished? Quite often undernourished, you start thinking of a chronic liver disease. Is there something, why is this? An obese fatty liver disease, etc. that can be there, which is going to make this child fall over the edge very soon because the child's liver was already compromised. If there is extensive hemolysis, if I'm in North India, I'm going to think of a G6PD hemolysis in a child with this thing, or I'm going to think about hepatitis A with hemolysis or an autoimmune hemolysis. These will be if there is a jaundice significant with it. Of course, we know that, the other hemolytic disorders, they will have jaundice, but that's not clinically so significant. So if you see a significant deep jaundice, then you start thinking of hemolysis, then it is the three, which is the Hep, Wilson's, autoimmune. Then the CLD signs. If you see a patient who comes to you just with history of jaundice for some time, but there are CLD signs, there is, palmar erythema or spider nevi or any atrophy, then you will know that I'm dealing with a chronic liver disease, even though it looks like a acute. If your spleen is beyond 3 centimeters, it's not really going to be an acute. It's going to be an underlying chronic disease, which time kidhar dikhega? Excuse me. Oh, so is going to be a splenomegaly. And if you get a child who's got already an ascites or a dilated vein, irrespective of hepatitis, you will think it's going to be an acute or chronic liver failure, and an edema may be there. So the type of the jaundice, the third commandment, fourth is the type. You have to know whether it's a cholestatic or an unconjugated or a direct bilirubin, because the etiology, like that cartoon says, totally differs based on the type of the jaundice, pre-hepatic, hepatic, and the post-hepatic, and these are typically seen with that. Then when you look at the liver enzymes, you need to understand, are the liver enzymes less than 3 times raised, or 3 to 20, or more than 20? Because if they're more than 20, that is the time I'm going to think about acute viral hepatitis, or a acute thrombosis like a Budd-Chiari syndrome, dengue, hypoxia, something which has happened, so that will be. And moderate, I'm going to think about mostly the metabolic disorders are going to have 3 to 20 times raised, and less than 3 times raised are the typical, either related to the drug or due to enteric, malaria. So these are the ones which are good, dengue, mild. So these are the ones. So looking at the enzyme, I can predict what I should be doing. And then I look at the enzyme, the ratio, is the SGOT raised or SGPT. Now, SGPT is more specific to the liver, not OT. So if OT is more, I'm going to think about a fatty liver disease or alcoholic liver disease, Wilson's disease, some hemolysis going on. So that's a, or a end stage chronic liver disease when the SGOT is going to get more. Then the sixth commandment is look at the GGT. Even in the government centers, I always insist, instead of an alkaline phosphatase, get the GGT done. Because the GGT suggests the ducts being involved. And if the ducts are involved, it's not the parenchyma injury. The enzymes were of the parenchyma, and this is the duct. So this is going to speak of whether the intrahepatic ducts or the extrahepatic ducts, so the gamma GT is raised. And they may not be raised in hepatocellular injury. And in very few conditions like bile acid synthetic or familial cholestasis, despite the direct bilirubin high, you'll have a low GGT. So we know what to look. Seventh, it's always very important to look at the synthetic function, because if I have to understand what the jaundice is about, I need to understand the synthetic function, because if your INR is raised, then I'm dealing either with a liver failure, if I'm thinking of an acute hepatitis, or if there was an underlying CLD, then I'm thinking of a decompensated liver disease. And in case the albumin was low and there's a short history, then very likely albumin gets low in either a chronic, or there is an ascites, or so these are the conditions where the albumin also is going to be affected. So when I'm looking at the patient with the jaundice, with the bilirubin, I'm not expecting in an acute hepatitis this to be affected. So those were the 7 commandments when you're trying to understand the jaundice, and now you realize that, oh, the synthetic function is bad, maybe this case is a liver failure, or this case is a cholestatic disorder. So you will have to refer to a tertiary care center where there is a liver center, because now we have liver centers all across the country. So very important thing, a commandment is to ensure the safe guidelines for transport. Most of the time doctors forget to talk about the transport. They just tell the patient you go, and that's not fair. You need to just look into a transport. It could be a well-equipped road or an air, because since I do liver transplants, we get a lot of patients through air and road. And another commandment is, when you are not sure what it is, Based on that, follow-up is extremely important because that is going to make you decide which way you're going. What was it? Maybe you didn't understand the first time. So follow-up will tell you where this patient is marching towards in a patient of jaundice. And lastly, the transplant is the cure for a liver failure or an end-stage liver disease. So unlike the kidney, we don't have a dialysis. We have a bridge, which could be a plasmapheresis, CRT, or a mass. But the ultimate thing, if the liver goes, whether it's a chronic or an acute, if it fails, then we do have the liver transplant, which has got very good. So that way the 10 commandments. And in the next 5-6 minutes, I'm going to race through you whatever I taught you till now, how you're going to interpret it in terms of cases. So a typical child jaundice who presents birth weight good, normal delivery, and basic test thyroid, G6PD blood groups were done early at the time of birth. 45 days he goes to the doctor, the pediatrician, who does a bilirubinometer and says your bilirubin is 9, don't worry, it's normal. The same child comes 57 days of life to me. Liver is 3.5, spleen is 2. I look at the child and is nappy and I get worried. Why did I worry? Because the color of the stool was pale. And what was the mistake the doctor did? One of the commandment I gave you was look at the total and the direct bilirubin. He did the bilirubinometer. He had no idea what the direct bilirubin is. So I'm just showing the commandments. So that was wrong, because unconjugated could be neonatal prolonged jaundice, but if it was conjugated, it would have been cholestasis, which is 100% abnormal, not even 1% that he could have thought about with that stool. So that was the mistake he made. The bilirubin was 9.6/7. So this was cholestasis, and this baby was well. If the baby is well, then it is more likely biliary atresia. If the baby was sick, it would have been infection or that. So this baby's biopsy was biliary atresia, underwent surgery, and 4 years down the line is still doing pretty well with the surgery which was. So we give the reports of the biopsy on the same day. It's like I call myself Salman ki behin, ek bari bol diya to phir apni bhi nahi sunti ho. Like I'd committed that I'm going to start a center when we started the first center in the country, that I'm going to have the biopsy reports by evening, and I still give it. And I also take pride in telling to you all, it is probably one of the cheapest private center in this country. And I mean it, you won't believe me. You look at whatever, the Ankura, Rainbow, Fortis, Max, G. Gangaram, everybody, and I'm still the cheapest because I always wanted to grow like a prop tree, and the admin would do. So it is the cost effectiveness, the transplant cost is the lowest in the country, and the endoscopy and everything, because the numbers matter. And we have a department with 6 fellows, 1, 2, 3, 4, 5, 6 fellows. So it's the biggest gastro department in the private sector. So now, fever, vomiting, pain, jaundice, liver 3, spleen 1. So one of the commandment I said to you is look at the enzyme. Now these enzymes are not significantly raised. So this is a probably infective like enteric hepatitis. Here, past history of jaundice is there. And because there's a past history of jaundice, think of chronic, and this patient turned out to be autoimmune liver disease. 4th commandment is, I'll have to rush through. So this child comes to you with pain, abdomen, jaundice, and look at the GGT. The GGT was very high, and this turned out to be sclerosing cholangitis. This patient, if you look closely, only OT is raised, SGPT is not raised. So this turned out to be Duchenne's muscular atrophy and not liver. In liver, it should have been raised. What is missing in this slide? I've given you reports, CBC, enzymes, bilirubin, RFT. Okay, what else? That was one of the most important commandment I gave. no, 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 no. My 10 commandments. What is missing in this? I gave you a clue there, irritability. Now you got the answer. Irritability was there. Excellent. INR is missing there. So I give you so much. So I said specifically always look at the synthetic function, the INR. So INR was missing. It turned out to be liver failure. When this patient came to me, INR was 4, repeat 4.6, then 5. This was the first child who underwent a liver transplant in India. And 20 years down the line, he's a handsome guy there. You can see him. So we've done more than 500 liver transplants with the smallest baby in the world, 2.1 kg done by our department. 33% of our cases are small babies, less than 6'8", and that's a very difficult task. You always start with older and then come to smaller children, and biliary atresia is a common cause. Liver failures are 1/3 of them, 27% of our data, and the outcome is excellent with 91% in a long follow-up. My children are now parents because I was the first to start in India in 2000s. So I think I would end up this slide. I just wanted to show that this child presented with pain, diabetes, and liver enzymes were abnormal. We could not understand. Enzymes were abnormal. Look at the TLC, 1,000 TLC with ANC 326. Even did a bone marrow which was normal, did a biopsy, viral hepatitis, cirrhosis, autoimmune Wilson's, genetics, everything was normal except that steatosis which could have been due to diabetes, and kept thinking, but what did I say? Follow-up is essential. Kept following up. 6 months down the line, I again repeated a biopsy and it showed probably something around the central vein. And then the family confessed, because we asked them 6 times even before, that they went to Baba Ram, they were admitted for 2 months for diabetes. So it was a drug-induced which got the bone marrow and nothing genes came out. So I would sum up commandments. Age matters, because based on the age your diagnosis varies. I'm not going to think about in a small baby or drug, so it matters. A good history, was there a past history, prodrome family history, good examination, was it more of a chronic liver disease, edema, this bilirubin, total, third direct, both you need. Enzymes, was it ALT raised, was it AST raised, or both were raised? And the gamma GT is suggestive of bile duct issues. Synthetic function is important to see. Early referral and a safe transport is equally important, and follow-up is important, and transplant is very rewarding. And I would like to thank you all for supporting me in my journey throughout in the last 2 decades. And you're most welcome to join in the next national conference that I would be organizing in Delhi. Thank you so much.
Thank you so much, ma'am. That was very informative lecture. Now I request ma'am and all the chairpersons to kindly proceed to the felicitation stage. Now I request Dr. A.S. Vasudev sir. Sir is senior consultant and pediatric nephrologist currently working in New Delhi. I also request chairperson Dr. Abhay Tilak sir, Dr. Dwarkanath Ladda sir, and Dr. Mamta Agarwal ma'am to come on dais. UTI. Most annoying and mischievous problem in kids is urinary tract infection. UTI are the ones, if not treated early, can lead to various complications. As we are treating UTI routinely, today we have guests with us who will enlighten regarding the newer guidelines. So topic is newer guidelines for UTI management. Over to you, sir.
Thank you very much. And we can invite the chairpersons. Thank you, chairpersons. Would you like to, can I start my talk with your permission? Right, thank you very much. So as already highlighted, I have about 15 minutes with me, and I would like to finish it a little earlier also, so that we can leave some time for question answers. And at the onset, thanking the organizers for giving me a chance to interact with you on a very important subject. And I'm not talking on the whole of urinary tract infection, but I'll be talking upon the recent guidelines which we have just released in 23. Am I audible? Right, right. So the recent guidelines which have been released recently, I'll be talking about it, and then we see what is the comparison between the ones which we had released in 2011 and now. Right, to start with, it's not moving forward. This, okay, right, thank you. Right, so we all know urinary tract infection is a very common bacterial infection, and even I was surprised to know that it is second only to the respiratory tract infection. And I always say we see so many respiratory tract infections day in and day out in our OPDs, in our IPD. Are we really seeing so many UTIs? If we are not, then probably we are missing a lot of them. And why are we missing them? Because the diagnosis is because the symptoms are very non-specific in UTI. So we have to have a very high index of suspicion. And what is the danger about UTI? Why are we so worried about it? Risk is about the scarring part, and that is why we are worried about picking up UTI very early and treat them properly. Now, what are the subtle symptoms I was talking about? It's not like every child will have classical symptoms of UTI, but any child who has got sepsis, fever without any focus or sepsis, a newborn who has got a prolonged jaundice, as already we have heard about the talk on liver, any child who has got an unexplained vomiting and diarrhea, so very common, vomiting and diarrhea. But if the child is having recurrent vomiting and diarrhea for no rhyme or reason, think of the underlying urinary tract infection. If the child has got failure to thrive, think of UTI. We run in for endocrine and other investigations, but we don't think of common thing like UTI. So it's very uncommon that you will get clear-cut symptoms of dysuria, urgency and frequency, where probably nobody needs to think about it. It's already speaking that it's UTI. So we have to look for subtle symptoms so that we don't miss it. Now, once we are talking about UTI, the first and foremost thing is collection of urine. Various ways are devised to collect the urine, but urine bag which we normally collect is not good for culture. It's only for routine examination and seeing the volume, but not a good method for culture. Clean catch midstream urine is normally the one which we most of the times require, and a thoroughly trained child can be having a midstream urine and a clean catch, but sometimes in a smaller baby it is difficult to pick up urine, and what we have devised is a stimulated voiding. That's a quick wee method. We put a gauze of cold sponge over the suprapubic area, which will stimulate the bladder, and suddenly the child would start passing urine. So ask the mother to clean the private parts with plain water, not soap and antiseptics. And then maybe in a smaller baby, she can apply a cold sponge which will stimulate the bladder and the child can pass the urine. Occasionally we need catheter and suprapubic samples also, especially in children who are hospitalized. Again not moving. Now once we have collected the urine, the first change we are making in our guidelines is about the examination of urine. We were always relying on the microscopic examination. When urine was collected, we used to send for routine and microscopy, and we were waiting for the microscopic examination to come to figure out whether the child has UTI. So first change we are making is that instead of microscopy, we are relying on dipsticks, and two excellent enzymes. One is leukocyte esterase, the other is nitrite. They can be picked up on these urine dipsticks, and this is the first line screening test for UTI. This can be done in the OPD, in the ward, bedside, so very simple. not very expensive. And if both of them are positive, it has got a very high sensitivity and specificity, and you can start the empiric antibiotic if both are positive and send for culture in the meantime. Second part is the urine microscopy, and then we send the urine for microscopic examination because that will take a few hours, and sometimes the urine is lying, and if there are more than 5 WBCs per high power field, they are significant. And occasionally, if the pathologist is good and he can pick up some bacteria in a fresh urine, that will be again a good thing. So if we have LE positive, nitrite positive, microscopy positive, the sensitivity is almost 99% that you are dealing with a child with UTI. You can send for culture and start empiric treatment. So this is the first change, that from microscopy we are shifting to the enzyme detection. Now, once the culture has been sent, we must know how to interpret the culture. If it's a suprapubic, then any number of colony count is significant and it's 99% probability. Catheter sample 10 raised to the power of 4. What is important is the midstream sample, which we are taking as 10 raised to the power of 5 earlier. We have brought it down to 10 raised to the power of 4 to 5 because we might be missing a lot of UTIs if we are relying only on 10 raised to the power of 5. So this is the second change, that in midstream sample, even if the sample is showing 10 raised to the power of 4 and there are symptoms pertaining to UTI, you can take it as a positive culture. Bag specimen, as already told, that is unacceptable. It's set as a negative predictive value. If it's a bag sample and it comes as negative culture, that means you are not dealing with UTI. But if it is a positive culture, just garbage that report. Unnecessarily the child will go on multiple antibiotics, which is not the right thing. Sometimes it's a lower count and they are also significant. If the symptoms are persistent, child has received antibiotics earlier, or is a child on diuretics, or is having frequent urination, then again it will be a dilute urine and the culture colony count may be low despite the fact that the child has UTI. This is a question which I would like to ask my audience, that there's a child who has got a presence of culture positive without any symptoms. It's quite high in boys, in younger boys and older girls, low virulence E. coli. So you get a culture and the culture has been sent for no rhyme or reason. Somebody has ordered all the investigation including urine routine culture, and culture comes positive and the child has no symptoms. What would you like to do in such a child? Start on antibiotics, the child has got E. coli positive, or wait? Wait, right. So this is asymptomatic child, and clinical point of view, no antibiotics for the treatment of asymptomatic bacteriuria. And routine cultures should not be performed in asymptomatic children. That's the catch. That if the child is well, why do we need to send a urine culture and get trapped? उसमें 10,000 colony count आ गया and we are tempted to start antibiotic. But if it's a child is asymptomatic, just ignore the culture. Now coming to the treatment part, that is the second guideline which we have changed. A child who has got a low grade fever, simple UTI, mild urgency, frequency, initial empiric line of treatment pending the culture report should be just oral medication, either first generation cephalexin or amoxiclav. Either of them can be used. Both of them have got excellent concentration in the urine. Duration of therapy, earlier we were saying 5 to 7 days, but what the revised guidelines are saying that 3 to 5 days of medication is good enough, and we do not need to prolong the treatment to 5 to 7 days. So this is the second change, and this is not like arbitrarily done. A lot of studies have been seen world over. The antibiotic AMR is increasing, microbial resistance is increasing, and the world is getting concerned. And in India also, we should also be concerned. Why should our children suffer because of AMR? So we have to cut down on the duration of treatment. Now, some of these complicated children with UTI, pyelonephritis or neonates, that's a different ball game. They have a high fever, toxicity, vomiting, renal anger tenderness or high creatinine. So these are the ones where we cannot take chances. So third generation cephalosporins or amoxiclav again can be started as first line empiric treatment, and subsequently the antibiotic can be modified depending on the sensitivity. So now again I would like to know from the house, many times The culture has been sent, the antibiotic has been started, you have started third generation cephalosporin, and the report comes after 2 days, and my resident comes and says, sir, isme to third generation ceftriaxone is resistant. And then you ask the child, how's the child? But sir, fever to theek ho raha hai, child has started eating. So what would you do? Change according to the culture report or continue the same antibiotic? Excellent, excellent. I think we are all knowing what to do. So we are clinically treating the patient, not treating the reports. So don't just buy the reports. Even if the child is getting better, we should not be tempted to change the antibiotic and continue with the same. Now, in our 2011 guidelines, we were saying IV antibiotics for 10 to 14 days, and all children were going on IV antibiotics. Cannula लगा के घर जाते थे, हर 2 दिन में cannula block हो गया, खींच दिया बच्चे ने, again लगा रहे हैं, and it was a story day in and day out, everybody faced. So what we are proposing in our revised guideline is oral antibiotic treatment for all acute febrile UTIs in children except for two categories. One is children below 3 months of age, and second is very sick child who is having sepsis. There we cannot take a chance. There we have to start IV antibiotics. But beyond that, if the child is not vomiting, just start with oral antibiotics and the child would be better. You can start a third generation cephalosporin or amoxiclav, and you don't need to run for IV. Even if you have started IV antibiotics and the child has got better in next 2 to 3 days, we can again switch from IV to oral. So the third change we are making is that instead of all children going on IV, let all children go on oral, even with a complicated UTI, except if very young or septic child. And even if you started the IV therapy, we can switch to oral after 2 to 3 days. Again, cutting down from 10 to 14 days, we are cutting down to 7 to 10 days in all febrile UTIs. So this is the third change we are made. Just to summarize, if the child has UTI, it's a lower UTI, oral antibiotics for 3 to 5 days. If pyelonephritis or a very small baby or septic child, yes, then IV antibiotics for 2 to 3 days. If there's a clinical response, yes, then complete the course with oral. If the child is older child, just start with oral antibiotics, and then again we don't need to repeat the urine cultures again if the child is getting better. Some of the supportive treatment, we all know about hydration, but what I highlighted is alkalization of urine is not required. Cranberry you can give, every parents will ask, you can give them. What is required is repeat urine culture should not be done after completing the treatment. Again, we get trapped, there may be some bacteria and we are not chasing till the last bacterium. So let the body take over after you have clinically improved the child, and do not repeat the cultures after completing the course. Now after settling the child, our responsibility as pediatrician does not get over. We have to investigate why the child got UTI, and 3 good investigations. We have to do ultrasound in all children where we know what ultrasound anatomical information it will give. VCUG is again another test which is required in some of these patients, which gives excellent information, and then DMSA for seeing the scarring. So which child would require, these are the figures which these are for all my patients with refluxes, which VCUG gave. Sometimes valves are there with bad bladder, and then some other lesions like ureterocele or diverticulum may be present. And DMSA scan, this is the normal scan, unilateral scarring here and bilateral scarring. So which child would require the investigation is very important. If it's a first episode, just get an ultrasound. If it is abnormal, then you go for MCO and DMSA. If child has got a recurrent UTI or a younger child with non-E. coli culture, then you have to get an ultrasound, and you will require MCOG in this child and DMSA scan also. But here DMSA scan should not be done very early because it can give you erroneous results. Some of these preventions for recurrent UTI, we all know about these, but just highlighting that cleaning the perineal area in girls is very important, and you have to spend a minute with the mother to tell her how to clean. Diapers I am not against, but then again they have to be changed every 2 to 3 hours if they are to be used. VUR I'll not talk much about. There's a next talk on VUR, so I'll leave this part of VUR and go on to the last slide as the key messages. We should have a high index of suspicion for urinary tract infection. Urine culture, a proper collection has to be done, otherwise child may go on antibiotics. Febrile UTI carries a risk of renal scarring and should be picked up early. And start with simple UTI, simple drugs, a shorter duration of antibiotics, and some of these children requiring prophylaxis, which Dr. Jyoti will speak in the next talk. So thank you very much for a patient hearing, and these are my helplines. Maybe you can take down the picture any point of time, day or night. If you need any help from me, you are most welcome, and I'll be picking up my phone. Thank you very much. Right, sir. Right, sir. Amoxiclav got a good, it's got a good sensitivity with gram negative and gram positive. Gram positive तो ज़्यादा होते नहीं है. Gram negative के लिए amoxiclav is excellent drug, and the concentration in urine is so good that even before the procedures like MCU and other procedures, we give them a dose of amoxiclav 2 hours before the procedure, and it concentrates in the urine very well. And trust me, I have seen children with ESBL positive E. coli who are responding very well to amoxiclav and third generation cephalosporins, despite the fact that the culture report shows resistant, and children are still responding. So we do not just go by the report, see the clinical response, and with the experience we all know that these are very good drugs.
Thank you.
Yeah, there's another question there. Cefexime is a third generation. We can use it, but don't use as a first line for first UTI. If it's a recurrent UTI, then it's good. First line के लिए I was always recommend use cephalexin or amoxiclav. They are simpler, and third generation again it can change the gut flora. So I would leave it to children with recurrent UTI or very sick one, difficult ones. Simple UTI, just use simple medications. Trust me, it works very well. Cephalexin शुरू करिए, इतना अच्छा concentration होता है, and first time UTI in a smaller baby, it can work very well. There's another question there. क्रैनबेरी बेसिकली देखिए, एवरी पेरेंट्स विल आस्क यू कि सर क्रैनबेरी वो सब पढ़ते हैं गूगल से कि दे सकते हैं. मैं बोलता हूँ दे सकते हैं, बट नॉट ड्यूरिंग द ट्रीटमेंट. इट्स ओनली फॉर प्रिवेंशन, एंड अगेन कितना फ़ायदा होता है वी डोंट नो, बट इट्स लाइक अ प्लेसिबो. इफ दे वांट टू यूज़ इट दे कैन. गायनी पीपल यूज़ अ लॉट ऑफ क्रैनबेरी. अवेलेबिलिटी इज़ अ प्रॉब्लम. कैप्सूल आते हैं नाउ. वन कंपनी इज़ मेकिंग कॉलिंग एज क्लियर UTI. That's a concentrated one. You have to dilute in water and you can give it.
Dr. Vasudev, I just wanted to bring to the notice that when we ask for culture and they give the sensitivity, it's based on the blood culture cutoff and not urinary. Many antibiotics are concentrated in urine so much that even though it looks resistant on the culture, your report, but actually it works. So the dictum is if you have started something, it works, just don't change if the patient is responding, irrespective of what the culture report shows. And second, for prophylaxis, people tend to go by culture. We are not giving it to treat. We are giving to prevent colonization, which are common organisms. So even a cotrimoxazole or a small baby cephalexin is enough. There's no need to go to fancy drugs. And lastly, nitrofurantoin as a treatment is a completely useless medicine.
Right, excellent. So what Dr. Nitin is suggesting that the in vitro and in vivo, there's a difference. Sometimes it may show a resistance on the culture, but actually the child may respond and we have to see the clinical response. And again, for prophylaxis, in younger children, less than 3 months, we would give cephalexin. In older children, cotrimoxazole or NFT. And NFT is an excellent, I haven't seen in 40 years resistance to NFT in any of the reports. It's such a good drug, but don't use it for treatment. Just use it for prophylaxis and a smaller dose. Only problem is that many of these children will have nausea with it, and the parents, mothers will complain कि तो जिस दिन पीता है वो vomit करता रहता है. There we have to change it to another drug, cotrimoxazole. Thank you, Dr. Nitin Shah, for your very nice practical comments. Thank you. Thank you.
Thank you for such enlightening session, Dr. Vasudev sir. Now I request Dr. Vasudev and Dr. Mamta Agarwal ma'am kindly proceed to the felicitation stage.
For the next session, I would like to invite on stage our speaker, Dr. Jyoti Singhal ma'am, and the beautiful chairpersons for this session, Dr. Sheetal Pagar, Dr. Deepashri Tatar, and Dr. Swati Bhutada. About 1 to 3% of all infants and children have a condition called vesico-ureteric reflux, which means some of their urine flows in the wrong direction after entering the bladder. Most children are born with it. Researchers are studying the inherited or genetic factors that may be the cause. To help simplify this interesting topic, hold back your seats as I welcome our next eminent speaker, Dr. Jyoti Singhal ma'am. She will highlight on what we pediatricians must know when we deal with a patient with VUR. Ma'am is a consultant pediatric nephrologist at KEM Pune. She has various awards and achievements in pediatric nephrology to her cadre. Over to you, ma'am.
Good morning, everyone. So at the outset, I would like to thank the organizers for inviting me for this talk on vesico-ureteric reflux. So we all know vesico-ureteric reflux is nothing but the urine which gets refluxed back into the ureter from the bladder. And traditionally, it has been classified into primary and secondary. So primary is when we have anatomical or functional defect of the vesico-ureteric junction. And secondary is because of the chronic elevation of the intravesical pressure because of functional obstruction, which could be in the form of posterior urethral valves or urethral stricture, or if there is functional obstruction because of neurogenic bladder or dysfunctional voiding. For the sake of this talk, I'll be covering mainly on the primary reflux. So what is different between a normal child and a child who has vesico-ureteric reflux? So the predominant defect is in this So the predominant defect is in the length of the submucosal part of the intravesical ureter. As we can see, the intravesical ureter has two parts, the intramural and the submucosal. So normal ureter has a longer length and an oblique path of the ureter. So it basically creates a flap-like mechanism. So when the bladder gets filled and during the voiding, the ureter, the submucosal part gets compressed against the detrusor. So that prevents the reflux and ensures that there is unidirectional flow. While in case of primary VUR, we can see this length is very small. So that basically disrupts the flap-like mechanism of the ureter and causes vesico-ureteric reflux. So that's the primary defect in children who have primary VUR. So why do we need to know about vesico-ureteric reflux? What does it actually lead to clinically in a child? So as Dr. Vasudev has already alluded to, it predisposes to recurrent UTI, which in turns can cause renal scars. So this clinical entity of vesico-ureteric reflux along with recurrent UTI, which ultimately lead to renal scar, is what we call as reflux nephropathy. Some of the children with vesico-ureteric reflux also have associated Some of the vesico-ureteric reflux children also have associated congenital dysplasia. So this is what is the difference between acquired reflux nephropathy, which occurs after the child has suffered from recurrent UTI, thereby leading to renal scarring, or when they have from birth congenital dysplasia. Whatever it is, whether it's because of acquired reflux nephropathy or associated congenital dysplasia, what we are worried about is predisposition to hypertension, proteinuria, and ultimately kidney failure. So this is what the cycle which we need to kind of stop when we are managing a child with VUR. So how do these children usually present? The most common presentation is with antenatal hydronephrosis. So boys most commonly are diagnosed after presenting with prenatal hydronephrosis, and 10 to 20% of these children have VUR. So the guidelines from International Society of Pediatric Nephrology says that any child with antenatal hydronephrosis repeat a postnatal sonography twice. First is in first week of life, and it should be repeated at 1.5 months of age. And if it shows moderate to severe hydronephrosis, irrespective of ureteric dilatation, or if there is any amount of ureteric dilatation, even if it is with mild hydronephrosis, the MCU is warranted to detect the presence of vesico-ureteric reflux. So that's the most common presentation. The other presentation, which Dr. Vasudev has already alluded to, is urinary tract infection, in which 1/3 of children who presents with UTI might have VUR. More so in infancy, if a child has UTI, they are more prone to have VUR. So this is a flowchart which Dr. Vasudev has already covered, so I am not going to dwell on it. The abnormality which we need to kind of focus on in sonography is small kidneys, abnormal echogenicity, increased bladder wall thickness, because it might suggest bladder outlet obstruction in the form of posterior urethral valves in boys or urethral stricture. Third presentation is when for some reason sonography was done and it finds that it has ectopic kidney with dilatation or horseshoe kidney or especially Duplex system on sonography. So there is a typical Mayer-Wegert's rule in Duplex system where the upper pole ureter is usually have a uretrosil which is obstructing and can cause hydroureter, and the lower pole ureter is placed laterally and most likely have VUR. So in this scenario, sometimes we might have to do MCU to detect the presence of VUR. And lastly, sometimes the parents are really worried that what are the chances that their other kids might have VUR. So if they're really insistent, you can just do a baseline sonography in siblings, and only if it is showing dilatation of pelvis or ureter, then you should go ahead with MCU to see whether the siblings also have presence of VUR. So coming to MCU or VCUG, which is voiding cystourethropy. So it is the gold standard choice of detection of VUR. I would like to dwell few minutes on this. So it's the ideal diagnosis. I would recommend always see the films yourself rather than seeing the report which has been reported. Ideally, MCU should have 5 views, which I'll be coming to. Always rule out urinary tract infection because it's an invasive procedure, and if the child is already suffering from UTI, that might again perpetuate that infection. And in neonates especially, I would recommend that please do urine culture, because sometimes neonates don't have leukocyturia in their urine. So if they don't have any growth in culture, then we can go ahead with MCU. It should be done under antibiotic cover and under all aseptic precautions. So the 5 films which we are talking about first is the Scout film. So Scout film gives us the idea. We should look for the spine, how it is looking, because sometimes spinal abnormality might suggest that there might be an underlying neurologic abnormality which might be the reason of presence of reflux. Second thing which we need to focus on is the fecal loading in the colon. So sometimes these children have associated bladder bowel dysfunction, and the presence of constipation alerts you to treatment of this constipation when we are managing this VUR. Next film is filling phase. So here we can see the catheter under which the dye is injected into the bladder according to the bladder capacity of the child. So what we need to see here is the bladder outline. So we may be able to detect that the bladder margin should ideally be smooth. So if it is irregular or if there are multiple diverticulum, that might suggest a high pressure bladder, which could be present in neurogenic bladder or a bladder outlet obstruction. Third is the voiding film. So voiding film is done in, we take oblique views, right oblique view and left oblique view. So oblique view is essential to look at the posterior urethra. So that helps to delineate the dilatation of posterior urethra, and also to look at the vesico-ureteric junction closely, because sometimes presence of uretrosil might be otherwise missed. And of course, we can appreciate the vesico-ureteric reflux here on the left side in the voiding film. The presence of VUR in the filling phase versus voiding phase has a clinical connotation, because if VUR is present during filling phase, it might take long to resolve as compared to a VUR which is present only during voiding phase. Then we have post-void film, where we have to see the amount of post-void residue which is remaining, which might be because of the refluxed urine which is coming back into the bladder. And sometimes we might see retention of dye in the pelvis. So if that is seen, that might suggest presence of additional PUGO obstruction. In terms of UTI, MCU can be done anytime once we have ensured that the urinary tract infection has been treated. So this is the grading of VUR, which is done according to the International Reflux Study. So low grade is grade 1 and grade 2, where there is reflux of ureter in lower part, and in grade 2 it goes up to the pelvic calyceal system. While in high grade we can see as the grade increases, the calyceal anatomy starts getting disrupted, and the ureter dilatation starts increasing and the tortuosity also increases. So this is how the VUR is graded. So why not DRCG? It will less invasive, less radiation dose, many advantages. But what is the limitation is that by using DRCG, which is a radionuclide scan, though it is very sensitive to detect even the smallest amount of VUR, it does not delineate the bladder wall or the urethra, which is very essential to rule out the secondary causes of VUR. So if DRCG is done as a primary investigation for VUR, we might miss the presence of secondary obstruction or neurogenic bladder, which requires a separate treatment. So these are some example of secondary VUR. So here we can see the severe dilatation of posterior urethra as compared to anterior urethra, thereby suggesting that the reflux is a secondary reflux, secondary to posturethral valves. And this was an infant who presented to us with recurrent UTI, a girl child, and we found that she had bilateral grade 5 reflux. Another thing which can be appreciated are multiple diverticuli in the bladder. And on careful clinical examination, she was found to have irregular buttock pad of fat, and on MRI, it was found that she has tethered spinal cord. So the MCU can give us a lot of clue to coming to the basic diagnosis of the child. Coming to BBD, as we have talked about in UTI guidelines also, we always talk about BBD. So what exactly is BBD? So BBD is nothing but bladder bowel dysfunction when you have lower urinary tract symptoms associated with bowel symptoms in the form of constipation or encopresis, and lower urinary tract symptoms could be dysuria, urgency, frequency, hesitancy. So these all symptoms in combination is called bladder bowel dysfunction. So as we can see in the picture, the presence of constipation really affects the bladder. Sometimes it causes overactive bladder, sometimes it causes insufficient emptying of the bladder, thereby perpetuating the vicious cycle of urinary tract infection if we don't treat it. So it leads to recurrent UTI in older toilet trained children, and it doubles the risk of UTI. It also prolongs the time to spontaneous VUR resolution. So the management includes urotherapy, which is nothing but bladder training, giving them simple advice that the child should void regularly. If there is presence of post-void residue, the child should do double voiding. And sometimes these children need pelvic floor exercises so that the sphincter contraction decreases and they can void completely. Of course, we need to keep them on continuous antibiotic prophylaxis till the BBD is resolved. Coming to management, so primary goal is prevention of pyelonephritis. So in case of low grade, we all know that as the child will grow, the low grade reflux will regress. So if there is no UTI, no prophylaxis needed. However, in cases of infants, you can consider keeping them on antibiotic prophylaxis. And if there is UTI, we'll focus on presence of bladder bowel dysfunction. If no bladder bowel dysfunction, no prophylaxis is needed. But in the presence of BBD, antibiotic prophylaxis should be continued till the resolution of BBD. In case of high grade reflux, always keep them on antibiotic prophylaxis irrespective whether they have BBD or not. Despite being on antibiotic prophylaxis, if this children develops recurrent UTI and we ensure that there are no symptoms of bladder bowel dysfunction, they can go for surgical management, which includes ureteric reimplantation, which could be laparoscopic or open depending upon the surgeon's accuracy. Endoscopic injection is indicated only in grade 3. It has not shown to be effective in grade 4 or grade 5. And circumcision in boys in high grade reflux have been shown to decrease the chances of recurrent UTI. So this is just a graph which shows how the resolution in different grades progresses. Spontaneous resolution is usually seen with unilateral low grade reflux and very rare with grade 4, grade 5, even if it is unilateral reflux. Coming to monitoring, clinically we should always monitor their growth, the blood pressure, as we saw that the renal scarring predisposes them to hypertension. Look for symptoms of bladder bowel dysfunction. Keep them under UTI surveillance in the form of whenever they have fever without focus, ask them to do a urine routine. Monitor for proteinuria, monitor the kidney function test. DMSA is suggested if they have recurrent UTI, and monitor for resolution of reflux. This becomes especially important in girls who, even if they have low grade reflux during pregnancy, that might get perpetuated and lead to UTI even if it is a low grade reflux, because they secrete hormones which can kind of relax the ureteric muscle and predisposes them to UTI. Thank you.
Thank you for the super informative session, ma'am. May I request the chairperson, Dr. Deepashri Tatar ma'am and Dr. Jyoti Singhal ma'am to proceed to the felicitation area. For our next session, I would like to invite the speaker, Dr. Izhar Zaveed sir, and the chairpersons, Dr. Krishna Pawar ma'am, Dr. Chaitali Patil, and Dr. Sunita Darade. How many of us have come across this finding, mesenteric lymphadenopathy, when we get a USG scan done? Almost all. In fact, कुछ नहीं तो ये तो पक्का finding होता है. Whether we really need to treat this entity or should we take it with a pinch of salt? Let us hear from our next eminent speaker, Dr. Izhar Zaveed sir. Sir is a well-known, renowned pediatrician in Beed district of Maharashtra. Over to you, sir.
Good morning. I'm thankful for those good words, but I think after those great urinary tract session, it's like a presentation from a poor nursing home pediatrician. So let us go back to the topic. So this is a very common topic, mesenteric lymphadenopathy. So by and large, mesentery is a fold of peritoneum which includes small and small intestine, jejunal and ileal lobes to the posterior abdominal wall. Mesentery presents with two borders. One is attached border, that is root, and free border, which is along the coils of the small intestine. We can see the oblique border is almost 6 inches in length, which extends from duodenojejunal flexure just left to the L2 vertebra to ileocecal junction just above right sacroiliac joint, while free border is 6 meters long, which includes jejunum and ileum. So contents of mesentery, we know that it's containing at the root superior mesenteric artery and vein. Vein being on the right side of artery, this relation is very important for radiological diagnosis of midgut malrotation. Other is jejunal and ileal branches of superior mesenteric artery and vein. Then look at this number. These are lymphatics and lymph nodes. They are almost 100 to 200 in number, just near the ileocecal junction in mesentery. Other things are autonomic nerve plexus, fatty tissues, and jejunal and ileal lobes. As you know, the lymphatic system is a meshwork of capillaries and the tissues, that is lymph node. They drain interstitial compartment of the body. Interstitial compartment is having similar components as plasma, apart from few more proteins than antigen presenting cells. They are taken, this all is called as lymph, they are taken through efferent to the lymph node. Lymph node by and large is having a capsule, a cortex, a medulla, and efferent. Cortex is very important because it is containing B and T lymphocytes. The antigen presenting cells and antigen which is drawn through lymph in the lymph node are interacting with B and T lymphocytes to mount an adaptive immune response, B and T cell mediated, and these sensitized B and T lymphocytes are then transferred to peripheral circulation through thoracic duct. So this structure of lymph node is very important. The capsule, cortex, medulla, which is providing supportive meshwork. Now we'll come to the basic mechanism of any lymph node enlargement. We know it's physiological hyperplasia. On exposure to some antigen, B and T lymphocytes proliferate, leading to lymph node enlargement. This is also called as reactive lymphadenopathy, which is most common cause. Then inflammation when bacteria infiltrates a lymph node, there is polymorphonuclear leukocytic response leading to suppuration and abscess formation. Infiltration, malignant cells itself arise in lymph node or they are taken from a peripheral site. Then medication, direct effect of medication, some of the antibiotics or serum sickness like phenomena associated with use of antibiotics can cause lymph node enlargement. Genetic very rare, Gaucher's and Niemann-Pick diseases where lipid-laden macrophages get stuck in lymph node causing lymph node enlargement. So regional draining pattern of a group of lymph node is very important when you are looking at a localized pathology like mesenteric lymphadenopathy. However, it can be a part of generalized lymphadenopathy where two and more non-contiguous group of lymph nodes get enlarged with or without hepatosplenomegaly, which indicates either a systemic inflammation or a malignancy. So mesenteric lymphadenitis is inflammation of the lymph nodes present in mesentery. It's either primary when you don't have an obvious cause for mesenteric lymph node enlargement. However, it's like a reactive lymphadenitis where there is exposure to antigen and BNT lymphocyte proliferate. There is a preceding history of respiratory or GI illness in last 4 weeks before we document a primary mesenteric lymphadenopathy. Secondary, where you have a cause for mesenteric lymphadenitis, it can be an acute infection or like viruses, adenovirus, rotavirus or influenza EB can cause, or a bacterial infection more so because of food poisoning, because of Yersinia, Salmonella, because of undercooked food or animal product, or an infection like Streptococcus and Staphylococcus. Whereas a chronic mesenteric lymphadenitis is because of chronic infection like tuberculosis, HIV, some autoimmune disorder like SLE, IBDs, or it can be a part of sarcoidosis and malignancy like lymphoma, Hodgkin's and non-Hodgkin's lymphoma. So this is very important clinical presentation. Many of the times there is a variability in presentation, and the most common presentation is asymptomatic when ultrasound done incidentally picks up mesenteric lymph node. It can present with abdominal pain, it's acute abdominal pain in right iliac fossa, or a dull vague pain in periumbilical area. There is a fever which is high grade, vomitings which are non-bilious, change in bowel habit, diarrhea more common compared to constipation. Associated feeding difficulties with these symptoms indicates severity of illness or need for hospitalization. Differential diagnosis, as we know, acute appendicitis, intussusception, Meckel's diverticulitis, ovarian pathology in female child like torsion. All these 4 surgical causes needs a thorough history, complete examination and a good ultrasound examination to rule out. Basal pneumonia many times with abdominal pain, grunting, respiratory distress and very few respiratory findings. UTI may come with urgency, frequency, dysuria, and inflammatory bowel disease, Crohn's disease, which can present with a chronic abdominal pain, bleeding per rectum, there is failure to thrive and anemia. So you need a detailed history and examination to ruling out these causes and ruling out acute mesenteric lymphadenitis. So if you go by one of the North Indian study, the commonest cause for mesenteric lymphadenopathy is primary non-specific mesenteric lymphadenitis, almost 60%, followed by infection associated mesenteric lymphadenopathy or appendicitis associated mesenteric lymphadenopathy. Rest of the causes are pretty less. Now coming back to the most common investigation which is performed for the diagnosis of mesenteric lymphadenopathy, that is ultrasound abdomen. So ultrasound abdomen, we take a probe size of 6 to 8 megahertz. You have to examine abdomen in oblique, transverse and longitudinal axis, and then you have to take a graded compression technique to look for the lymph nodes. The things to be looked for in ultrasound abdomen examination, first is lymph node size. You have to measure a short axis and a long axis diameter of lymph node. And interestingly, there are no consensus in radiology how much size of the lymph node is to be considered significance. Moreover, commonly they consider a size of short axis diameter more than 5 millimeter is significant, and a long axis diameter of more than 10 millimeter is significant. So here is the catch why we get more number of lymph nodes on incidental ultrasound examination. As we can see, a long axis diameter correlates well with the symptomatology of the patient compared to a short axis diameter. The other things to be looked for in ultrasound is cortical ecotexture. A hypoechoic cortex indicates a distracted lymph node. Spherical shape rather than a oval shape is significant. Capsular irregularities, absence of fatty hilum, increased vascularity at the hilum, mating or coalescence of lymph node. Other abdominal lymph nodes like para-aortic, then peripancreatic or periportal lymph nodes needs to be looked for. And the most important thing is to rule out an inflamed appendix. Absence of thickened blind ending tubular structure has to be ruled out because that might be the cause of mesenteric lymphadenitis. So this is just sum up. You can see multiple lymph nodes which are not coalescing. There is increase in vascularity. You have to measure a short and long axis diameter. And the important thing is to look for a normal appendix. Other investigations like CBC, ESR, CRP for inflammatory markers, urine examination, dipstick test to rule out UTI. Most important thing is the tissue diagnostic. In suggestive clinical or radiological examination, when you have a non-localized fever associated with weight loss and loss of appetite, you have to go for tissue diagnosis. Remember, nothing is empiric nowadays. Tissue diagnosis can be made by a laparoscopic biopsy or a CT or USG guided biopsy. You can send that sample for histopathology, gene expert and mycobacterial cultures. As we know, the most common cause for mesenteric lymphadenopathy is primary mesenteric lymphadenitis, and it is self-limiting in nature. So most important thing is to rule out a surgical cause, whether it is associated appendicitis or some other surgical cause that needs to be ruled out. Once that cause is ruled out and we are on primary mesenteric lymphadenopathy, we just need to support that child with hydration, either with intravenous fluid or oral dehydration solution. You have to give pain control with paracetamol or antispasmodic depending on the type and severity of pain. Counseling of the patients and parent. Primary mesenteric lymphadenopathy is a benign problem. It may take some time, like 3 to 6 months, for those lymph nodes to resolve. There is no need for a battery of investigation, and there is no need to confuse yourself with more number of investigation. You can use that window period to monitor growth of the child, and if new symptoms which are coming up, and just discuss concerns of the relatives. So key messages: mesenteric lymphadenopathy is a common problem in school going children. Though it's a common problem, we don't have consensus for diagnosis, follow-up and treatment. Most common cause for mesenteric lymphadenopathy is primary mesenteric lymphadenitis, and we need to rule out other causes of acute abdominal pain by thorough history, clinical examination and good ultrasound examination. Primary goal in managing mesenteric lymphadenopathy is to recognize those requiring immediate surgical intervention and ensure that these nodes are not misdiagnosed as tuberculosis or early manifestation of lymphoproliferative disorder. In suggestive clinical and radiological settings, tissue diagnosis like biopsy or molecular diagnosis like gene expert is important. Now this is our agony, day-to-day problem in our life, a clinician and a radiologist. So rather than monetary gains or our friendship, just show empathy towards the patient. When someone tells you to correlate clinically, don't confuse yourself with ordering more number of investigation and confusing yourself by putting Mantoux to the child. Look at that radiologist whether he had really picked up significant mesenteric lymph nodes or not. Many a times if he cuts down short axis diameter of 4 to 4 millimeters or something, he can pick n number of lymph nodes which are not really significant for us. And last but not the least, go back to the basic art of medicine, take detailed history, do complete physical examination, draw certain conclusions out of that. to localize anatomy, pathology, etiology and malfunction associated with the disease. If it's a child who is stable, having vague, dull aching periumbilical pain, you can very well advise supportive treatment and follow up that child. Whereas whenever a child comes with an acute abdominal pain in right iliac fossa, when you are on a slippery ground, you can advise an ultrasound abdomen. With this, I'll conclude my talk. Thanks for patience listening.
Thank you for the lovely session, sir. I request Dr. Sunita Darade ma'am and Dr. Izhar Zavid sir to proceed to the felicitation area for felicitation.
Now I request Dr. Chinmay Joshi sir to kindly come on stage. I also request chairpersons Dr. Sangeeta Lodha ma'am, Dr. Reena Rathi ma'am and Dr. Rohan Shah sir. Let's move towards some medical emergencies in pediatric, which if you can catch in early stage will give better prognosis and reduce the overall stress. Topic for discussion is early recognition of shock. Over to you, sir.
Thank you. So first of all, I would like to thank the organizing team for inviting me for this talk. And secondly, I would really like to congratulate them for being so perfect with the timing. It's really a commendable job. We're almost right on the time. So we've had some fantastic talks this morning from all the stalwarts in the field, and I feel a bit of pressure on my shoulders after following these talks by a few giants here. So my talk today is about shock, early recognition and management. This is going to be a mainly practical aspect, as in a clinical OPD, you're sitting there, you get a patient, how do you approach that? What do you do next? Instead of definitions and criterias and whatnot. So this must be a very common scenario for all of you, a busy OPD, lots of chaos, lots of people shouting outside and children crying, mothers screaming and attenders screaming. And suddenly a nurse comes in and says, doctor, there is a mother there who says my child is very, very sick. And as you're speaking to the nurse, the mother brings in this child. You look at this child, this is a 3-year-old boy, 12 kilos, previously fit and well, has been unwell for last 3-4 days, just generalized complaints. You follow an ABCD pattern, you see that airway is patent, breathing-wise the child is slightly tachypneic, a bit of work of breathing. Child is tachycardic, is a bit drowsy, intermittently responsive, and is febrile. And you get a swift X-ray, very efficient, it's there in front of you in 10 seconds, and that's the X-ray that you see. How sick do you think this child is? Do you think this child is not too sick? Go outside, wait for your turn, I'll call you when your turn comes. Or maybe a bit sick, you're here, let me give you some oral antibiotics, come after 1 week. Oh, no, this child is very sick, I need to do something right now. How many of you think that this is option 3? So yeah, rightly so. So this child is quite sick, and why is that? We'll see in the next slides. So what is shock? Again, as I said, we'll not go in definitions, but shock is essentially a discrepancy between the supply and demand. Your body is demanding a bit of oxygen and nutrients, and your tissues are demanding oxygen and nutrient, and your body is not able to take care of all that. So there's a gap between the demand and supply. Somebody might say that, the blood pressure looks normalish for this child. Are they really in shock? Well, shock doesn't always mean hypotension. And why is that? We'll see in the further slides. So I'm going to use a bit of analogy. So let's imagine that this is a factory that we have. I don't think this has a pointer. No. Anyway, so that green thing there is a coal mine, and which is producing a lot of coal every day, and then it is taken to the factories in 10 trucks every day. So the trucks go there, get filled with coal, go to the factory. There are multiple factories, smaller, big one, large one, and the body has its own system of giving them importance, as in which factory is more important for me and which is less important for me. The factory uses about 3 to 4 trucks, sends the whole thing back, it gets filled again and goes back again. And this keeps going in circles. Why do we need to know this? Because heart is that mine, so you get oxygenated blood pumped out. The RBCs are your trucks, so they are taking your oxygen about 100%, as we saw in the first picture, to various factories, which can be brain, heart, kidney, intestine, skin, and so on and so forth. Those tissues, those factories will use few of that supply, oxygen, and send the remaining back. Now let's put this in the medical language. So I personally feel that anything that we do in an ICU or in an intensive care environment, everything boils down to this equation. That's why I personally like to call it an everything equation. That's not an official term, as a disclaimer. So basically, oxygen delivery depends on cardiac output and arterial oxygen content. We all know this equation, cardiac output, as all pediatricians, everybody knows that it is amount of blood pumped out of the heart per minute. So that's heart rate into each stroke volume. And then stroke volume will depend on your preload. So how well filled the heart is, how is the supply, how is the pumping, that's contractility, and how is the resistance. So is there vasodilation, vasoconstriction? These three things will define your stroke volume. Coming to the second part of equation, arterial oxygen content. Obviously, if the child has low respiratory infection, low SATs, low hemoglobin, those things will hamper your oxygen content. We'll come back to this equation. But what I would say is that human body is an ultimate machine. It has a lot of compensatory mechanisms built in it, lot of fail-safes built in it. So by the time we start seeing symptoms, a lot of these mechanisms have been used and have been exhausted. So that's why, how do we recognize something early is by knowing what these compensatory mechanisms are. So as we saw in that previous equation, the first thing body did in response to shock or reduced supply is put the heart rate up. You see that as a tachycardia in this patient. Second thing body did was, maybe this factor is not important, that factor is important. So for body, skin is not important for survival, but heart is, brain is. So it took the blood from the skin, sent it to the heart and brain. That's why you got cold and pale skin. Then that's why you got delayed capillary feel. Pulses and the vessels are contracted in the skin. So that's why you get peripheral weak pulses. Now the situation is still getting worse. Body thinks, right, kidneys, if they go, I can still survive. I still want my heart to function. Take the blood from kidney, oliguria. Intestine, I still survive without intestine, or that's what body thinks. Send it to heart and brain. You get feed intolerance, vomiting, ileus. And then finally heart, no, definitely heart needs to keep pumping. Coronaries need to get perfused. Take it from brain, altered sensorium. So all these signs, all these mechanisms are in action by the time that this particular child has come in. So after all these things get exhausted, then we see hypotension. So by the time we see hypotension in a child, it's already too late. But then we think that the child is normotensive. So that is what, these are a few things. And why do we need to know this? Because this is, in older literature, this used to be called as a compensated shock. So compensated shock takes hours to go to hypotension, but it only takes minutes to go to reversible injury, and only takes seconds from there to go to death. So if we catch this early, we can treat this early. Just a quick update about types of shock. I'm sure everybody here knows about types of shock. The top there, the tap, I wish this pointer was working, but I'm sorry, this is not. So the tap there is the heart. The tap is leaking, is not working well, not giving enough pressure. So you're not giving, so basically, I'll start from the beginning. So there's a tap, there's water, there's a hose, and you're gardening, you're giving water to your garden. Now the tap stops working. It doesn't give enough pressure. Cardiogenic shock, cardiomyopathy, myocarditis, cardiac failure. So that's a tap failure. Second, you have a leak somewhere. You have a leak in the pipe. Thank you. You have a leak in the pipe, you have a leak from the tap, or there's not enough water in the tanker, hemorrhagic shock, hypovolemic shock, diarrhea. Now fine, the tap is okay, supply is okay, you have connected it with the hose, but the tap is small and you have used a very big hose. So the water, instead of going too far, is just falling there. Vasodilatory shock or distributive shock. And everything is fine, the tap is okay, flow is okay, hose is adequate size, you're gardening your garden nicely, and your kid or your wife or somebody comes and stands on the hose and the water flow drops, obstructive shock. So that would be cardiac tamponade, tension pneumothorax. So these are the types of shock. I'm sure everybody is aware of that. So coming back to the case, we know that this child is now tachycardic, drowsy, so is unwell. So we need to take further steps, which would be oxygen, cannula, antibiotics. You start having multiple attempts at access, child is already shut down, you're struggling to get an access. What next? Intraosseous. I can't tell you how many times this particular equipment has saved my patients and effectively my life and my hospital and my infrastructure by getting an adequate access in the right time. This is a separate talk in itself, but I highly recommend that you use this. It's a one-time small investment, which will yield really good results. So you get an access, you give fluid, and now the child has become even more tachycardic, and now the liver is palpable 2 centimeters. What do you think is happening? Sorry for this slide, it wasn't supposed to be like this. Does anybody know who this gentleman is? This is Professor Emmanuel Rivers. He is an adult intensivist who brought in an era of fluid resuscitation by publishing a study in 2004 called Early Goal Directed Therapy. What their study shows that lot of fluid initially come out of shock. But eventually further studies like PROMISE, PROCESSORIZE showed that fluid is not always the right answer. If you look at this curve, Frank-Starling curve, this is your fluid status or preload, this is your stroke volume. You give this much of fluid, when you're depleted, you get that much of rise in stroke volume. But if your patient is in this part and you give the same amount of fluid, you get only this much of rise in stroke volume. What has happened to the extra fluid? It has gone to the tissues, it has gone to the lungs, it has gone to the interstitium. And then we wonder why this child has gotten so puffy and so edematous. So these are the studies if anybody's interested. Coming back to the case, the child is still unwell, still tachycardic, the ICU team has arrived, and now you decide to intubate this patient. There's a concept of physiological difficult airway. We need to understand that this child has been unwell for quite a few days and has very high endogenous catecholamines. So the moment you give sedative drugs, you're going to blunt that response, drop the preload, and child has a potential to arrest. What medications would you use? As an intensivist, I will say strong no to propofol, not very hemodynamically stable. You could use ketamine, fentanyl, rock. Those are the doses. And then do it, I would again recommend do it with a backup of adrenaline. So you keep some adrenaline flow running in the background or keep some bolus adrenaline ready to go. Just the only point of mention, you start peripheral adrenaline through here. What you need to remember is this yellow cannula has a dead space of 0.1 ml. The connector has a dead space of 0.3 ml. So even if you start that adrenaline at 1 ml per hour, it's going to take 24 minutes to reach the bloodstream. So you might have to give a small push so that it hits the bloodstream. Right, so successfully intubated this child, now still worsening, and you decide to use some inotropes. What would you use? Again, there are many, but we'll just talk about these four main things: adrenaline, noradrenaline, alpha and beta agonist. Adrenaline, particularly small doses, beta agonism, so increases the force of contraction. High doses, vasopressor, primarily alpha action. So that is a bit tricky there. And noradrenaline, purely alpha, so you get very nice vasoconstriction. Vasopressin also purely vasoconstrictor. Milrinone is a bit tricky because it does something called as lucitropy. So this heart has been beating at the rate of 190-200. You need to relax it. Because it's beating so fast, it's not getting enough time to get filled. So you give it some time, you make it relax in diastole, get it filled properly, and then you get better ejection. What I will say in a peripheral practice, if you don't have an art line, you don't have an intensivist, adrenaline is almost always the right choice. So familiarize yourself with the doses, and you can always use that for transport. Just a quick summary, coming back to the equation we saw earlier. So what did we do to optimize this? Cardiac output, heart rate, body took care of that. Stroke volume, preload, we gave fluid. Contractility, we gave inotropes. Afterload, we gave vasodilators or vasopressors. Coming back to the second part of equation, arterial oxygen content, hemoglobin, you gave some blood. SATs, started oxygen. There's this tissue environment. So how do you normalize that? So you normalize pH, CO2, temperature, other stuff. So homeostasis essentially. This case turned out to be empyema, needed 2 weeks of recovery, needed chest drain, VATS, and then improved with a wonderful outcome, excellent treatment by all the team. So just a quick update about surviving sepsis guidelines. This is essentially what we talked. This is the first part of surviving sepsis guidelines. It says the same thing that we have done. The only thing that I would like to mention here is early antibiotics. Kumar et al. Study showed long ago that every hour delay in administering antibiotics after establishment of shock increases mortality 7-folds. So if you think that this child is in shock, yes, absolutely don't use antibiotics injudiciously, 100% judicious use of antibiotics. But if there's a suspicion of shock, do not delay giving antibiotics. Okay? For that, importance of IO. That's when to use fluids, when to use inotropes, as we saw earlier, early use of inotropes and presses. And what I would say is patient don't suddenly deteriorate. It's just we are who we suddenly notice. That signs are always there. It's our job to see all those subtle signs. With this, I'll conclude my talk and leave you with this few food for thought. Intensive care is not about doing too many things. It's always less is more. Let the body heal itself. Your job is just to support it, not to take over. And that concludes my talk. Thank you very much. I'm happy to take questions.
Excuse me, sir. So I have one query. In neurogenic shock, where there is loss of sympathetic innervation, and we don't get rise in SVR or tachycardia for that matter, being early clue for to detect the shock. Apart from going to the stage of hypotension, what are the clues in neurogenic shock so as to pick them up early?
So first thing in neurogenic shock, I would say the most important clue will be the etiology, the presentation, what the child is presented with. Because the commonest thing that we see in our practice is something like septic shock. So you know that there's been history of being unwell. Neurogenic shock, you get the certain history that this child has had some sort of neurogenic injury or insult which has led to a trauma, then that has led to this. So that is the most important clue. And then secondly, if this child, what I would say that neurogenic shock would almost always present to you with symptoms instead of all these previous things. This is mainly pertaining to septic shock, vasodilatory or hemorrhagic shock instead of neurogenic shock. But yes, I think you'll see the symptoms and treat them and see the response.
So can you use a bone marrow needle instead of the intraosseous needle if you don't have it?
Yes, sir, you can. So basically, two things. You can use a bone marrow needle as long as you have the right connector. Anything that you can give through the cannula, you can give it through the bone marrow. You can also do a blood gas. Previously, that wasn't the case. With new gas machines, you can do it. The only thing with bone marrow is duration. If you're putting the marrow needle and transferring the child to another ICU, that might be a bit challenging.
Yes.
The new bone marrow needles, not IO needles, come with a certain fixator.
Yes.
So that takes care of mobility and transport.
And would you remove the intraosseous as early as possible when you
As soon as possible.
Yes.
The moment you get a definitive access, the line needs to come out. It is a high risk for compartment syndrome.
The last question is that when you have a cardiogenic shock, either primary cardiac illness or secondary to myocardial dysfunction, do you go slow on the fluids and reassess like 5 cc per kg, 10 cc instead of giving higher doses?
Absolutely, sir. So any case that or shock that presents to you, unless it is a very clear trauma or hemorrhagic shock, and if you have not done an echo, I would always recommend giving 5 to 10 mils per kilo. In our center, we always do 10 mils per kilo, see the response. If the child gets worse, get an early echo and go further according to that. Thank you. Thank you very much.
Thank you for the interesting talk, sir. I request Dr. Chinmay Joshi, sir, Sangeeta Loda, ma'am, and Reena Rathi, ma'am, to proceed to the felicitation stage.
There is a slight change in the schedule. We are now going ahead with the panel discussion. Next session is a panel discussion on overcoming common hematological hurdles. We often deal with hematological disorders in everyday practice, right from the ABCs of CBC to the BMTs and much more. Hematology is diverse and so are the hurdles associated with it. This session will be moderated by a very well-known and senior pediatric hematologist and an excellent academician, Dr. Nitin Shah, sir, with almost 40 years of experience. The panelists for this session are Dr. Pinky Shah, Dr. Nitin Surana, Dr. Lisa Bulsare, and Dr. Tushar Idhate. I invite all the panelists and our eminent moderator to come on the stage and enlighten us for this interesting session.
Good morning, and very happy to be here in Nashik amongst friends. Good, I came by train because the roads are terrible, and now even trains are terrible because there's a landslide and no one is able to cross the Bombay. I don't know how I'm going to go back, but one of you will have to host me at your house if I don't get a way to go back. Second thing was I was having very bad viral fever, so please pardon me if I have a sore throat and a hoarse voice. Can I have my presentation? So it says that what is the use of a teacher if the students don't surpass him? And I am sure all three have been my students. So Pinky was a direct student at Badia Hospital. She did fellowship in pediatric hemong with us. Tushar I know since Sion Hospital days. And Nitin, I don't remember, but 23 years back he said he was visiting my clinic to understand the nuances of practice. So in that way, I'm happy that I'm moderating a session with all the three now extremely knowledgeable colleagues. And what task I have been given is overwhelming the common hematological hurdles. So I thought I'll run 5 cases and get some basic questions answered because, you know, it's just common problem here, not complicated. The complicated ones I will do when I deliver the oration after some time. This doesn't move. Oh, right. So let's start with case number 1, and you can see this is a measly looking child. She's quite malnourished and short. So Nitin,
What happened? Okay. So an 8-year-old female from Jodhpur presents with fatigue off and on since 1 month, pallor which has been going on for a few years. Many of our parents don't even bother to do a CBC, and you see many times children coming anemic. There is no history of pica or bleeding or worms. The diet is average, and there has been no transfusion in the past either in the child or in the family. So essentially just pallor and fatigue, which is probably very chronic. This is the weight, 22 kilo, height 112 centimeter. She was pale. There was no icterus, there was no organomegaly, like no lymphadenopathy, no liver spleen. Mild platinikia was there, and other system examinations were normal. She was treated with oral iron, hematinics, deworming, and B complex umpty number of time, but of no use. Her hemoglobin wouldn't improve. And this is the CBC with which she comes to you, Nitin. What is your interpretation on this CBC, and what do you think? Where are we heading to?
So symptoms of fatigue since last 1 month. There is a platinikia, there is a pallor, so this is definitely a case of anemia.
Correct.
With
Yeah.
less hemoglobin, less MCV, suggestive of maybe iron deficiency anemia.
So how do you know
But-
it's iron deficient, not megaloblastic, not leukemia? I mean, how do you go with the interpretation of CBC series by series? So let's talk on the RBC series. What's wrong in RBC series?
So MCV is on lower side,
Very good.
RDW is increased.
When you're
So
low MCV, it could be also thalassemia minor or chronic
yes.
infection. How do you know? Is there anything else which can help you, which is there on this CBC?
RDW is
Yeah.
more important.
So what is RDW, if you can explain?
RDW is increased, MCV is on lower side. So that is most probably suggestive of iron deficiency anemia.
Correct. So high RDW means anisocytosis. What I see on the smear cells of different size is what the counter picks up as high RDW. So low MCV, high RDW, iron deficiency. Other series, WBC platelets.
WBC is normal, platelet is also normal, sir.
Okay, so platelets, if at all, little
Slightly
on the higher
on,
side.
slightly on higher side.
Yeah. So, but why is she not responding to oral iron?
So we need to rule out the other causes, maybe some absorption disorders, some internal bleeding over there, maybe internal organ bleeding might be there.
Okay, but
Some-
that's going on for so many years. So malabsorption is one likelihood or other cause. So what he's trying to say is that think of non-dietary deficiency causes of iron deficiency. First, you will always confirm on a smear, and you can see very nicely severely hypochromic microcytic cell, and you see these ovulocytes, long elongated cells. Sometimes you see pencil-like cell, and that's very typical of iron deficiency. And this is what he was talking about. You have high RDW, low MCV with iron deficiency. You have low MCV with normal RDW, thalassemia minor. On the other side, if you have high MCV and a high RDW, megaloblastic anemia. You have high MCV and no RDW, then aplastic anemia. So all high RDWs are nutritional deficiency, low MCV iron deficiency, high MCV megaloblastic. All normal RDW are usually non-nutritional. You have low MCV is thalassemia trait, it is high MCV, then some liver disorder. Okay, let's move on. So you already answered this. So when do you think of secondary cause of iron deficiency, and what further investigation will you do? Anyone? Tushar? Pinky?
Sir, we should do iron studies along with the ferritin levels.
No, first, when do you think of secondary causes? Like, what are the clinical scenarios? Like, this is one.
Sir, when a patient is not responding to iron treatment, we should rule out the poor compliance, we should
Okay,
rule out the
very
blood
good.
loss,
Absolutely.
we should rule out the wrong dose, we should
Correct.
rule out the wrong duration.
Perfect.
So all
Also,
this,
the age. This is not the age
Yeah.
for typical deficiency.
Yes, the
It's
age is
usually
also-
the growing age.
yes.
All right.
Then
And
sir has already mentioned malabsorption syndrome, poor absorption. We should also rule out when patient is taking iron along with the inhibitors,
Correct.
like tannins, or they are taking with the meal, they are taking with the antacids. So we should rule out that also.
correct. So we should always say that Indians are more smarter than Britishers. We always take an orange after our dinner, so it helps to absorb iron. These stupid people, as you know what happened in the election, they take tea after dinner, and the tannin actually prevents absorption of oral iron. Very good. So you said you will do iron studies. All right. What else? So this is iron, 3 nanogram per ml. That helps you?
Poor ferritin levels. So stores are really very low. That means it may be a chronic iron deficiency anemia. And the
So
second
this
thing,
is iron deficiency not responding at a very atypical age. Now what further investigation? You said malabsorption, blood loss. So what are the tests you will do for?
so we should rule out celiac disease like
Perfect.
gluten sensitivity. So we
Okay.
should do tissue transglutaminase IgA levels.
Suppose that come normal, any other cause like blood losses,
Yes,
chronic blood loss, like where?
blood loss. Then even a hookworm can lead to
So
such
GI blood loss. So you do stool focal blood, how many days you do?
3 days minimum.
Minimum 3 days. Don't give up on single day. And so if someone comes with this and little cough and cold off and on, do an X-ray to see for
Pulmonary hemorrhage.
hemosiderosis. Excellent. So this is the investigation. Now you see the anti-TTG is very high, both IgG, IgA. When you do this, always do serum IgA, because if this is low, then this may not be picked up because IgA is more specific. So diagnosis is celiac disease. There's no question. Any other autoimmune workup, because this is an autoimmune. Tushar?
Maybe connective tissue disorder because of a female child. Other autoimmune like SLE, maybe I will like to rule out.
That blood sugar, because sometimes diabetes can go hand in hand with celiac. So other autoimmune disease you should keep in mind. And how do you prove? Is there need to do a duodenal biopsy, or can you just treat them based on such very high anti-TTG level? It's always a fight between hematologists and the hepatologists. They always like, I don't know, Iram Bon is here, she'll always say never treat without doing a duodenal biopsy. So if you do a duodenal biopsy, it will show you flat villi, and then you put them on gluten-free diet, and the child will improve, and you can repeat a biopsy and show that the villi are back. All right. How do you treat these patients, Tushar?
So of course diet you have already mentioned.
Yes.
And then the iron supplements we will have to give them.
But it won't get absorbed
So
in the villi.
parental iron will be the another option which we will consider in this
So
patient.
initially you can give IV iron till the time the malabsorption is taken care of. Usually it takes 1 or 2 months for the child to improve, and then you can switch over to oral iron. All right. So let's discuss in general. Now this case is over management of iron deficient anemia. Indication of IV iron.
So basically, practically very small indications. One of them we have already discussed, malabsorption. Second, if you are opting from surgery, hemoglobin is borderline, you want faster rise, that will be the another one.
Right.
And
We used to use a lot of erythropoietin preterms. So that time we would give IV iron, and pregnancy.
Pregnancy.
Where you want a faster rise without transfusion. These
Sir,
are the indications. Yes,
I have to say that whatever is the hemoglobin level, if patient is hemodynamically stable, we should not use IV iron.
And you should not transfuse them, because there is no cutoff for transfusion in an iron deficiency. A child with 2 gram can come walking to your clinic, is otherwise asymptomatic, no need to transfuse. All right, which IV iron, Pinky, you are familiar to
basically
use?
new.
Yeah, Pinky. I think the mic is not working there. Someone can help her? Excuse me,
Hello.
the mic is not working.
Working. So there are multiple formulations available, iron dextran and iron sucrose, but I'm more comfortable with the iron sucrose because it's a quite safer drug.
Can you use IV carboxymaltose, because it's a single dose at one go and you can finish
Yes,
it off?
we can do that.
Okay. So
Basically,
IV
this
sucrose,
newer preparation, maybe
Yes,
just I will
please.
touch upon. This FCM is now newly available, ferric carboxymaltose, which is considered quite safe. It can be given as a single dose.
Correct.
And reportedly, there are very few side effects noted.
Correct.
So maybe we can use it more
so
safely now.
4 into weight in kg into the deficit of hemoglobin. So you want to rise from 5 to 10, 5, weight is 10, so 10 into 5 is 50, into 4 is 200, add 50% for store, so that makes 300 milligram. 300 milligram elemental iron in 200 cc normal saline on an OPD basis under supervision, and that's the end of it. Very rarely we use it in children, remember, for absolute true non-compliance. Parents just don't take it and the child suffer. All right. For oral iron, which is the gold standard for pediatric patients, which salt do you prefer?
So basically, this is always the debate, but we all have agreed that ferrous salts, whatever are there, ferrous sulfate, fumarate, all those should be preferred.
Okay.
Ferric is like eating like this, so that should be
What
avoided.
about ferrous ascorbate, which is like very commonly used?
Yes.
Little expensive, but good
Yes.
compliance. All right. Dose?
So dose,
Therapeutic.
older doses we all know 6 milligrams per kg per day, but
Correct.
in last 2 years only IIP has given the guidelines, and
Please
maybe
read the
3 is
IIP
also
guidelines. Yes.
3 is also
3
sufficient
mg
enough.
per kg is enough. There is no need to give higher doses. Schedule, when do you give it?
Usually, sir, we should give a night dose, which have a very better absorption, plus GI mobility is less, so absorption is much better. Now, a new guideline says thrice a week is also, like alternate
Perfect.
day is also good.
Yeah. So the intestinal epithelium absorbs iron, and the turnover of intestinal epithelium is 3 to 4 days. So once you have taken an oral dose and the epithelium is saturated, next 2-3 days you're not going to absorb. So if you give after 3 days again another dose, that's also equally good as a therapeutic reason. Compliance always, as you said, you check the pill compliance, the tablet compliance, and so on and so forth. Other measures, very
Before
important.
we go ahead, just about
Yes,
the compliance, maybe if we can add, like this is the routine problem what we face is GI intolerance is there. So what I do in my private practice is I start with a lower dose.
Correct.
To start with, and I give it after food.
Correct.
So for 8 to 15 days, get the child accustomed to the iron. Then you can shift to empty stomach is always a better absorption, but maybe that 15 days will give the window of opportunity for the family to get used to the iron.
So ideally single dose at night. If cannot tolerate, divide into 2 doses. If cannot tolerate, give with food. If not tolerate, reduce the dose. If not tolerate, make it alternate day, twice a week. But give iron, because that is going to help the baby grow better physically and more important, mentally. And children who don't, mothers who don't stop bottle or have prolonged breastfeeding, etc., I scare them by saying that because of you, your child could have become doctor, but will now become a male nurse or a female nurse, and that really hits them here. And then they stop the bottle. Or they have diarrhea, they are admitted, you say it's because of iron deficiency, child is admitted, overnight the bottle stop. अभी बच्चा नहीं मांगता है. So चमत्कार के बिना नमस्कार नहीं है. So remember, hemoglobin is not only heme, which is iron, it's also globin, that is protein. So give good diet, give protein, stop prolonged breastfeeding, stop the bottle, deworm, and remember iron is also B12 folate. So all these measures are equally important. One word about the iron prophylaxis, the NIPI
This national guidelines.
National iron.
So basically thrice a week they have said, and it is
this
right
is
from
table.
the all age
Should
groups.
Keep this under your OPD table. Yeah. So first 6 months to 5 years, give 20 milligram of elemental iron, and you give it bi-weekly. 5 to 10 years, make it 45 milligram once a week. 10 to 19 years, 100 milligram once a week, and this is for the older ladies. So try to give as much iron as possible.
So in one line, it is basically irrespective of the all age groups, prophylactic iron is to be given.
Yeah, correct. So it is always IFA, iron and folic acid. But we are seeing a lot of B12 deficiency now because of, what is the source of B12 for vegetarian like me?
Milk.
It is only contaminated water and food, because the bacteria which are contaminating are giving me B12. Now I am very happy only drinking mineral water, and then I don't even get that B12. I need to take B12 supplement, and that is the reason why we always give B12 in every anemic child. Alright, let's move to the second case. Any question on iron deficiency? You can always intervene. Yeah, please. Liposomal iron. I'm absolutely not in favor of such preparations, but
Sprinkles, powders, liposomal iron.
I mean, we don't take names, but there are some which say that they need only 1/3 a dose and they are
Yes.
equivalent. They haven't proven it in the actual studies. In fact, one study is just now started in Wadia Hospital. I said, you prove it and we will use it. So we have time tested ferrous fumarate, ferrous sulfate, and ferrous sorbate. Just know one product and the strength, and that's enough for you to practice, because
They
this
claim,
is your
sir,
bread and butter.
they claim that the GI tolerance is better with that and absorption is better. How much true it is?
That is not proven, that's the question.
No.
And I have never had
Ferrous.
problem with ascorbate, fumarate, sulfate if you are
Yeah.
giving the 3 mg per kg instead of what we do 6 mg per kg.
Most important thing is, do we have problem with the conventional? The answer is no.
Exactly.
So why do we need to shift?
Perfect. All right, case 2, Tushar, maybe you can lead this. 14-year-old male from Satara presents with pallor for last 5 months, yellow eyes since 1 month, there is no fever, pica, bleeding, diet is normal, no transfusion. So only again like previous child, pallor, but this is an older child and has also yellow eyes. Weight is good, 62, height is very good, he is very pale, mildly icteric, stomatitis, no organomegaly, and other system examination is normal. Again treated with B complex, deworming, hematinics, not helping him. This is a CBC. Can you interpret it for the crowd?
So just last week I have treated this patient.
Good.
These patients are
I hope
routinely.
it's not the same patient who came to Bombay.
No, of course now they don't come to you. So
No, I'm just joking. Of course.
so these patients are treated with viral hepatitis.
After all of you have taken the practice in the interiors of Maharashtra, we are all out of business in Mumbai. Joking, no problem.
So basically these patients are always treated with viral hepatitis. This patient was also
Correct.
treated with.
So what is one point that tells you that this is not a hepatitis but something to do with hematological case?
The CBC will come later on,
No,
but
forget.
only the yellow eyes are there.
So
But,
what is the next question that you ask?
what is the color of urine?
Absolutely. Choluric or acholiuric? liver disorder, choleric, dark
Yes.
urine. Acholeric, hematological cases, indirect bilirubin, not a liver
Not-
disorder. These
yes.
children are given liver tonics sort of, but they don't help. Okay,
Yes.
interpret CBC.
So basically, 2-3 things which will help here. One is yellowish eyes, which will actually help you because the bilirubin is increased because of the ineffective erythropoiesis.
Perfect.
Okay, so that is the one thing. Second, stomatitis you should pick up. Third point, maybe MCV. We know it is very high, 115.
And-
Even the low platelets will help you
And
point
RDW.
towards.
Let's take RBC
Yes.
series first.
So first, HB is
Severe
on lower side.
anemia, which is
Macrocytic,
and a higher
higher W, nutritional.
So we showed you the table of RDW and MCV, high
Yes.
MCV, higher W, nutritional, megaloblastic. Okay, how do you confirm? So why are the counts low and why is the platelet low?
So basically, pancytopenia is one of the routine manifestations of megaloblastic anemia.
Correct.
Yes.
Because B12 and folate not only control erythropoiesis, they control myelopoiesis and megakeropoiesis. Okay, retic is 3%. Does it help you?
Yes, sir.
Retic is 3%.
Yes,
Does it
little bit of means the marrow. It will rule out aplastic anemia if
Correct.
at all that is in your mind. Of course, the icterus will also rule out it.
So you may feel retic is high, but it's actually not high. If you correct it for the
Yes.
for the hematocrit, I have not given you, but hematocrit will be somewhere around 15, which is 1/3 the normal. So retic actually is 1%, but that tells you the marrow is normal. 1% is a normal MCV, normal retic count. Okay. So
Just I will like to add.
Yes, please.
Like we had done one study at MGM with the pancytopenia patients. 130 patients we had studied. So most common cause in our region is the megaloblastic anemia actually,
Correct.
and followed by aplastic and this thing. So when pancytopenia patient comes, we usually think of hematological causes, which is actually the reverse case. So megaloblastic is the most common cause of
So when you
pancytopenia.
think the child is leukemia, is actually not leukemia, and the time when you think is not leukemia, it turns out to be leukemia. So it is always like that. So we already said what is corrected count. Can it be leukemia? Any further history on examination, Dr. Nitin? You like to see? He said megaloblastic. is
Organomegaly will be important,
So
sir.
there was no
Bone-
organomegaly,
Bony
okay.
pain will be important.
Okay, very good. And anything else on examination? Like suspected megaloblastic, anything else you will look at?
Knuckles will be
Very
important.
nice. All right. So this is the type of presentation you will have, hyperpigmented knuckles. So you can see the interphalangeal joints are very dark and in between the skin is normal. All right. So this is even more starking. Of course, they are different patient and they have this bold tongue. There are no papilla seen. All right. Anything to look on smear, Pinky?
We should look for the hypersegmented neutrophils.
That's
That
why
is,
I
we
call
have
my
to
friend.
see the 100 segmented neutrophils you have to see, and if a number of lobes is more than 5 in a 5 neutrophils, or number of lobes more than 6 in a single neutrophil,
Correct.
that is a hypersegmented neutrophils. Then macroovelocytes we can see over
So
there.
you can see
Basophilic
the
stippling.
macrocytes, ovelocyte, basophilic stippling, you can
Yes,
see.
sir.
This is
And-
our friend, hypersegmented
Yeah.
neutrophil. This is present pathognomonic. There is no need to do any further tests. All right, and these are those oval jolly bodies.
Oval jolly bodies.
Okay.
Yes.
So, bilirubin health, the total bilirubin is 2.5, indirect 2.2. That's why it's acholuric. This is not liver disorder. This is hematological disorder. All right. Any other biochemical tests, Pinky?
We
for
should do
malignancy is another.
LDH. LDH we should do.
So can you tell me 4 or 5 causes of very high LDH like this? One is megaloblastic, of
One
course.
is megaloblastic, then is leukemia in case.
Second,
Hodgkin's lymphoma
So
we
any
can
malignancy,
have. Any
okay.
malignancy we can have. Then intracellular infections like pneumocystis carini, we can have a high
Okay, very
LDH.
good. All right.
And
In hemolysis also.
Any hemolysis can lead
Hemolysis.
to, and common where you do LDH and as a monitoring is, one is megaloblastic, other is HUS,
HUS.
hemolytic uremic syndrome. All right. So we already said this. Diagnosis is megaloblastic anemia. All right. Is bone marrow a must?
Absolutely
Tushar?
not. Not.
no, sir.
No.
In this patient, I will not do.
You will not do. So remember, there's no need to do bone marrow. If you have a very classical picture like this, you can treat them as a therapeutic trial, and if they don't respond, then you go back. But do not give transfusion, do not give steroid, because if you miss leukemia for some reason, then you will have temporary remission and the patient will be in a very bad soup if when he comes
So the
back as a relapse.
point here is that you treat them means you have to. Are we
Right,
discussing
so,
the
yeah, yeah.
doses?
So this is the bone marrow. If you're done, this is what you call megaloblast, which is a bluish cytoplasm, and an open nucleus, sieve-like charni that we use to screen our
Yes.
food or particles. So this is how a megaloblastic will look like. All right. Is it necessary to do B12 folate level?
Yes, sir, we should do.
How much
But
is the
even
cost?
if,
What's the cost of B12 and folate?
sir, 900 rupees, I guess.
Is that only that much here? Oh wow.
B12
With
it is
discount.
1200, 900.
Yeah.
Yeah.
Maybe
Folate
1000.
is higher. But even if the levels are normal, we can't rule out the functional deficiency.
Absolutely. So 10% of normal population is low B12 but no megaloblastic anemia, and around 20 to 30% of patients of megaloblastic anemia have a near normal B12. So actually it doesn't help unless grossly low. But yes, if patient can afford, और कुछ test करने का है doctor, और कुछ हाँ करो है.
And sir, impact is much more if levels are low, they are more.
Absolutely.
Yeah.
So low level conclude, but normal level do not rule out. All right, perfect. Tushar, when do you suspect it is pernicious anemia
If
and
they
not
don't,
a deficiency?
if they don't respond to the
That's
B12.
one, okay. And they have other associated autoimmune disorders,
Right.
like,
Sir,
again, they can have diabetes, they can have gray
yeah,
hair.
there's a TRMA, thiamine responsive megaloblastic anemia, consists of triad of sensory neural deafness,
Perfect.
hemolytic and megaloblastic anemia, and
So
diabetes
that
mellitus.
is one disorder. Other is pernicious, as you see in adults, which are autoimmune disorder because of antibody to gastric mucosa or to the receptor for B12. So we don't normally do unless the patient is not responding. All right. Dr. Nitin, in your practice, when you have megaloblastic anemia, you don't want to refer to Tushar because then the patient doesn't come back to you. So you want to treat. Yeah, please. Correct.
Yes,
So will you
yes.
do homocysteine and methylmalonic acid?
So basically that is an indirect marker of B12 deficiency. Of course you can do it. And conventionally we think that it is more costly. It is actually a reverse. It costs less than the B12 levels. So that is one way we can
if you are
confirm
doing
it.
homocysteine, I mean if you are doing B12 without homocysteine, it's like a barber without knife. Because your low B12 has to reflect physiologically by having a high homocysteine. So if you have a normal homocysteine and a low B12, that is normal. So if you want to do studies of B12 folate, you should always do homocysteine, but it's an expensive test again. So normally in a patient, you can just treat them and see. If they don't respond, you can do all the further tests. All right, Nitin, how will you treat these children?
So oral and in IV and IM, all three options are available.
Correct. So which
I
one
will
you prefer?
prefer IM option. Oral absorption may be doubtful, so I will prefer in confirmed cases of the megaloblastic anemia intramuscular, that is to be given daily for 2 weeks, then maybe alternate day for next 2 weeks, and later on twice a week for 2 weeks.
All right, so this is a typical pernicious anemia protocol. Dr. Tushar, is it necessary to follow it, or maybe if there's no diarrhea or malabsorption?
So there are two things. If you have got frank pancytopenia, maybe you are considering parental iron. If the just child has come walking, talking to you with HB of 5, WBC platelet is normal, then you can just start with the oral B12 also. Absolutely not
And
necessary.
which is the indication of giving injectable?
Neurological
Like a small
symptoms.
baby. Yeah.
Neurological symptoms.
Infantile tremor syndrome, ITS. Never try oral, always give injectable because you want to prevent any further brain damage as fast as possible.
And while correcting B12 and folate, B12 has to be given initially.
Because why?
Folate should be given after 10 days.
So if you give-
Otherwise, it will worsen the neurological
If you
symptoms.
give only folate, is even disaster because the hematological situation will improve, but the neurological will deteriorate. All right. Any syndrome, you already said you will look at TRMA, thiamine responsive megaloblastic anemia, or Imuslin-Grasbeck syndrome, which is another associated with the B12 receptor problem. And many of them also have associated proteinuria. So look at sugar level, look at proteinuria in a syndromic child with megaloblastic anemia starting very early in life. All right, let's move to the case 3. Dr. Pinky, you can take the lead here. 2-year male presents with fever off and on since 1 month. Now it's a sick child, okay? Pallor for 15 days, epistaxis for 7 days. So something is progressively becoming more. Now no leg pain, no night awakening, no transfusion in the past of family. Can we have some silence here, please? Sorry. On examination, the child is 9.5 kilo, height is 81 centimeter, is pale as petici, there are no organomegaly, no bony tenderness, other system examination is normal. Treated with antibiotic, anti-malarial, ibupera, mefenamic acid and whatnot. Hopefully, so no one landed up giving meropenem and vancomycin, which is like a panacea of every fever. And this is the CBC with which he comes to you, Pinky. Now, how will you proceed? Your mic, I think you need to.
Hello.
Yeah.
So this child is having a fever for 1 month and mucosal as well as skin bleeding.
Correct.
Along with the so much bleeding that he had a pallor.
He
On
had
a
what?
pallor.
Palo, yes, sure.
So,
So
but this
two-
child doesn't have any
So
organomegaly. That
from
is,
the history, two cell lines are involved probably,
Yes.
RBC and platelet.
Yes.
Fever is there, we don't know, maybe the neutrophil also are down. So
Yes.
it looks like a three-line defect, even
Yes.
on clinical, without even touching the patient. Now on touching, no organomegaly.
no organomegaly, no bony tenderness. So, practically less chance of malignancy.
Correct, perfect.
He has been treated with the multiple antibiotics, ibuprofen, that can also lead to a bleeding manifestation, low platelets. On CBC, he has
So he's not responded to a standard fever treatment, which means it's not just infection, something beyond. I mean, we are evolving from history to examination to the basic treatment concept. Now investigation.
So
RBC series.
he has a lower side of hemoglobin,
Yes,
along
moderate
with
anemia.
the macrocytic anemia.
Yes, borderline
and his
macrocytic.
borderline macrocytic. He has RDW of lower side.
Correct.
It's not high, and he
What-
has even WBC and platelet are a lower side
So
with a
suppose-
retic count of.
Okay, suppose this child had WBC of 2500 and 80% poly.
No, sir,
versus
it's a
2500 and
neutropenic
30%
also.
poly. What is the difference in your thinking?
So absolute neutrophil count
Perfect.
should be
How
less.
many of you calculate ANC and ALC on a CBC in a tricky patient? In a normal run to patient, cough, cold, fever, you don't do, it's okay. But you must do, because ALC also. If you have a 1-year-old child coming with recurrent infection, WBC is 5000, 10% lymphocyte, unless proven otherwise is primary immunodeficiency because T cells are knocked off. And other way, you look at the ANC. So your ANC is low, around 1000,
Yes.
little less than 1000.
So this is a case of fever along with the bleeding manifestation without any organomegaly, with a pancytopenia, with a
But
low
his retic is
retic.
1%, no?
Lower
Then
side.
How it's low? It's normal, no 1%.
Corrected will be
Corrected
less.
retic we should do.
Your hematocrit will be somewhere around maybe 20 or 25, so it's half of normal. So this retic is actually 0.5.
Actually lower side.
So retic is a window to the bone marrow. You look at the retic, high retic, marrow is functioning, probably you don't need to do the marrow. Low retic, marrow is not functioning, either is failed or it is infiltrated, like leukemia, lymphoma, you need to do the marrow. All right.
So
let's-
before marrow, actually, we can conclude here like pancytopenia, low reticulocyte count, high MCV,
Ah,
pointing towards.
perfect. So you saw that picture of high MCV, high RDW, nutritional, low RDW, bone marrow failure syndrome, right?
Yes.
All right. So is it leukemia or hypoblastic? It could be both. Even leukemia can
Yes.
come without organomegaly
Yes,
and
yes.
seemingly no blast on the smear, what you call
Yes.
leukemic leukemia. All right.
Yes.
Next investigation, uric acid and LDH and
LDH
PS.
and peripheral smear. Definitely we should look for the any
Correct.
blast cells.
So suppose uric acid is normal and LDH also is normal. Does it generally rule out like leukemia?
Generally, sir, LDH should be higher in a leukemia, infiltrative
Correct.
disorders.
Fine, perfect. And the PS for what?
PS for leukemic cells, any blast cells, we should look for it along with the confirmation of our CBC finding.
Other finding, absolutely. All right. Tushar, what bone marrow sample should a pediatrician collect if he's going to do a marrow before he sends to you?
So basically, this is a patient where you will definitely not do only aspiration. You need to have a biopsy along with that.
Perfect.
So bone marrow aspiration, slides and biopsy. That is like the least thing.
Correct.
Second, of course, what we do is we also collect 2 EDT and 2 heparin samples. So in case if it doesn't turn aplastic and if it is leukemia, you can always proceed flow cytometry, fish and karyotyping from those samples.
So this
So
is
slides, 2 EDTA, 2 heparin and the bone marrow adequate size of sample.
So this is an important message. If you are doing marrow, okay, go ahead, but send those liquid marrow so that we don't have to repeat marrow when he comes to us, because it's a painful procedure in a sick child to do marrow again and again. And it's very difficult to go. Like I always say, doing a bone marrow in a ITP is like milking a cow. Doing a bone marrow in an aplastic anemia or malignancy is like milking a bull. It may be so difficult.
And one more, sir, culture we should take, bone marrow culture in case of a fever of 1 month.
Perfect. All right. Can the child be transfused? Can the child be transfused with platelet and RBC?
Yes, sir, we should transfuse patient if we are planning for bone marrow under GA. So hemoglobin should.
Before he comes to you, the pediatrician not doing marrow, he wants to refer to you. Parents say, so हम सोचता है कभी जाएंगे. Now you said, tab tak
Sir-
I will give platelet because he's bleeding.
Sir, with hemoglobin of 7, I would say we should wait for
Absolutely. If
PRBC.
he's not in failure, wait. Platelets,
We can give if there is a mucosal bleeding, yes, you should
yes.
definitely give.
But then send the patient as fast as possible because a single transfusion is enough to lead to temporary remission. After 2 months, the child will come back with florid leukemia again and he will blame you. Okay, what
Sir, here
errors?
can I just differ?
Yes, please.
Because we have given this message in so many conferences which show this thing. Now people are referring with the HbO of 3 and child in failure. So, you can transfuse the patient. There are case reports rarely that child has gone into remission. But if child is into failure, you can transfuse by 5 ml per kg without giving hydrocortisone as a routine. And then we can still do the bone marrow
So how do
examination.
you transfer a sick child suspected leukemia is, if in failure, transfuse him, but collect some smear before transfusion and send them unstained, we can see them. If bleeding, give platelet. If fever, give antibiotic after taking culture. Give fluid, just resuscitate him, wait for 24 to 48 hours. There is no urgency. No marrow of leukemia become normal in 48 hours after a blood transfusion. If that was so happening, we'll be so happy. Why do we give 3 years of treatment? But if you sit on him for 10-15 days and also have given steroids by mistake for whatever reason, then the problem starts that the patient can go into remission. Alright, so this is the marrow. This is the aspiration full of fat spaces, hardly any cellular. This is the normal marrow on a trephine biopsy. You can see these are the cartilage and in between cells which are very thickly packed. As compared to here, it's an empty marrow. So this is more likely to be a hypoplastic anemia. Alright, so bone marrow is hypoplastic anemia. Any further points on examination would have helped you? Your mic
Syndrome.
is not working, I think. You need change the mic, na?
Hello. For sir, any syndromic child, like we
Correct.
should rule out the, we should look for the tripharyngeal thumb, any Fanconi's faces for the
Can
inherited.
you have a Fanconi's anemia who is looking physically completely
Yes,
normal?
phenotypically normal,
Correct.
but they are
So all
genetically.
hypoplastic anemia in pediatric patients are to be ruled out from inherited bone marrow failure syndrome, even if phenotypically normal, because 10 to 15% of Fanconi's anemia can be physically normal. So
Yes.
what are the different inherited bone marrow failure you can pick up on clinical examination?
So Fanconi's
So like-
anemia we can
yeah.
pick up.
So
Then
you can
diamond
see
fleck.
an extra digit.
Yes.
You can see
extra
perioral
fronts.
hyperpigmentation, sometimes microcephaly, high arch parallel, malposition kidney, a double thumb, an absent thumb, and so on and so forth. So these are the things that you should never miss in a patient of hypoplastic. In fact, if this is there, you know it's hypoplastic anemia and not malignancy. Yes.
If we would have taken heparin sample, then we could have done karyotyping with the bone marrow sample only.
Perfect.
If you just do the marrow and if you don't, then again for the karyotyping and further MDS workup, you have to collect sample again.
So do you do stress cytogenic in every patient because he may be phenotypically normal?
We do it in every patient.
Alright. What about PNH studies?
Yes, in all cases.
All right. What about viral markers like EBV, CAP,
all
PARO?
cases.
How many times you have found any of them positive?
Rarely. Paro I have seen once actually, to be very frank.
And cytogenetics?
In all patients we are doing
So
it.
little older child with hypoplastic anemia, MDS can be the presentation.
Yes.
These are the things we do normally, but believe me, we have
rarely.
Hardly.
not even 1 in 1,000. In fact, I had almost stopped doing it in a non-affording patient.
Yes.
Yes, okay. But stress cytogenic, yes, you must always do. All right. Role of next generation sequencing in hypoplastic anemia, Pinky?
In a cytogenetics, then why NGS?
Absolutely. No, I will show you why NGS helps in hypoplastic anemia in my
Yes.
oration. I'll reserve this question for me to answer. Okay, should we subject them to all stem cell transplant, Tushar, or is there any medical treatment?
So the first, we have two types of aplastic anemia. One is congenital and another is acquired. Congenital, which are the Fanconi's anemia and syndrome, a clear-cut answer is bone marrow transplantation.
Perfect.
Even in acquired aplastic anemia in pediatric, the first line of therapy, if you have a matched sibling donor, the bone marrow transplantation will be the first choice. Now you are left with two things where you don't have a matched sibling donor and you are opting for a haplo-identical transplant, or you have a immunosuppressive therapy. So there the choice remains. Still haplo-identical transplant in a good center, I will prefer to send for a child for a transplant only. And if at all affordability is issued or there are some inhibitions about the transplant, then only maybe I will try with the immunosuppressive therapy as a front line.
So there are a lot of papers which have come up. In fact, we have a series of 8 cases from Vadia and I have another 6 or 7 from my own practice. All these 14 children with moderate to severe aplastic anemia, they had sibling donor in some of them,
Yes.
but still we put them on L-Trombopac and cyclosporin, and believe me, 90% of them are absolutely after 1 or 2 years having normal counts, and on follow-up they are doing well.
But
so
they
there
are
are lots
moderate,
of
sir.
paper in adult and in children that you need not do transplant in every hypoplastic anemia, even if it's severe. You can give first a trial of cyclosporin and L-Trombopac, which helps in many of these patients. Yeah, you want to say something?
I may differ, sir. Because in moderate aplastic anemia we can try, but if it is a severe aplastic anemia, we are losing the crucial period. Because by giving a trial of cyclosporin L-Trombopac, that a crucial period of 2-3 months might be lost, and we may lose the child in between because of the bleed. So maybe we will definitely work up. If there is a matched sibling donor, as upfront only I will refer this patient for the transplant.
Okay, so that's where we differ between two of us. Little louder, we can't hear you.
Madam has to differ because now she says.
Tushar, I beg to differ not because I do transplants, but because there is literature which says that for every aplastic anemia, if you can go ahead with a transplant, that's the best option.
Yes.
Because with cyclosporin and L-Trombopac, with your immunosuppressive therapy, the chance of relapse is around 40%.
And there
So even if you-
then the transplant will not give the results which you would have got as an upfront transplant.
Absolutely.
Yes.
All right, let's move. Maybe the last case, because we have 8 minutes. This is a child. Nitin, you can take this child. So you can see this child has got gross petechiae and subconjugal hemorrhage. A 9-year-old presents with skin bleeds and ecchymosis for 2 days only. No fever, no wet bleeds, means no mucosal bleeds, no weight loss, no bone pain, no significant past or family history. On examination, his weight is 18 kilos, height is 109 centimeters, generalized petechiae and superficial ecchymosis. There is no pallor, organomegaly, joints are normal, system examination is normal. So a relatively well-looking child is what I'm trying to say. And this is the CBC. Can you interpret?
So this is a case of superficial bleeding, no
Correct.
internal organ or joint bleeding. So this is most probably due to the platelet disorder, where we can see that platelet count is 10,000,
Yes.
and rest of the investigations are nearly normal.
Correct.
So
Most likely.
first diagnosis will be maybe ITP.
Okay. So any other point on history or examination that you will want to see? You already said
Whether there is a history of viral fever 10, 15 days back,
Okay.
and previously whether she has been having any hematological disorders, a history of any transfusions or any other disorders.
Perfect. There was one thing which we have not touched upon in any of the CBCs. What is the immature platelet fraction? Can you throw some light, Nitin, on what is the immature platelet fraction?
Sorry, sir, I'll refer this to
All right,
hematologists.
Tushar.
So basically what we have discussed is reticulocyte count is a window to the marrow. Similarly, IPF is one thing where immature platelet fractions, it will, if it is on a higher side, it shows that the marrow is functioning well. If it is on a lower side, it means marrow is not functioning well. So as we routinely use this test into two things. One is ITP. If your ITP is high, IPF is high, it means the marrow is functioning well and the destruction of platelets is occurring in the peripheral blood.
Perfect.
Second, where I will just complete the discussion on IPF, where we are using it in the dengue,
Correct.
where you are waiting for the platelet recovery, but you are not seeing the count. So if you do the IPF, it is on a higher side, you mean that within 2-3 days, maybe the marrow will functioning and you will get the rise in the platelet
So the
count.
parents who are eating your brain, why are you not giving platelet transfusion? The platelets have fallen to 20,000. You can rest assured saying that now the IPF is 15, 20, next 1 or 2 days the platelet will jump, and it also tells you these are young platelets which work 3 times more. So even on platelet of 10,000, they are actually like 30, 40,000. That's why the patient is not bleeding. So in dengue, unless there is someone bleeding, you really don't use any of the blood products. Yeah, you want to add something, Pinky?
So for IPF, indirectly we can say it's a marker of destructive etiology of low platelets.
Absolutely. But remember, if the platelet count is very low, like 5,000, 3,000, 8,000, your machine may not be able to give you IPF.
Yes.
And you will see a blank dash at the in the report where the IPF is supposed to be. But today you should insist on a report from a pathologist who has IPF built in the report, so that you don't waste the money. I mean, let them charge if they want 100 rupees extra, but IPF is a part of now CBC. So previously, platelets are not given, they used to black it out unless you pay the money. Now that is gone. Now you have automated counter which give you retic count, IPF, so many other things as a routine, and you should ask for this type of report. All right. Tushar, is this child had undergone bleeding time and clotting time? I mean, you do ever do in
No,
such?
no, we don't
It's
do it.
outdated.
Yes.
Absolutely, it's outdated. So you always do PT, PT10 plated and never do BTCT.
Here
what,
the,
what about PTT also in this child?
Yes.
Was it required?
So with the low platelets, I think PTA, PTT is also not required.
So this child was looking like a clinical ITP well child. Otherwise, there is absolutely no need to do BT, CT, PTA, PTT, fibrinogen, factor 13. People do all that. It's not required. It's a waste of money. Have you ever seen a patient with H. pylori coming as ITP? Adults is common. Children
Yes.
maybe not. ANA, yes.
ANA we
When
can
do you
do
do?
Yes.
in
When
an
you do?
adolescent. In
So
an
adolescents you will
child.
do, or
Female
in
child.
a chronic ITP, where the patient is not responding, you may think it's an autoimmune disorder. Is bone marrow must, Pinky?
Sir, if your PS is seen by hematologist, when you rule out the blast cells or any abnormal cells with a normal neutrophil counts, and clinically there is no organomegaly, no bony tenderness, then we should wait for the bone marrow.
Okay, absolutely. So unless you are starting steroids on your own without the smear being seen by a qualified pathologist and or a hematologist, and when I say qualified pathology, it rules out 9 out of 10 pathologists because they are not qualified. They are only qualified to sign the reports. They don't look at anything. They just count how much money has been made at the end of the day. So smear is something which a blast can pick up very easily, and that's why a marrow is required only if you are doing all these heroics. All right. So acute ITP. Do we treat every patient of ITP at the first time, doctor? What do you do in your practice? This child was to come to you. Parents say, "अरे sir, platelet इतना कम है, इतना उसको skin में सब दाग है, कुछ तो दवा दो."
So if there is a severe bleeding, then we'll consider the platelet transfusion. If there is
No, I'm not about platelet transfer. I'm talking about any drug. I mean, will you just watch and follow him up?
options for the treatment are IVIG, steroids,
But will you give
and
it
wait.
to this child?
Here we will wait.
Okay, Tushar.
So I always like to make it clear rather than just giving the theoretical answers. So practically, I will end up treating this child.
Pinky.
Sir, if child having a mucosal bleeding, I would definitely.
No mucosal bleeding like this child.
If child having a 10,000 platelet count, I would definitely treat.
I will
Because
not
there is
treat
a
based
risk-
on the platelet
There is
count.
a risk of further mucosal bleeding. If child is small, then there is a definitely chance of.
So my take on such a patient is that number one, if the patient is staying far off and is unlikely
Yes.
to come in time, always treat first time because he may have major bleeding and may not reach you in time. Second, if I'm going to start steroid, I would definitely do a marrow and then treat. And third thing is, if a patient is low platelet like this for the first time, I want to know whether he's going to respond to to oral steroid tomorrow, because after 10 days he comes up with epistaxis. I don't know whether to give IVIG or give steroid. So, and also reassure the parents. So while all the books would mention that you need not treat the patient, follow up, etc., all three of us agree that we actually end up treating at least for the first time. After that, when you stop the steroid, the platelet further falls. You have now won the confidence of the patient. They know there is something which will help them to increase the platelet count. Then you can be a little more softer in just following up without treating them.
And
All
we
right,
have seen cases like now, Dr. Izar Javed was there. One of the patient was there from the Bid who was mislabeled as ITP marrow, was never done. And when he had another sibling, this went on for 3-4 years. Another sibling was delivered. Day 15 platelets were 50,000. Genetic study has revealed CAMT, congenital omega-keratocytic thrombocytopenia.
absolutely. So quickly, we have only 2 minutes. Steroid or IVIG? Tushar.
Depending on the cost of the therapy. If the family is affording and they don't want to do marrow, I will give IVIG.
All right.
Younger child, IVIG.
Okay. Oral
Older
or-
child, non-affording, steroids.
Okay, Pinky, oral or IV steroid? Mike.
So if a child is playful, taking oral, then definitely I'll give option of high dose, short course oral therapy. But if patient having a anxious, not taking oral, then definitely IV steroid can do.
What is chronic ITP refractory ITP? These terms are changing, Pinky. What does it mean?
So first 3 months of the diagnosis is a newly diagnosed case of ITP. 3 months to 12 months is a persistent ITP. More than 1 year is a chronic ITP.
Correct.
When the patient is not responding to steroid and other is a refractory ITP.
Perfect.
And recurrent is when patient is already responded to the treatment, platelet went ahead. Then again after few days, few months, patient having again episode of ITP, then it's a recurrent ITP.
So relapse is a recurrent, not responding till 1 year, you don't label chronic. 90% of them would respond by 1 year. So chronic ITP is more an adult condition rather than a childhood condition. I think I'll wait here because the time is over. Well, I thank you very much all the panelists for your wonderful deliberation and giving clear-cut message. And I hope I have made the staff, the delegates, little more rich in the chronic, the day-to-day hematological problem.
I want to have one disclosure that not a single case was disclosed to us because sir thought that it will look artificial. And being a general pediatrician, I was most scared that what sir is going to ask me.
2 days before, I had also called sir. Sir, it feels like I am giving fellowship exam again.
So it was more of a exam of the moderator by knowing that all answers are known to them.
We are
What
happy
question
that
to
now we
ask.
can practice with confidence in our religion.
Thank you.
Thank you for such a thought-provoking session. I request the panelists and Dr. Nitin Shah sir to proceed to the felicitation area for felicitation. There is a slight change in the schedule. Our next session is on skin, a mirror of pediatric systemic disease. I take immense pleasure to invite on stage our beautiful speaker, Dr. Sharmila Kulkarni ma'am, and the chairpersons for this session, Dr. J.S. Patel sir, Dr. Praful Patel sir, and Dr. Tushar Hire sir. Dr. Sharmila Kulkarni madam is a well-known senior pediatrician from Nashik city and holds numerous achievements and awards to her cadre. Skin is not only an organ but a system that communicates with the internal environment. Although a plethora of modern diagnostics are available, skin still remains an organ directly accessible for clinical examination. Let us hear from the glowing lady herself. Over to you, ma'am.
So, good morning, everybody. Before I start, I too have a disclaimer like Dr. Nitin. Any speaker after Dr. Nitin Shah has a disadvantage, a great disadvantage. So, all of you, please bear with that. So, friends, skin throws a plethora of signs at us. We just have to pick it up and make a diagnosis. So in the next 15 minutes or so, I'm going to present a few cases where skin has been used as a diagnostic tool to diagnose some cases, systemic cases, which are potentially may be fatal. Where is it? This will not work. Okay. So you see here an 8-year-old child who was admitted in status epilepticus. The clue of his diagnosis of his convulsion was written all over his face. You can see the shagreen patches on the forehead, the angiofibromas on the face, and the ash leaf hypopigmented spots and macules on his back. The MRI confirmed the diagnosis of tuberous sclerosis. Now, interestingly, this child had undergone the knife, twice before by a dermatologist, and the diagnosis had not been made. The surgery had been done because it was obstructing vision. So, if unfortunately nobody had paid any attention to this angiofibromas, and an early diagnosis here could have actually prevented this fatal episode of convulsions. Now, port wine stain. Friends, we all see these stains in our babies at birth, and many times very loosely we diagnose them as a birthmark. But if this birthmark is unilateral, if it is in the area of the ophthalmic division of the trigeminal nerve, then it can be Sturge-Weber's syndrome. This child had type 2 Sturge-Weber's, and according to the Roche scale, and he was in high risk for developing glaucoma. In fact, this child was kept under observation. Repeated IOP screens was done every 6 monthly, and glaucoma was picked up very early. Glaucoma was treated, and this child is now 18 years old and he is doing extremely well. He is on aspirin to prevent hemiparesis and strokes. So we come to the next case. This is a 5-year-old girl with high-grade fever since 7 days, maculopapular rash, conjunctivitis, and mild cough. Was diagnosed as measles and was referred because she was not responding. So why was this not measles? She had high-grade fever, which was 102, 103, unremitting, but the child didn't look toxic. Then the rash was truncal and had not started on the face from behind the ears. Conjunctivitis was non-exudative with limbal sparing, and the child had a reddish tongue with dry, cracked lips. There was no Koplik spots. And look at this edema. Look at the edema and the erythema on the palms. All these features are diagnostic. You know that it's KD. Now, this is a classical case of Kawasaki's disease where the skin mirrors the diagnosis, and desquamation is seen after 7 days. So it is of paramount importance that the diagnosis of KD is made within 10 days, because if IVIG is given in time, then we can prevent the fatal coronary heart disease from 25%, it comes down from 25% to 2%. So this is another case of a classic signs of Kawasaki's disease, but over the next 2 days, this child worsened. She looked toxic, and so we thought of Stevens-Johnson syndrome here. If we carefully look at the lesions, patient had vulval maculopapular dry rash, it had peeling, and there was no periorbital edema, no oral ulcerations, and there were no vesicles or bullous lesions on the skin. So this pointed against Stevens-Johnson syndrome. We did a 2D echo for her, and it showed pericardial effusion, and KD was confirmed. Now, this didn't end here. This child kept on deteriorating, and she went into acute renal failure. She was shifted to the PICU. A nephrologist was called in, and the child improved over the next 3 weeks, and this was a photo after 6 weeks. So friends, this was an atypical presentation of KD with renal involvement. This is very rare. We published this case because of its odd presentation. We have been following up this girl for the last about 10-15 years. Repeated 2D echoes have been done, and this child has been normal. So now this is another very interesting case which I had seen probably around 20-25 years back. And this child you see here is male, 2 years old, febrile, irritable with rash. This was a kind of rash. And you see here, this child has a tender plaques on the right cheek, and there is erythema on the left cheek with some pregangrenous lesions on his left pinna. So in view of the developing rash, the necrotic rash, we thought of rickettsia, and Wheel Felix was sent and doxy was started. But the child showed no improvement after 2-3 days. Rickettsia was ruled out, and we were not sure of the diagnosis, so we called in a dermat. After extensive discussion with the dermatologist and other intensivists, a diagnosis of Aplaz was considered. Now friends, this was way back in 2001, where Aplaz was an absolutely new entity. In fact, there were hardly any papers on it. People had not seen it. So what we did, we sent the antiphospholipids to Mumbai, and it came positive. So child worsened over the next 2 days and developed multi-organ failure with hypotension. Here you can see the classical sign manifestation of Aplaz, the livedo reticularis, the skin ulcers, digital ischemia, purpura, everything. It was just staring at us. We just had to know it to make the diagnosis. So this child worsened. The child went into multi-organ failure, and we had to revise our diagnosis from Aplaz to catastrophic Aplaz. And CAPS is a very, very rare etiology, and therefore, but this child, actually we were lucky, this child improved, and patient responded to high doses of steroids, IVIG and enoxaparin, and of course supportive treatment. And this child then was settled over the next 2 to 3 months, and we actually could save this child at the small cost of 2 of his toes. And here friends, it is a good idea, the take home message from this is, it's a good idea to have a brainstorming session with our colleagues and keep a good dermatologist in the loop, especially when you have some skin lesions and we are not sure of the diagnosis. So this is the next case. This is a common case of fixed drug eruptions, which we all of us see. We see it in our OPD at least 1 or 2 cases every year. And the culprit here is always a drug. The most important thing is that actually these lesions come within 30 minutes to 8 hours of ingestion of the drug. Now, why is fixed drug eruption so important? It doesn't really cause anything to the patient, but the important thing is if we don't find out the drug which is causing the fixed drug eruptions, if we don't make the patients and the relatives aware of this, then this patient sometimes can land up with a serious problem, and that is a Stevens-Johnson syndrome, or he can also develop something like TENS. This is very, very fatal. In fact, this is TENS and Stevens-Johnson's is one of the most severe actually spectrum of the cases where fixed drug eruption comes at the lower end, erythema multiforme is in between, and we have at the serious end TENS, which is really fatal. And if the scrotum score is done and we see if it is more than 5, then mortality is as much as 90% or even more. So it's like you are signing a death certificate for a patient who has ingested a drug, and you could have very well prevented this. So we come to the next case. This is a 7-year-old male, progressive painful lesions on the fingertips. This child has papules on the dorsi of the fingers. He has heliotropic rash and periorbital edema, and there are some sclerodactyly with pregangrenous changes on his fingers. So all these changes are suggestive of inflammatory vasculitis. Now, you look here, the heliotropic rash and these Groton's papules, these are diagnostic of, they are characteristic and they are diagnostic of juvenile dermatomyositis. Now, this patient actually did not have any muscle weakness, and therefore he was diagnosed as a case of amyopathic juvenile dermatomyositis. And dermatomyositis is a rare, this case is a rare and a distinct entity of juvenile dermatomyositis. So here again, why is it so important to make this diagnosis? Because this patient, this condition can lead to sometimes very fatal complications like calcinosis, respiratory muscle paralysis, and even death. So we come to the next case, and this is a newborn with pigmentary lesions since birth. Now you see the child is very comfortable, and you can see the lesions all over the body. They are brown in color, they are ill-defined, and the child is otherwise very healthy. The clue to the diagnosis was given by the mother. The mother says that after giving a bath, when she gently rubs the skin, it urticarates and it also blisters, and that is the diagnosis when this is known as a diarrhea sign. And why do we get it? Because of the release of histamine in this lesion, and this is the diagnostic sign of a condition which we actually confirmed by doing the biopsy, and this is urticaria pigmentosa. Now again, urticaria pigmentosa is the commonest type of mastocytosis. Why again early diagnosis is important? Because the dreadful complications of bronchospasm, of syncope and hypotension can occur sometimes. Generally these lesions, they heal by puberty, and we are following up this child since last about 8-10 years because it can cause, there's a rare chance of malignancy and infiltration of organs with the mast cells. So now, okay, so here I have written about urticaria. I think we'll skip this slide. So we come to the next case. As we know, skin can reflect something very, very unexpected and ominous, and this is one such patient. She is 4-year-old. She came for obesity consultation. On examination, she was found to have acne, a plethoric face, and upper lip hair. Now, had she been an adolescent, we would have definitely thought of PCOD, right? But this child was a 4-year-old child, and she had pubic hair stage 4 without any breast development. So when there is no breast development and there is pubic hair, friends, we have to think of adrenal androgen secretion or production. USG was done and it showed adrenal mass, and it turned out to be an adrenal carcinoma. So the take home message here again is that if there is acne or sexual hair in a prepubertal child, this is a red flag signs and we need to do investigation. So this is a 10-year-old child. This boy was getting treated for vitiligo. He had recurrent abdominal pain, for which in fact in his hometown they had even done surgery, abdominal surgery, but it didn't reveal anything. Now here vitiligo and the unexplained recurrent abdominal pain, it suggests autoimmune cause, and in this case it turned out to be celiac disease. Now after a gluten-free diet, the child improved, but he came back after 8-10 months with respiratory distress and abdominal pain, and his BSL was 480. He had now developed type 1 diabetes mellitus. So this patient showed a cascade of endocrinal abnormalities which were totally linked. Now this is another boy, 12-year-old, presented with tetany, but the incidental finding was alopecia and the loss of eyebrows. He didn't tell us about that. Now with the low calcium and the alopecia, what is the diagnosis? It is hypoparathyroidism. So friend, whenever one sees vitiligo or alopecia, we should always think of an autoimmune etiology and rule out polyendocrinopathy syndromes, because the same gene controls all these three glands, the parathyroid, the thyroid and the pancreas. And of course, sometimes even these children can get autoimmune hepatitis. So these are all the partners in the same crime. So we now come to the last two cases where in the first case we made a diagnosis, but we still could not save the child, and the second case the diagnosis eluded us. So this is, most of us has seen neonatal scleroderma, in fact all of us have seen, which comes in early neonatal period, but fatal scleroderma neonatorum, which is presenting at birth and which is dying within 1 hour, is very, very rare. In fact, hardly any case have been reported. And this was one such case. A C-section was done for decreased fetal movement. There was difficulty while delivering the child because the child was very stiff. In fact, it was like rigor mortis, and we thought that that was the first thing that struck us, that something is desperately wrong here. The skin was waxy, it was cold, indurated, it was hard, and there was no pitting on the skin. Okay, and he had mask-like features. You can see it here in this face. We had difficulty doing resuscitation, and it was totally ineffective because of the tightness of the chest. And we could not save this child, and the child died within the next 1 hour. Now, before the child died, we took a skin biopsy, and the histopath confirmed the diagnosis of scleroderma neonatorum. Now, in this case, the character of the skin pointed towards the diagnosis, but the progression of the events was so fast that we were unable to save this child. Can you give me 1 minute? Yeah. So now we come to the last case, and this is a 1-day-old child who was again born of a C-section and was admitted for lethargy and poor suck. Now the diagnosis naturally of sepsis was entertained, and we put the child on IV antibiotics after sending blood. Okay, but the sepsis skin was negative, neurosonography was normal, and CSF was also normal. The next day the child developed this kind of rash on his nose, which we thought was not really significant. Okay, so the child was not showing any improvement. So we did repeat tests. We did a ProCal, we did repeated CRPs, we did a 2D echo, metabolic screen, everything was normal. Now, the rash progressed and it became vesicular and there was crusting. Now, at this point, we were absolutely, we had no clue to what we were dealing. So again, because of this rash, we were actually clawing at some straws, and we called in the dermatologist. He thought of herpes. Now here, he asked us to take a Zang smear, but there was crusting and we could not take a Zang smear. So here, actually we were confused. The mother gave no history of herpes, although she had fever 3 days before the cesarean section. So we were still not sure, and unfortunately in the next 2 days the child kept on deteriorating and the child died. So we lost this baby, and we then thought, probably retrospectively, that mother could have had some asymptomatic infection. Transmission is well documented even in a cesarean section, and probably we could have started IV acyclovir. I leave this question open to the audience because we are still not very sure even after about 2-3 years of the diagnosis. So with this, friends, we come to the last slide. The take home message is that skin lesions can give a clue to a potentially fatal systemic disease. Failure to recognize these clues can cost a life. Team approach can help in difficult cases, and careful observation and logical deduction goes a long way in saving a child. Thank you, friends. Thank you so much for your patient listening.
Thank you for such an interesting session, ma'am. The hall is houseful. Any questions from the audience or the chairpersons? I request the chairpersons and the speaker to proceed to the felicitation area for felicitation.
Now I request Dr. Narendra Nanivadekar sir to kindly come on stage. I also request chairpersons Dr. Atul Dattputre sir, Dr. Atul Kanikar sir and Dr. Dattatreya Patil sir. Come back to OPD setup. The always missing medical apparatus from the pediatrician's table is BP apparatus. Why is it so? We hardly need it or we hardly think of using it. Now, sir will solve all those queries. Now, topic is blood pressure, the neglected vital sign in OPD. Over to you, sir.
Thank you. Are you going to put it in the A mode? Okay. Start. Good morning, everyone, and thank you for the team Nashicon to have invited me for this talk. It's absolute basic talk, and still I'll try to do justice. In fact, this talk was supposed to be up immediately after the septic shock, so I expected that I would take on a few things from the previous speaker. Nevertheless, now with the current conference themes, we have to take a leaf out of them. Those who have been doing extremely good work in the 5-day tests are doing good work in the T20 also. So we have to also abridge ourselves and make the things appear fast and effective in next 13 to 14 minutes. So when we examine a patient, the topic is blood pressure, a neglected sign. When we examine a patient, all of us know a good clinical history, a thorough physical examination and a relevant diagnostic test to support the diagnosis is the way we are going to go. And the ultimate aim is to know the child's clinical condition for planning further treatment and necessary advice. So in a sick child, few of us are from advanced life support. So for a sick child, what the blood pressure means, the circulation assessment means all the heart rate, rhythm, pulses, refill time, skin color, etc. and the blood pressure. So this helps to differentiate me between a compensated and a hypotensive shock. And when I see a child whose percentiles are less than 5th percentile for that particular age, I know that this child is going into hypotensive shock because the outcome differs. And any child who has got hypotension with hemorrhage, we expect that this child is going to have 20 to 25% of acute blood loss. And any fall of blood pressure by 10 millimeters from the observed level is definitely significant. Why? Because if you see the vascular resistance increases, the blood pressure drops down in a hypotensive shock in an exponential manner, and we tend to lose the child in case we do not act in time. Whereas in a stable child, when we talk again the same things again, but I don't doubt whether anybody must be checking the capillary refill time for a stable child, but a blood pressure is essential. This is to complete the examination. Now, what happens in a busy OPD? In an OPD like this, when there are so many patients waiting outside, the reality is shortcuts are taken to finish the work in time to avoid the wrath of the waiting patients and the demanding parents. A general examination is done almost always. Vitals are checked, yes, majority of the times. SpO2, yes, sometimes, but especially the child is sick. But blood pressure, almost never. But in the bargain, are we going to miss something? So let us go through few cases. This is a 7-year-old female, high-grade fever, headache. You know the season of dengue is going on. Giddiness, general examination normal. She was having pulses of central pulses, peripheral pulses, poorly felt. The blood pressure was 84/70, narrow pulse pressure. Admitted, needed IV boluses. She was having dengue positive. She improved in due course of time after giving the IV fluids. Second case, 3-year-old female seen at the periphery, loose motions 3 to 4 times, vomiting 3 to 4 times, lethargy, started on IV fluids by a peripheral practitioner, blood pressure was not taken. When she was brought to us, she was lethargic, pulse of 180, poorly felt pulses, blood pressure of 72/40, hypotensive and distributive shock. This child required IV boluses, dehydration correction was given but went into multi-organ failure, required ventilatory supports, vasopressors, antibiotics, improved after a week of intensive therapy. She was lucky enough to get survived out of the whole catastrophe. The picture probably could have been different if the blood pressure was seen in the first facility and a few hours earlier. This is a 9-year-old just admitted last month, 43 kg, 140 with a BMI of 22, admitted for infective hepatitis. Noticed to have a blood pressure of 140/86. Auscultatory method confirmed that it is 140/84. There was a risk factor, he was obese, and follow-up was started. It was shown to have stage 1 hypertension. Counseling, lifestyle modification is advised. Now we are awaiting how this child's blood pressure is going to behave. This is another child. This is one of my friends from Nipani who has been keen on taking blood pressures of everyone. So a routine patient OPD care, this child, female who came, was having a blood pressure of 180/100. Investigated, found to have hypokalemia. So secondary thought of hypertension was thought of. The investigations, the renal paragraph, the renal ultrasound as well as the Doppler showed no abnormality, but the corticosterone as well as decorticosteroid both were high. She was diagnosed to have 17-OH deficiency, put on treatment, now doing fine. Case 5, 6-year-old male, intermittent headache, palpitations, flushing, sweating, found to have normal blood pressure on 2 to 3 different instances. Brought in an acute phase. Previously this was blood pressure was checked but was found to have a normal blood pressure. So this time again the blood pressure was 180/100. Investigated, found to have high VMA levels. Operated successfully for a pheochromocytoma. And this is another child admitted for headache, altered sensorium, hypoventilation, required ventilation. Found to be hypertensive. Initially it was thought that this is a reaction to this, and he was having one side weakness, hemiparesis, and he had a bacillary artery thrombus. There was a past history of admission for pneumonia, and the records when seen showed one record of BP of 130/90, probably missed and was not followed up and overlooked. So investigations ruled out secondary cause of hypertension, so probably this was the primary cause. Currently this child is on hypertensives. Now the question is whether this was a preventable episode. Last is an 18-year-old, this is a story going few years back, 18-year first year MBBS student. During the physiology class they were taught how to check the blood pressure, and somebody took this student's blood pressure, found to be 220/140, confirmed on 7 other sittings. Investigated and found out that the lower limb pulses were poorly felt. Diagnosis made at the age of 18 was coarctation of aorta. He was seen previously by one of the best pediatricians in that particular town. He was operated successfully and leading a successful medical practice. So the question is, what if the blood pressure is not taken? This ideally the child would either land into PICU, ICU with some hypertensive emergencies. They would have some major organ dysfunction or ophthalmic issues or some catastrophe which we have seen. Few would succumb to a catastrophic event without even a diagnosis made, and few will be picked up in due course of time in adulthood with associated comorbidities. So probably we are sitting on some time bomb. So from here I'll talk about hypertension, because hypertension we have already been seen by a previous speaker. So the prevalence as per the Indian data is 7%, 4% for sustained hypertension and 10% for elevated high blood pressure. The overall prevalence in children and adolescents is roughly around 3.5, and obviously higher prevalence in overweight and an obese child. The incidence of primary pediatric hypertension is also increasing. It would be identified early in primary care setting. So why is blood pressure important in pediatrics? We'll just go back again. In sick child, it will define whether the child is stable, compensated or hypotensive shock. But in a blood pressure which is higher, first of all, checking a blood pressure gives you a routine monitoring of overall health. It identifies underlying health conditions. You can pick up a renal condition or a cardiovascular issue. It enables early detection of primary hypertension and detection of asymptomatic hypertension secondary to some other cause. And it is vital in pediatric age group, especially given the relative prevalence of secondary causes of hypertension. And 1 point increase in systemic blood pressure increases the likelihood of developing hypertension by 10%. So the question is why the blood pressure is not taken in the OPD. First of all, it's a varying physiological parameter. Busy pediatric practice, we have already seen the OPDs which are running full. Appropriate cuffs are not available, actually, which should not be the excuse for not taking a blood pressure. The environment is stressful. Most office visits are for a childhood illness, fever hai, cough hai, you treat and the patient goes home. And even if the baby blood pressure is taken, this is the most important point. Even if the blood pressure is taken, do I know the cutoff value for that particular age? How that is to be solved, we'll see later. And many times it's not the lack of awareness, but it's just an inertia on our part. So the problems, there are multiple problems with measurement. Either you've got an interpersonal variability we have already talked about. Many times basic measurement techniques are not followed. Lack of routine screening, difficulty in getting the accurate measurements, and again limited awareness. And if I diagnose a child to have a blood pressure which is on a higher side, it will make myself uncomfortable, it will make the parents panicky, and the child will feel discriminated. Tumhara blood pressure zyada hai. So, and if not treated, we have already seen these are the ones which are likely to go into adulthood with a lot of morbidities. So this is something basic which will go back to, so we must have wide range of cuff sizes including a thigh cuff for use in children and adolescents with severe obesity. All of us do know that obesity is on rise, and we have got many patients who are obese, and we must take their blood pressures. Then measuring the correct length. This is very important. Measuring the mid-arm point from the olecranon. The patient should not have had any caffeinated drink at least 1 hour before the testing, should not have smoked. They should not, if they would have emptied their bladder, full bladder will add to 10 millimeters. It is advisable to have patients seated for at least 5 minutes. If suppose my clinic is on second floor, make him sit for at least 5 to 10 minutes. No conversation, very important, because talking or active listening is going to add to your blood pressure reading. Patient's back and feet should be supported, legs uncrossed, because that also is going to add to the blood pressure. And the arm should be supported at the heart level, because unsupported again is going to add to the blood pressure. Then it should be measured in the right arm, obviously, and for comparison for the standard tables, the arm should be at heart level, we already talked about, and the correct cuff size should be used. If the cuff size is falsely small, cuff size is going to have high reading, a larger cuff will give falsely low reading. So once we have taken the blood pressure, how do we are going to use it? So, and what are the important points in systolic versus blood diastolic? Diastolic is going to be important because it is less affected by extraneous other influences, reflects constant load or strain, and fall in diastolic pressure suggests peripheral vasodilation. So in a child who is sick, this is going to be important. And of course, if we find a wide pulse pressure, these are the causes which we see. Of course, we don't see AR so commonly, but fever is a common thing which we are seeing. During exertion, we are going to see commonly. And of course, anemia. And in a narrow pulse pressure, this is the one which we are going to see in a sick child who is admitted in the ICU, not in a office practice, but these shock, cardiac temporal, all the other things will give rise to narrow pulse pressure. So screening will require further evaluation, and this is the chart which all of us should have put on our walls, because this is a basic chart. If suppose we find something abnormal, then we have got the other charts from which we take the BMI of the patient and then plan whether the child is going into early hypertension. These are the definitions. For the lack of time, we will not go into that. So the American Academy has given these few important key statements. For the lack of time, we'll just go on to these three. BP should be measured annually in children and adolescents above 3 years of age. This is the key action statement. The evidence is grade 3. BP should be checked in all children, adolescents more than 3 years of age, grade C, sorry, more than 3 years, for taking medications, obesity, renal disease, aortic arch disease, diabetes. Trained healthcare professional in office should make a diagnosis of hypertension if the adult or a child has got auscultatively confirmed blood pressure reading more than 95th centile. And in a child who is less than 3 years, prematurity, all the other catastrophes, renal diseases, UTIs, child having solid organ transplant, malignancy, bone marrow transplants, treatment which is given to give drugs known to raise blood pressure, all these should be evaluated for blood pressure. And there are prevalences with various conditions, will not go into details. Obesity, The sleep disturbances and the CKD are the ones, and of course the prematurity, because these are the ones which are likely to have good chances of getting hypertension. So if suspected elevated blood pressure, then what are we going to do? Most important is chart the growth of the child. This is yet another neglected record in all our OPD findings, and we must make a point to keep a chart of height as well as weight and make the centile so that you can match with that particular person. And if the patient is elevated, you should do 2 oscillometric or oscillatory BP measurements at the same visit. If using auscultation, average measurement used to determine the child's BP category. Just a minute. And let us not go into the causes because it's a big talk, but we know that how do we follow the pediatric age group where we try to diagnose secondary causes. So renal, endocrine, other causes have to be thought of. So there are various screening tests to be done. And how do we strategize to improve the BP monitoring? First of all, training healthcare providers, all our staff nurses, implementing routine BP screening protocols, using electronic health records to track BP trends, reinforcing the importance of BP monitoring in children, and encouraging proactive measures in healthcare setting. So to summarize, taking a blood pressure is a part of the examination both in a sick as well as stable child. All the children should have their BP checked at least once in a year, more than 3 years. All the children should have their BP checked at every visit with a risk factor, and try to identify the primary cause in the pediatric age group before labeling it as essential hypertension. Always have the reference tables ready at the bedside. If the protocols are followed, it will no more be a neglected sign. Thank you.
Thank you for the wonderful lecture,
Can I
sir.
make a comment here, sir? Chairpersons? Can I make a small comment?
Yes.
I am Dr. A.S. Vasudev, pediatric nephrologist. So blood pressure, as Dr. Nanavadikar has seen, I think this is one thing which we are seeing often missed, and I see a lot of renal patients whose blood pressure is not taken, and we miss at times. I will give you 2-3 simple things which can be kept in the clinic. You all have 5 inches cuff size, adult cuff size. Just buy one more 3-inch cuff size, and it can serve 2 years to 18 years all the practical purposes of taking blood pressure. Secondly, sir, having charts, as Dr. Nanavadikar says, is very important. At times we take BP, but we don't know whether it is high or not. And thirdly, I think all children, as pediatricians, we are seeing one-time blood pressure below 5 years of age at least should be measured so that we don't miss on any of these children at later date. Thank you very much.
Thank you.
Thank you, sir. Now I request Dr. Narendra sir and all the chairpersons to proceed towards the felicitation stage. I request Dr. Sandeep Kadam sir, who is a consultant neonatologist currently working in KM Hospital, Pune. I also request Chairperson Dr. Praveen Kale sir, Dr. Amit Patil sir, and Dr. Suvarna Devre to come on stage. Dealing with neonates is always a difficult task, and if these complex newborns not responding to routine steps of treatment, then the whole NICU team land up in dilemma. For answering one of such difficulties in NICU, sir is here. I request sir, please start your talk.
So good morning everybody, respected seniors, chairpersons. At the outset, I would like to thank the office bearers of IIP Nashik for giving me this opportunity to be here this morning in front of all of you. So in the next 25 minutes, what we are going to discuss is approach to refractory hypoglycemia in newborn babies. So as we know, if you look at hypoglycemia, there is no one number, and different people have defined different cutoffs to define hypoglycemia, and these are variable. The American Academy of Pediatrics and the WHO says, well, less than 47 milligram as hypoglycemia. In first 24 hours, the cutoff may be less than 40. After 24 hours, the cutoff may be 44. The Pediatric Endocrine Society says, well, less than 50 at 48 hours, and after 48 hours, any blood sugar less than 60 is hypoglycemia. So the cutoffs are going to be variable but by and large, for all of us sitting in this room, the operational threshold is very important. So we need to maintain a sugar of at least above 50 in all newborn babies in order to prevent hypoglycemia related injuries to the brain. Now, if you look at these organizations and the cutoffs, I am sure with increasing age the numbers are increasing, but by and large there is no consensus. And that is what I would like to emphasize, that people are going to give you different numbers and we need to have an operational threshold. So please remember that we need to keep the blood sugar of at least 50 and in the first 24 hours and more than 60 thereafter to maintain euglycemia and in order to prevent neuromorbidities related to hypoglycemia. I'll just take you through this little bit complicated diagram related to biochemistry. When we all eat or give feeds to the baby, the glucose is converted and then it's metabolized by the glycolytic pathway and it gets converted to pyruvate and acetyl-CoA. Now acetyl-CoA goes into the citric acid pathway or the TCA cycle to give us ATP in the mitochondria of this cell. When there is excess glucose, it gets converted into glycogen and that is stored in the liver and the muscles. When there is euglycemia, obviously there is more insulin and that's why we get protein synthesis and fat synthesis because of anabolic effect of the hormones, that is insulin. But when the sugar falls and there is hypoglycemia, this glycogen is going to get converted into glucose by glycogenolysis. Proteins are going to get broken into amino acids and thereafter it gets converted to ammonia and ammonia is excreted in as urea in the urea cycle pathway. But these proteins which are broken, they give us glucogenic amino acids and these amino acids are converted by gluconeogenesis into glucose. Similarly, the fats are broken into glycerol and free fatty acid. These free fatty acids are converted by beta oxidation to acetyl-CoA and thereafter we get neoglucogenesis. So in cases of low blood sugar, glycogen is converted to glucose, proteins are converted to glucose by gluconeogenesis, fats are converted to glucose by gluconeogenesis, and also this acetyl-CoA gets converted into ketone bodies which can be used by a newborn brain. So these are some of the compensations which act in our body, and for these compensations to act, basically we need three things. One, enzymes, and we all realize that a lot of these enzymes are important for glycogenolysis, gluconeogenesis and lipolysis, that is the beta oxidation. We also need substrates and we need hormones. Whenever there is hyperglycemia, insulin is secreted, but in cases of low blood sugar, the counter-regulatory hormones which are glucagon, adrenaline, cortisol and growth hormones are released and they are necessary. So these are some of the things which are essential, which happen in our body, which happens in a neonate in order to prevent hypoglycemia related problems in these babies. So which are the babies or whom to screen for hypoglycemia? The more you screen, the more you are going to find, and more you find, the more you are going to treat, and the more you treat, the more you are going to prevent the hypoglycemic encephalopathy and its long-term sequelae. So all preterms, SGAs, large baby, infants of diabetic baby, but most important, any sick newborn in the NICU, please do a blood sugar. And you will be surprised that you would find more and more cases of hypoglycemia in these babies. Apart from that, RH isoimmunization, babies on TPN, post-exchange transfusion, mothers on beta blockers and midline defects. So these are some of the babies where we would screen for hypoglycemia. Coming to refractory hypoglycemia, what is definition? Any baby where glucose infusion rate is more than 12 milligram per kilo per minute, or babies whose hypoglycemia or fluctuations of sugar persist beyond 7th day of life is refractory hypoglycemia. So this is where we are in terms of trying to find what is the way ahead. So before we go to the pathways, a word about screening for glucose. We all know that glucose oxidase method is the best method to look at blood sugar in babies in the laboratory, but all of us are using glucometers or point of care devices, and there is a wide variation when the sugars are too low or too high, and the variation can be as high as 10 to 12% in these babies. And there is a third way wherein you could look at the enzymatic point of care analysis and specific glucose cartridges. Currently there are also researches going on about continuous glucose monitoring in some of the babies. So please remember, if the sugars are too low or too high, we need to send a laboratory sugar and check the blood sugar and correlate it with our glucometer readings. So physiological approach to babies with hypoglycemia, well, the cause could be either very high insulin or decrease in the counter-regulatory hormones, decrease in the substrates where you have less glycogen, less proteins or less lipids, and last but not the least, there could be increase in the demand by the baby, which results in hypoglycemia, and therefore this is how we would tackle these babies. Now I'll take you through some of the cases which we have seen in our day-to-day practice, and I'm sure you have seen these time and again. Now this is a term baby, large for gestational age, 4.2 kilo, mother was diabetic, requiring fairly high insulin, she had polyhydramnios. Looking at this, it is obvious in an uncontrolled diabetes, elective section, and this baby had low blood sugar immediately after birth, requiring very high glucose infusion rate. The concentrations went up to 18%, sugars, GIR of more than 12 milligram per kilo per minute, and it required about 12 hours for the babies to stabilize the sugars. So this was obviously persistent sugar instability, persistent hypoglycemia related to infant of a diabetic mother and high insulin. So this was a hypoglycemia due to diabetes in the mother. Now this is a 36-weeker 1.3 kilo baby born to a mother with severe PH. The baby was transferred in the NICU for low birth weight and very low birth weight status and SGA. Baby had mild tachypnea but hypoglycemia in the first 3 days of life. Baby required a glucose infusion rate of 12.5 milligram per kilo per minute. The hematocrit was 76% with a hemoglobin of 24, obviously telling us that this was a symptomatic polycythemia, and in this baby the insulin which was sent was 3 units. So here in this case we had a severe SGA, polycythemia and a detectable insulin. All the 3 could explain hypoglycemia in this baby. And this is the third case wherein this was a term baby, female child 3.4 kilo, transferred from outside for hypoglycemia. Baby had low sugar. This was an off-colored baby with poor capillary filling time, poor pulses, low blood pressure. Baby had low platelets, received multiple antibiotics. This was a typical late onset infection. Insulin was 5.6 international unit. So this was a case of late onset sepsis with high insulin. Now what are we looking at? So all these 3 cases we had high insulin. The first case was typically an infant of a diabetic mother. Second was a severe SGA with high insulin, and a third case was severe infection which was late onset sepsis, maybe an element of fungal infection or a gram-negative sepsis with high insulin. So these are the cases where we had insulin which was detectable with hypoglycemia, and these are some of the scenarios which we see right, left and center in our unit in day-to-day practices. So a large baby, a small baby, or an appropriate for gestational age baby where it could be in utero asphyxia or postnatal infections, and you can get hypoglycemia. So transient hyperinsulinemia can be seen in babies where they have intrapartum or antepartum hypoxia and perinatal asphyxia. It could be due to infections. It could also be sometimes due to umbilical arterial cannulation where the UAC is misplaced and it is exactly at the site where it was celiac plexus, and the pancreas is secreting more and more of insulin. It could be seen in SJ, typical insulin resistance syndrome, or infants of diabetic mothers. So please remember, these are transient and the response to diazoxide is very good. And if you treat the underlying cause, most of these hypoglycemias improve and these babies do well. So this is rewarding for all of us sitting in this auditorium, that babies would do well when we treat the underlying cause. Now coming to the fourth case, this is a term baby, 3.8 kilo, breech delivery, and this was a breech extraction. Baby did not cry at birth, baby had mild distress, low sugar, requiring high glucose infusion rate. So a UVC was put. Since the glucose concentration was more than 12.5%, we had to put an umbilical venous catheter. Despite giving high glucose infusion rate, the hypoglycemia persisted. So we thought of infection. We did septic workup, we started antibiotics, the insulin was detectable, hence baby was started on diazoxide. But the intermittent hypoglycemia used to persist, there was dysregulation. So what next? Anybody? We did an ultrasound and there was some collection in the liver. So we removed the UVC, we thought there was some problem with the umbilical venous line, whether it's caused any extravasation or whether there's any infection, abscess, so on and so forth. But the sugars were still low. So we repeated ultrasound and it showed a big adrenal hemorrhage with a subcapsular hematoma of the liver. The serum cortisol was low, and this was a case of adrenal hemorrhage presenting as hypoglycemia. Baby was initiated on steroids and the baby did well. So moral of the story is that adrenal hemorrhages are rare, but not that it's impossible. We need to have a very high index of suspicion. So any hypoglycemia where the sugars are not coming well, we need to send a serum cortisol. This is typically seen in large babies, seen in breech extractions, babies with perinatal asphyxia, or sometimes with severe infections you can have adrenal hemorrhage. The key would be to look at the baby and see if the baby is pale and anemic. There could be refractory hypoglycemia. Babies may have low sodium and high potassium, hyponatremia with hyperkalemia. In case of mineralocorticoid insufficiency, cortisol levels sent are often diagnostic, and herein steroids are drug of choice. So this could be adrenal hemorrhage presenting as severe refractory hypoglycemia. Now case number 5. This is a term baby presenting with severe persistent hypoglycemia, referred for seizures and hypoglycemia on day 6 of life. This was a 3.8 kilo male child, large baby. Baby required fairly high glucose infusion rate. Diagnosis was congenital hyperinsulinemia. The serum insulin was 18 international units. Baby was started on diazoxide. However, despite giving 15 milligram per kilo per day of diazoxide, there was no response. So what next? Is this congenital hyperinsulinemia, nasidoblastosis, or is it islet cell hyperplasia? What are we looking at? So this was obviously persistent hyperinsulinemia, and we looked at the genetic diagnosis, and this was ABCC8 gene defect, which was autosomal recessive homozygous. So herein you had a genetic basis for hyperinsulinemia, and this was a congenital hyperinsulinemia on a whole exome sequence. So basically when you look at hyperinsulinemia, next few slides I am going to just sensitize all of you regarding insulin and its problems. Whenever there is glucose which is present in the blood, it comes inside the cell, it enters the cell, it undergoes glycolytic pathway. So glucose is converted into glucose 6-phosphate, and thereafter it gets converted into pyruvate, and it goes into the mitochondria, and there is ATP production. When the ratio of ATP to ADP increases, this ratio, the potassium channel, that is the potassium ATP channel, closes. So there is no potassium efflux. There is depolarization and the calcium channels open, and this calcium which comes inside the mitochondria causes rupture of the insulin producing cells, and there is release of insulin. So the calcium induces insulin exocytosis from the cell. So this is how insulin production normally takes place, or insulin secretion normally takes place in the beta islet cells of the pancreas. Now slightly more complicated slide. Now this is the typical potassium ATP channel through which the potassium efflux normally takes place. There are two subunits, the KIR 6.2 and the SUR, sulfonylurea receptors. Now glucose is going inside the cell with the GLUT2 receptors, gets converted to glucose 6-phosphate by glucokinase, which causes increase in the ATP ADP ratio. Increase ATP closes this pathway. There is entry of calcium inside the cell. This calcium will cause insulin secretions. Similarly, there are proteins and amino acids like glutamate, which gets converted by glutamate dehydrogenase to alpha ketoglutarate, which increases this ratio, and this closes the ATP channel. So if we give certain amino acids or proteins, that also can increase insulin secretion. So this is typically what we were taught about leucine sensitive hypoglycemia or branch chain amino acids, and this there in turn is insulin secretion. Now why am I taking you to so many biochemical pathways? The whole purpose is we need to also understand what is the application. Well, the application is very simple. Glucose comes inside the cell, it undergoes glycolysis, gets converted to pyruvates, it gets converted, increases the ATP to ADP ratio, and thereafter there is closure of this potassium channel, calcium influx, and insulin which is secreted. Now if you inhibit this glucokinase, or if you open this potassium channel by giving diazoxide, the calcium entry is going to decrease and insulin secretion is going to decrease. So how can I decrease the insulin secretion? I need to open this channel, which can be done by diazoxide. I can close the calcium channel by giving calcium channel blockers, or I can block the insulin release by somatostatin, or I can inhibit this enzyme by inhibiting or reducing leucine and glutamine. So these are some of the applications wherein you could treat hyperinsulinemia. So how do I diagnose hyperinsulinemia, or in a case of refractory hypoglycemia? Whenever blood sugar is less than 50, any detectable insulin which is more than 2 unit is diagnostic of hyperinsulinemia, wherein you have low beta hydroxybutyrate, low free fatty acid, detectable insulin or C-peptide, and most importantly, if I give glucagon, there is an increase in the blood sugar by 30. So these are 4 criteria to diagnose hyperinsulinemia in a newborn baby. But point to be noted is I need to exclude hypopituitarism, wherein I look at cortisol which is more than 10 and growth hormone more than 7. Whenever we have hypoglycemia, as I told you, the counter-regulatory hormones are supposed to increase. If there is a failure to increase counter-regulatory hormone, wherein your cortisol is less or your growth hormone is less, you need to have an index of suspicion that there could be a possibility of hypopituitarism. So in absence of detectable rise of cortisol or detectable rise of growth hormone, in presence of hypoglycemia, we need to consider hypopituitarism somewhere back of our mind. And always remember, hyperinsulinemia is hypoketotic hypoglycemia. So that is something which we should remember. Low ketones, hypoglycemia, think of hyperinsulinemia as first diagnosis. What are the clinical clues to you and me? Whenever you see a baby who is large, think of infant of a diabetic mother, Beckwith-Wiedemann syndrome, or it could be a genetic cause of hyperinsulinemia. A small baby with high insulin, again look for a SGA baby. Hypertrophic cardiomyopathy, think of a potassium ATP hyperinsulinemia, and a congenital heart, look for Turner's, or even a perinatal asphyxia with asphyxial cardiomyopathy. How do I pick up hyperinsulinemia or residuoblastosis? Well, I can do a PET scan, which is a DOPA PET scan, wherein 18-fluoro-dihydroxyphenylalanine or DOPA PET is taken up by the neuroendocrine glands. And this scan will help us differentiate between a diffuse and a focal disease. So babies who have got genetic hyperinsulinemia, diazoxide unresponsive hyperinsulinemia, or a genetically negative hyperinsulinemia, we need to do the DOPA PET scan to pick up a disease which could help us pick up either it is a focal or a generalized disease. If it is a focal, all that I need to do is tell a pediatric surgeon that he will excise that part and the baby becomes well, and it's a rewarding surgery. So coming to the drugs that we would give in hyperinsulinemia, we use hydrocortisone in fairly large number because we have nothing to give in cases of refractory hypoglycemia. Is it correct or is it wrong? Well, it is not indicated because we are trying to buy time and it may not help in these cases. The dose is 2.5 milligram per kilo per dose 12 hourly, but give it only if the cortisol levels are low. Well, diazoxide becomes your first drug, 5 to 20 milligram per kilo per day in 3 divided doses. It binds to the sulfonylurea receptor, it opens the potassium ATP channel, and therefore it decreases insulin release. But diazoxide has got adverse effect of retaining the fluid, hence we have to add hydrochlorothiazide in a dose of 5 to 10 milligram per kilo per day along with diazoxide. And also it can cause hypertrichosis. If diazoxide doesn't work, then we could give octreotide in a dose of 5 to 25 microgram per day. It is given either subcut or it can be given as an IV infusion. It basically acts through the somatostatin. It binds to the somatostatin receptors and therefore it decreases insulin secretion by the beta islet cell. The only problem is that octreotide is short acting and it has to be given as a slow infusion. And one could give glucagon, and then as I told you that glucagon can be given in a dose of 0.1 milligram per kilo, and there is a sudden rise of more than 30 milligram of sugar, and that is diagnostic of hyperinsulinemia. So diazoxide responsiveness, well, dose is 10 to 15, you can go up to 20 milligram per kilo per day. Usually in the first 3 to 5 days, you should start seeing a response. If there is response, obviously the glucose infusion rate falls and your sugars are going to be above 70. But if it is unresponsive, then you need to look at genes, ABCC8 and KCNJ11. And most of the time you may find some gene abnormalities. You could do a DOPA PET scan and you could continue octreotide. So in case of diazoxide unresponsiveness, please send genetic workup, whole exome sequence and consider octreotide. Octreotide basically inhibits insulin secretion by binding to the somatostatin receptors and causing hyperpolarization of the beta islet cells. The dose is 5 to 25 microgram per kilo per day, but the risk is NEC and diarrhea. Sirolimus is another drug where people have used in diazoxide resistant hyperinsulinemia. Dose is 0.5 milligram per meter square. It may be given along with octreotide and it may reduce the viability of the beta islet cells of pancreas. So what essentially we learnt in hyperinsulinemia is if there is response to diazoxide, you increase the feeding and wean off diazoxide in the next 6 to 8 or maybe 12 weeks. If there is no response, send a whole exome sequence. If it is homozygous mutation, give high glucose infusion rate, give high calories. You may consider octreotide, but the child finally would need near total pancreatectomy. If the genetic studies are negative, then look at the father's ABCC8 and KCN, do a DOPA PET scan. If it is a focal lesion, you need to just do a lesionectomy. If it is a diffuse lesion, near total pancreatectomy. So this is where we are in terms of diazoxide resistant hyperinsulinemia. Not so useful therapy, steroids. Don't use it unless it is indicated in adrenal insufficiency because it can cause long-term problems of infections, hypertension, bone demineralization. And people have tried giving calcium channel blockers but again have not shown to be of great help. Next case is a term baby, 2.4 kilo, transferred for hypoglycemia on day 4 of life. This was a 3rd degree consanguineous marriage. Baby had hypoglycemia on day 3. There was minimal tachypnea but chest was clear. There was no murmur, no dysmorphism, no organomegaly. Blood sugars were low. ABG showed metabolic acidosis. The lactates were high. Ammonia was high. Obviously this was a case of organic acidemia and inborn error of metabolism presenting as hypoglycemia. So if you have looked at hypoglycemia and there is no acidosis, the ketones are low, free fatty acid levels are low, you are looking at hyperinsulinemia or hypopituitarism. You could give glucagon and see a rise of glucose. If the free fatty acids are high and ketones are low, that is hypoketotic hypoglycemia with increase in free fatty acid, this is a beta oxidation defects or it could be carnitine deficiency. If there is acidosis with increased lactate, look at gluconeogenic defects. If it is acidosis with increased ketones, look at glycogen storage or hypopituitarism. Similarly, this again would come to the same levels. We could look at normal lactate, high lactate, acidosis and high insulin with hypoketotic and high ammonia and low ammonia levels. So this is how we would look at inborn errors presenting as hypoglycemia. Next case is term baby, female child, 2.8 kilo with hypoglycemia on day 4. There were no ketones, insulin was not detectable, free fatty acids were normal, cortisol was 1.3, growth hormone was low. So this was a typical case of hypopituitarism where this was a midline defect. Maybe there could be presence of micropenis, central incisor, midline cleft, and the CT showed small pituitary fossa. So please remember, a cortisol less than 10 or a growth hormone less than 7 in presence of hypoglycemia is again a red flag that this could be a pituitary deficiency. So whenever you see a hypoketotic hypoglycemia and poor response to diazoxide with normal or high insulin and deficiency of cortisol and growth hormone, we should start thinking of hypopituitarism. Look for physical features of midline defects, good response to cortisol and growth hormone, and also these babies can have cholestasis. And the cholestasis typically in neonatal period is unconjugated with hypopituitarism, and in infancy and thereafter it could be a conjugated hyperbilirubinemia. So unconjugated hyperbil is a presentation of hypopituitarism in the neonatal period, and thereafter it could be cholestasis presenting as congenital hypopituitarism. Word about dextrose infusion, we would all like to maintain blood sugar around 70. We need to start with IV dextrose. We need to look at the glucose concentration. Anytime your glucose concentration is more than 12.5%, please use central line and don't give oral feed or tube feeds alone because they may not be able to maintain your sugars that well. Some practical tips, basically how to calculate glucose concentration. And this is a formula that is 5x minus 25. So if you have 5% and 25% dextrose and you want to make a desired concentration, say 12.5%, then in that case 5 into 12.5 is minus 25 is equal to 37.5 ml of 25% dextrose, and to this 100 minus 37.5 is 62.5. So you take 37.5 ml of 25% dextrose and 62.5 ml of 5% dextrose to give you a 12.5% of dextrose concentration of that 100 ml. So this is 5x minus 25 for us. We also need to understand how to calculate glucose infusion rate, and these are two formulae, that is rate of IV, that is ml per kilo per day into percentage dextrose divided by 144, or you could also look at rate of IV glucose, that is ml per kilo per day into percentage dextrose into 0.007, and this will give us the glucose infusion rate. And this is a nomogram which is fairly available. Here you know how many ml per kilo per day of fluids you are giving, you know what is the percentage, and you can calculate the milligram per kilo per minute of glucose infusion rate. So these are some of the nomograms, and obviously there are a lot of apps which are available. And this is another way by which you can see, this is the percentage dextrose and this is the ml per kilo per day, and you could look at the glucose infusion rate. So basically what is it that we have learned in the last 20-25 minutes? Look at the clinical clues. If it is a large baby or a small baby, look at polycythemia, look at midline defects, and try to pick up some of the clinical presentations as to what could be the etiology of persistent refractory hypoglycemia. Look at the blood sugar, but also do a urinary ketones, and if it is a hypoketotic hypoglycemia, you have got hyperinsulinemia or hypopituitarism. Look at insulin and cortisol. If your cortisol is less than 10 with detectable insulin, probably there could be a cortisol insufficiency that you're looking at. It could be due to adrenal hemorrhage or it could be due to pituitary cause. Any baby with high insulin start diazoxide, and in case of unresponsiveness to diazoxide after 72 hours to 96 hours, think of a genetic investigation. A whole exome sequence is warranted, and you could pick up a hyperinsulinemia, a genetic cause. Hypoketotic hypoglycemia not responding to diazoxide, look at ABCC8 or KCNJ11. Fatty acid oxidation defects or hypopituitarism. Octreotide and sirolimus may be tried in these babies. F-DOPA PET scan can be done or needs to be done in babies with persistent hyperinsulinemia, and inborn errors of metabolism and endocrine causes are something which should be thought in refractory hypoglycemias. We may have to take help from our pediatric endocrine colleagues or a metabolic specialist so as to sort out these difficult to treat or dilemmas in our day-to-day practice. So with this, I would like to thank all of you for your patient hearing. Please remember that hypoglycemia is one of the most common preventable cause of mental and motor delay in our babies. The more we screen, the more we find, the more we treat, and that is going to decrease the morbidities in the long run related to hypoglycemia, cortical visual impairment, mental subnormality, ADHD, autism, and developmental problems. So let us all pledge to screen, treat, and prevent hypoglycemia in our day-to-day practice in all our babies who are admitted in the NICU, and also low birth weight babies in the postnatal ward. Thank you.
Thank you for this informative talk, sir. Now I request our chairpersons and Dr. Sandeep sir kindly proceed towards the felicitation stage. There is one announcement regarding the vehicles. Vehicle number 1819 reads and DS 8984. They are obstructing other vehicles. Kindly please take care of it. We now move on to the oration. For the same, I hand over the mic to Dr. Sachin Patil, Secretary of Nashicon.
check. Hello. 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 Check.
There is a request to all the Nashik IIPians. There will be a group photo after oration. So I request all the Nashik IIPians to be in the hall after oration. Thank you. There's one more announcement. For everybody's knowledge, we'll be having one more grand CME on 17th November in Guru Dakshina Hall at Nasik, Athavle Foundation's Infectious Disease CME. The details will follow soon. Thank you. We now move on to the oration. For the same, I hand over my mic to Dr. Sachin Patil, Secretary Nashik IIP. Over to you, sir.
Thank you, madam. Good afternoon, all. Now is the moment we are waiting for. May I request Dr. Sachin Chaudhary, sir, President IIP Nasik, to escort our chief guest, Dr. Nitin Shah, sir, on the stage. I also request Nashicon chairperson, Dr. Ravindra Sonawade, sir, and Dr. Milind Baradia, sir, founder president Nashicon, to escort Dr. Subhash Kashyap, sir, on the stage, please. I request Dr. Rahul Kopikar, son of late Dr. Kopikar, sir, to join us on the stage. I request all dignitaries to please come forward. Thank you, sir. Now I request our IAP President, Dr. Sachin Chaudhary, sir, to give us a brief introduction of Dr. G.V. Kopikar oration and also introduce our chief guest, Dr. Nitin Shah, sir. Over to sir.
Hello. Good afternoon, respected Dr. Nitin Shah, sir, Dr. Subhash Kashyap, sir, and all delegates of Nashicon 2024. I, as the president of Nasik IIP branch, feel extremely proud to be here on dais for today's Dr. Gautam Kopikar, sir, oration, an annual oration in fond memory of our beloved IIP member late Dr. Gautam Kopikar, sir. After sir passed away on 9 November 2006, the then Nashik IIP members contributed to generate a fund to have an annual remembrance in form of oration since year 2007. Dr. Gautam Kopikar, sir, was not only a person of academic excellence but also of great empathy towards patients. He was a great human being with all humbleness. He was an inspiration for all of us practitioners in Nashik. I was fortunate enough to be associated with him at Kilbil Hospital, where I learnt a lot from him. He was teacher to many of budding pediatricians at that time. We used to get amused by his clinical diagnostic skills coupled with perfect academics. It used to be a feast for students while attending rounds with him. Apart from academics and clinical skills, he had an extra edge of knowledge in share market, literature, etc. Evening meetings of IIP used to be cheerful with his spontaneity. For new generation, Kopikar sir's story may sound like a fairy tale. It is actually true also, because legends are born once in a while. It may take hours to tell about sir, but due to time constraints, I need to curtail myself. We are proud that Kopikar sir's son, Dr. Rahul Kopikar, is also showing his sparks and is a rising star on the horizon of Nashik IIP. I wish him all the best. I wish best of health to Mrs. Kopikar madam on behalf of Nashik IIP. Today we are lucky to have Dr. Nitin Shah sir, a renowned pediatrician, to deliver today's oration. I think there is no need to introduce sir, as probably you won't find anyone here who doesn't know about sir. Sir currently is the head of Department of Pediatrics at Hinduja Hospital, Mumbai. He has many awards and research papers on his name, and he has been past president of National IIP year 2006. He has vast interest across all subspecialties in pediatrics, but especially hematology, hemato-oncology, immunology. I will now invite Dr. Shah sir to please enlighten us on the next generation sequencing, boon or bane. Thank you.
Can I have this? So first of all, I would like to thank the organizers and the oration committee for giving me this wonderful opportunity to be here and deliver this oration. What better way to be familiar with Dr. Kopikar than as a personal friend? And I remember when I was the president in the year 2006, almost at the end of my career as a president, I heard the news that we lost him. So many times the question the child asks, Dad, why do all the best people die early? So the answer given by dad is that, my son, while you are in a garden, which flowers do you pick up? The most beautiful ones, right? So the God also does the same probably, and that's the reason why the most intelligent, the most handsome, the most academic and the most dashing person from Nashik IIP, we lost him very prematurely. Of course, the destiny is not in our hand, but it was very befitting for the IIP Nashik then to start this oration on his name, and I am really fortunate and a lucky one to be delivering the oration and standing in front of you. The topic I chose, of course, as you know, pediatric hemato-oncology is my profession and vaccination is my passion. But today I will talk more on my profession than on my passion. And that's why I chose the title of Next Generation Sequencing, is it a boon or a bane? When Dr. Sonamane and the oration committee were asking me to suggest some titles, I had given several topics, and this one they liked the most because, as Dr. Sonamane was saying, it's become a fad for people to do next generation sequencing where they don't know what the problem is. The problem could be as simple as something which is clinically solvable, and yet the patient is made to spend thousands of rupees. And at the same time, of course, there are areas where there is absolutely no clue as to what's happening with the child, and that's the time when this type of reporting is very easy. So let's see this child. It's a simple anemia. A 3-year-old girl born to consanguineous marriage, a case of a congenital deafness, was posted for cochlear implant at a public hospital. Now they did a pre-op investigation and they found that she was anemic. So at 7 months, she had anemia and breath-holding spell. So that is way back 2 years before she came to this hospital. She was transfused on a hemoglobin of 2.5 gram without really much investigation done in a peripheral place in India. And that time the hemoglobin was 2.1 with WBC of which looked normal and a platelet which was normal. There was a smear which showed macro, micro, NISO per kilo, so probably looked like a nutritional anemia, though it's very early, 7 months to have such severe anemia. Anyway, that didn't click the parents that time. They had done an iron studies and an HB electrophoresis which was normal. So over the years, she was given oral iron, multivitamin, but without much benefit. And at 1 year, there was one more CBC available which showed 6.7 gram hemoglobin. And the first time that MCV showed was 93 milligram. And the WBC looked okay and the platelets looked okay. There was no petechial rash, ecchymosis, fever, jaundice, abdominal distension, lymphadenopathy, organomegaly, bone pains, cox contact, really to suggest what the cause of that ongoing anemia from 7 months in such a small child was. There was no family history of any early neonatal deaths or any blood dyscrasias or transfusion in the past. So while she was investigated at 2.5 years as a pre-op investigation for her cochlear implant, they found that the hemoglobin was 7.3, and for the first time there was little low neutrophil 25% and a little low platelet count of 95%, and the retic being 0.8, the corrected would be somewhere like 0.4. So obviously there was something wrong with the bone marrow of this child. Extensive investigations were done for the anemia. Ferritin was near normal, G6PD, liver function, renal function, thyroid function, bone marrow aspiration, biopsy, everything was done. The bone marrow aspiration was suggestive of megaloblastic anemia, and bone marrow biopsy report was not traced by the patient, and he just disappeared. And he got admitted in a public hospital again. And there the bone marrow biopsy report was shown, and that showed myelofibrosis. So someone started the child on steroids for 4 weeks. And on one day she had polyuria and the blood sugar was done which was 350. So she was in diabetic range of sugar. So she was diagnosed as steroid induced diabetes. Her insulin levels were actually little low. So it was not that it was absent which you suspect in a patient with congenital diabetes mellitus, and her antibodies were not detected. So an anti-insulin antibody was 10.6%. She was treated with insulin and steroid was stopped. Patient did not improve even when off steroids and needed to have insulin to control the diabetes. At this point, patient came back to us. So we put everything together. Consanguineous marriage, something you must keep in mind in neurology and hematology. Consanguinity means some inherited disorder unless proven otherwise. She had congenital sensory neural deafness, for which she went first to the public hospital for cochlear implant. She had a diabetes mellitus which was ascribed to steroid, but the steroids were stopped and yet the sugars were not falling. And she had a chronic anemia which looked like a megaloblastic anemia, and then myelofibrosis actually misled the treating physician into starting steroid which were not required, because there is nothing like a primary myelofibrosis in children. It's a very adult diagnosis. In children it is always secondary to some chronic inflammation or chronic infection. So if you are smart, and of course this is I'm talking about when next generation sequencings were not available in anywhere in the India, certainly not in Bombay. This is I'm talking almost 15-20 years back, and this was very early in my practice. So all I had was a smartphone. And for some of you who are not tuned to, please do store the OMIM site on your phone. The OMIM is the one which gives you any genetic disorder for which there is a known mutation and a known clinical presentation. You punch in even now congenital sensory neural deafness, diabetes mellitus and megaloblastic anemia, and it will give you a diagnosis that this is nothing else but TRMA that Dr. Pinky Shah talked about, the thiamine responsive megaloblastic anemia. Now as sequencings were not available, so I searched through the OMIM site, and you will get several sites where a test is done free of charge. All that you need to spend is transporting the what do you call, the CBC or the EDT or whatever sample, and they will give you the report you cannot use for commercial purpose or for giving as a label to the patient. It's only for research purpose. So under that, I found this Dr. Neufeld at Boston, USA, who was doing this type of investigation. I'm happy Pinky is here because she's the one who mentioned about TRMA, and this was indeed TRMA, started on high dose thiamine, anemia got corrected, everything else was corrected, diabetes disappeared, but what will not disappear is the cochlear lesion, because that is in utero damage to the hair cell of the cochlea, and that's why the deafness will never disappear. So this is the report sent by Dr. Neufeld from Boston, saying that, Dr. Shah, I hope this is not the same patient who keeps on coming again and again to different doctor, either sample coming to us again and again. So I said, no, this is a new patient, and he said, okay, he has this mutation in the SCN1 which leads to, she's homozygous, so please check the parents, and so on and so forth. So this was in the era where the next generation sequencing was not available, and we were struggling to really prove a difficult case or a rare case as the cause of the clinical condition that the patient has. So then follows the next generation sequencing, which has made life both easy as well as miserable, and I'll see you how. So what is NGS? There are some 7,000 undiagnosed disorders which are refractory to standard clinical and laboratory testing, out of which 80% have a genetic basis. So if you had a genetic diagnosis possible, you will be able to give a label to this patient and maybe do research to find out some treatment solutions. Now, rare diseases are the ones which affect less than 20,000 subjects in United States, and ultra rare diseases are which affects less than 2,000 subjects of the entire US population. So if you say India is 7 times bigger, so you'll say almost a lakh of people or less is a rare disorder, and 10,000 or less people affected in India would be a ultra rare disorder. Now sequential targeted genetic testing could diagnose 55% of those. So that's the reason why the entire gamut of human genome sequencing started, and the sequential targeting was the initial test that was used. Now when you use a next generation sequencing, which is a very fast process, it will add another 25 to 50% of the remaining cases. So it can virtually diagnose 80 to 90% of these rare or the ultra rare disorders by doing the genetic test. Whole exome sequencing adds another 10 to 15% more diagnosis than the whole exome. So while we are not doing whole genome sequencing in our country still, because it is still expensive, you know what is genome and what is exome and what is clinical exome. Clinical exome is targeting the genes for which we know a disease. Exome is targeting the entire exome except the introns, and whole genome is taking exome as well as introns. So it's like taking the entire genetic pattern of the patient, of the person, and sequencing that. So there has been an increasing awareness about using targeted sequencing to the clinical exome, to the whole exome, and even whole genome. Now in the Western countries, whole genome is as expensive as the whole exome. So they tend to do whole genome. In our country, whole genome is almost 3 times or 4 times more expensive than the whole exome. But fortunately, whole exome has become the same cost as clinical exome. So we have stopped asking for clinical exome and we ask for a whole exome sequencing. So this is all because of this Human Genome Project, and I hope some of you know about what it is. World's largest collaborative project to identify all base pairs that make a human DNA, and identify, map and sequence all human genes out of these base pairs from physical and functional standpoint view. So you may have a mutation which may matter or may not matter to make or not make a protein, which ultimately leads to a disease. So imagine how much thought process and background work went on to have this type of Human Genome Project. So there are more than 3 billion nucleotides in human genome. Samples from few individuals used to sequence these nucleotides by International Human Genome Sequencing Consortium. IHGSC was the one which was funded by the voluntary foundation as well as by federal funding, and they undertook the task. Started in 1996. And only 92% was completed in 2003 and 100% in 2022 at a cost of $3 billion US. But the advantage of that we are getting now is reaping the benefit of using this database to find out new and rare disorders. So this human genome sequencing from 1996 to 2022, you are talking about more than almost 20 years, is because of Sanger sequencing. Sanger sequencing is where you take a piece of nucleotide bit by bit and then add them together. It's a very, very laborious process. Of course, that's the gold standard today. So what has happened is now the NGS. Sanger sequencing involves sequencing of a single strand of DNA at a time. So it takes decades for the entire human genome to be sequenced. Whereas the next generation sequencing involves massively parallel short-read sequencing in which millions to over 1 billion DNA fragments are of approximately 100 to 500 base pairs are simultaneously generated across the exome or the genome as you have asked for, and then they are aligned and analyzed. And in silico, which means the computer then analyzes this millions of pairs that you have aligned now with a database that is available, and there are several databases that are available, and tell you whether you have or you don't have a particular genetic mutation, and whether that particular genetic mutation is the cause known to humankind today for causing a particular disease. So that is how the entire whole exome sequencing and the whole genome sequencing has evolved from the Human Genome Project to today getting a whole exome sequencing for as less as 10,000 rupees. One exome sequencing, if you send abroad to USA, used to cost more than ₹1 lakh, is today available for as low as 10,000 rupees. So you need a peripheral blood sample or a buccal mucosa. In someone who has been transfused recently, you can't take the peripheral blood, so they take buccal mucosa swab, like how they take for the HLA antigen testing. The advantage is speed, throughput, and accuracy. And I think these three things are very important because it gives you a report within 2 to 3 weeks, at the most 4 weeks. Once you get something abnormal on an NGS, you always have to verify by Sanger sequencing because that is the gold standard for small gene sequencing bit by bit. But you don't have to Sanger sequence the entire genome, you only Sanger sequence the mutation that you have found after doing a NGS. So that's the advantage of using NGS and Sanger sequencing in a tandem. Now, applications include genomic and clinical research to find out new disease and new treatment, reproductive health in someone having a problem in reproduction, environmental, agricultural, forensic science, and so on and so forth. In medical conditions, it is mainly used for all genetic disorders, obviously, neurological disorder. The advantage of this whole exome sequencing is more in neurology, especially primary mental retardation or delayed milestone where you don't have a reason like hypoglycemia or some asphyxia at time of birth in an otherwise normal baby but having mental subnormality. This has really helped us to understand a lot of genetic disorders. Hematology, yes. Oncology, yes. Immunology, yes. And today I am going to show you some cases where it has helped and somewhere it's not helped in hematology and oncology because it's a vast subject, we cannot cover all the systems. So can it replace newborn screening? Like you spend 15,000 rupees on doing some 120 or 160 metabolic disorders, can you do a next generation sequencing? That will be a problem because tomorrow you have a baby born and you are very happy and you do an NGS and it finds that that female girl has a BRCA gene positive. You don't know when to remove the breast of that young girl. So it's a tremendous problem in your brain to rear up a child where you know a mutation can lead to a problem later in life. So it is like the Trikal Gnan or the Sahadev was so miserable in life because he knew what's going to happen next and he cannot prevent it. So that is a type of problem this next generation sequencing is going to create, that too much knowledge also may be dangerous for a normal human life. I mean, all of us are here born to die someday. Okay, you need not die of something which is preventable, but if you are going to die every day for knowing that you have some mutation which is in the back of the mind, I think that's a disaster that is happening. I hope this doesn't happen, that newborn screening is not replaced by NGS. Otherwise, mind you, if any one of you sends your NGS, you will find at least 30 to 40 mutations. But they are not labeled as pathogenic because they are not known to lead to disease. But once you know, like suppose you have a mutation which is heterozygous for a bone marrow failure syndrome in your child who is born today, you really wonder whether he is going to develop bone marrow failure, because today it's not known that that mutation can lead to bone marrow failure. Tomorrow the science may progress saying, oh, that is the cause of a rare bone marrow failure syndrome. So every time you'll keep on looking at the nail, is he looking pale, is he having fever, something, and keep on investigating. So these are the dangers of this type of investigation done routinely. So it should be done with a precise need and a precise indication. So the types of genetic next generation sequencing are what you call single nucleotide change, small insertions, deletions, large structural change, copy variant, pseudogene. These are all the names, just don't forget about it. It can be intron as well as exon, or the entire, it may be in the germline or during the cell division somatic, or acquired like in a cancer as an environmental mutation, etc. So clinical exome, what we used to use in past, would target 3000 to 6000 genes known to lead to human disease. Whole exome targets almost 22,000 genes. Many of them are not required, but some of them may be new genes, and the whole genomic is targeting the entire exon plus intron to open up the vista for something which is going to happen tomorrow. So the NGS report typically has 5 different categories. So you have variant that is pathogenic and variant that is likely to be pathogenic. These two means this is the cause of your problem in the child. You have variant that is likely to be benign or variant that is actually benign, you just discard them. In fact, the labs should not even report them. The problems only come when there is a variant of unknown significance, because it means this variant is in a gene which is known to lead to the clinical condition for which you have asked for, but it is not known to be associated with any disease in the database as on today. And every 2 years, 1 year, 2 years, the database gets updated, and it may become a variant of significance after 2 years. So that is the VUS is the real nightmare when you ask for a NGS in your patient. So these are easy, these are the cause, these are to be discarded, and this is the one which is going to lead to trouble for you. But you should not discard them, you should keep them in mind. So now the question, is NGS a boon or a bane? So let's see some cases where it's a real boon. So let's see this child, 2-year-old male child, presented with skin purpura and epistaxis. So he was a bleeder. There was no fever, weight loss, joint pain, organomegaly, and his CB showed mild anemia, which was normocytic, normal differential and WBC and differential, and a low platelet of 17,000. So suspected as ITP, bone marrow was done, which was normal, was given oral steroid, there was no response. Bleeding stopped, and that's why he was kept under follow-up. Now in follow-up, the skin bleeds continued. Repeated CBC showed that there was thrombocytopenia with fluctuating hemoglobin and fluctuating absolute neutrophil count, which means his counts were going up and down. Someday there is only anemia, sometimes there is low platelet, and so on and so forth. So he was admitted for workup. Repeat bone marrow aspiration was done, which was again normal. Bone marrow biopsy was done, which was mildly hypocellular. So now it's giving you a clue that he is progressing into a hypocellular type of marrow, maybe some constitutional hypoplastic anemia. Meanwhile, his viral markers were done as we do stress cytogenetic and MDS cytogenetic. Everything was negative except the EBV IgM came positive. So he said, okay, maybe it's a treatable cause of a bone marrow suppression because of EBV. So he was given IVIG, but there was only partial response. Actually, he didn't respond really well. And a repeat EBV workup after some time became negative. So again, back to square one, we don't know the diagnosis. Started on cyclosporin, not much help. Over the months, low counts with skin purpura continue. A third bone marrow biopsy is done, which now shows mildly hypocellular again. So he's not evolved severely into a severe or a moderate hypoplastic anemia. So we are stuck as to what is it, and do you treat him as hypoplastic anemia, and do you subject him to transplant, as we were discussing before, and very vehemently the transplanter and one of the panelists says that no, they will always subject a hypoplastic anemia of acquired origin to a transplant. So we said, okay, let's do a NGS pending a search for a donor, and you get this mutation, homozygous for thrombocythemia, autosomal dominant condition. The gene involved is the THPO, which is the gene which is involved into thrombopoietin. Now this fellow has no thrombocythemia, he has got thrombocytopenia. So what is it? And he is homozygous. So obviously there is, you cannot discard a homozygous which do mutation in the same exome. So you look at this particular variant in the search in OMIM, it will tell you if there is a gain of function mutation, he will come with thrombocytopenia. If the loss of function mutation, they will come with bone marrow failure syndrome. And that is exactly what this child was presenting with, bone marrow failure syndrome. And why am I stressing it is because if you have a mutation in this THPO gene, which means they are not making thrombopoietin, the marrow does not produce RBCs, polymorph and platelet, all three, and not only platelet. And these children, if they are subjected to stem cell transplant, it will fail. So this child should not be subject to stem cell transplant. And all he needs is to give him thrombomimetic agents, and that is your L-thrombopag. So this child was again confirmed by a trio. When you have a mutation in the child which is homozygous, both the parents have to have each mutation. So we did the study in father and mother, both had the same mutation. So we proved by a trio that that is the real mutation. And defect in the thrombopoietin, patient was started on weekly romiplostim, and remarkable recovery of counts of any blood product support, normal CBC over the last several months. If this child was subject to transplant, he would have either died of transplant or he would have failed miserably. All he needs now is, in fact, this child is not very affording. So we said, okay, can we reduce the weekly injection to bi-weekly? He still had good counts. We made it 3 times once in 3 weeks. He had good count. Now he takes only once a month romiplostim, and his hemoglobin is maintained above 9, platelet above 50-60,000, ANC above 1500. This child will need lifelong romiplostim, but he is cured of a disease by a simple medicine. This was possible only because of the mutation that we did in the analysis. So, question that I asked, do you do NGS in all hypoplastic anemia? The answer is yes, you should do, because you will get sometimes this type of disorder. Second case where it's with a boon. Why is this child bleeding? 1 year male child presented to me with prolonged bleeding from a tongue cut following a fall. Now, tongue cut bleeding will be massive because it's a very vascular organ, but it should stop after some time. Hemoglobin fell to 5 gram, WBC and platelet count being normal, PT, APTT being normal, thrombotime being normal. Fibrinogen levels came back as 150 milligram, but that's not enough to lead to such severe bleeding. It has to be really below 50, 60, or maybe even absent, like in an afibrinogenemia, and a factor 13 being normal. So whatever bleeding profile we could do to ascribe the cause in this child was normal, and he was bleeding like a tap. Anyway, we rescued him by giving transfusion, FFP, local adrenaline pack, oral tranexamic acid pending all these reports, and his bleeding stopped. So you were discharged as query hypofibrinogenemia, but to confirm on a later date by doing serum fibrinogen. So on follow-up, he continued a skin purpura. He was investigated again, including the repeat fibrinogen level, which came normal. So we said, okay, let's do von Willebrand level, let's do platelet function studies. Both came normal. So now, and his PS shows a normal platelet size and shape. So now we have ruled out platelet dysfunction also as the cause. Now what is happening in this child? He came back 1 year later with epistaxis which was not controllable and needing a nasal packing by the ENT surgeon. His repeat bleeding profile was normal. So this time what we did, because his hemoglobin was not low, we just gave him platelet alone, without FFP, without PRBC, and his bleeding stopped. So we knew at least in hindsight that the cause of his bleeding is some platelet disorder, which we are not able to find out either as a number because the platelets were always normal, and in the form of platelet function studies it did not become a platelet dysfunctional disorder. So we need to investigate what type of platelet disorder this child has. Remember, when you give platelet to any child who is bleeding, where you don't know the cause of low platelet, I am not talking about this child, a cause of low platelet, you should do 3 things. You should do a platelet count at 1 hour and at 24 hours. If your 1 hour platelet count is same as the 0 hour, it means there is immune destruction, because whatever you given is destroyed immediately. If there is good recovery at 1 hour but poor recovery at 24 hours, which means it's consumed in the next 24 hours, that is your consumption coagulopathy. And if your recovery is good at 1 hour and at 24 hours, it means decreased production like hypoplastic anemia, aplastic anemia. So at least when you give platelet to a child, do this test to find out. Okay, so we did his NGS again, and he showed that he is double heterozygous for a platelet type bleeding disorder 19. And we of course did the same test in the parents also. So the parents also had the same type of mutation. So we knew that this is a pathogenic variant of a platelet dysfunction, which is not picked up by platelet aggregation studies, because everything is not picked up on platelet aggregation, and all this child would need is sparingly use platelets whenever there is a major bleeding disorder. Okay, so this is the parent study, and this is the mutation which is known to lead to a platelet type of bleeding. Alright, third case, ITP, 10-year male child presented with skin bleeds off and on for 1 month, occasional epistaxis for 2 days, no fever, bone pain, weight loss, trauma, well looking child, liver spleen not palpable, low lymphadenopathy, no bony tenderness, joints normal, skin purpura, typical ITP presentation, well looking child having some epistaxis for a short time. Hemoglobin was 9.5, little low. And why should a 10-year child have low hemoglobin in an ITP? if he has not bled from outside so much. Okay, WBC and differential are normal, platelet is 18,000. Marrow is done, normal, labeled as ITP, started on steroid. 4 mg per kg for the first 4 days, as Dr. Pinky said, high dose, short course, and then tapered. There was partial response, platelet rose to 45,000, but not like magic response that we expect. Bleeding stopped. So we said, okay, some ITP don't respond to steroid as well, we kept on follow-up. Over the months, the platelets kept on fluctuating between 16,000 to 80,000 without any treatment, and he had now pallor. So what was 9.5 before became 7 grams. Even the WBC ANC fell 3,500 with a polymorph of 30%, which makes ANC around 1100 to 1200, which we are not comfortable in an ITP case. Clinically, he developed just palpable liver and a 2 centimeter spleen, so some organomegaly. Did we miss malignancy? But no, we had done a marrow before giving steroid. So bone marrow was repeated again. Again it was normal because we were worried about a malignancy. IPF was done. It was not high. Now we said IPF has to be high in an ITP patient. That means he is probably not an ITP. His DCT was done because his hemoglobin is low, because sometimes we may have two antibodies, what you call Ivan syndrome. DCT was negative. We thought of immunodeficiency. We thought of ALS, autoimmune lymphoproliferative syndrome. We did his immunoglobulin levels, and we found that they were little low with a low CD3 count. Now, is it because the steroid he received that there was an immunosuppressive? Because steroids can depress the lymphocyte count. And we did this for his ALP, the double negative T cell population, it was normal. So there was no active bleeding, hence we kept on follow-up. And on follow-up, the CBC kept on showing low hemoglobin, low ANC, and a near normal platelet. Something is amiss. What is happening to this child? So we said, okay, let's send his NGS. And we found that he is hemizygous for an X-linked disorder, which is from his mother, which is known to lead to X-linked lymphoproliferative syndrome type 2. Not type 1, which leads to EBV, malignancy, which is a very drastic disorder, type 2. Okay, we confirm by doing the mother's test, which also she showed that she has the same mutation as the child. And then we search in the OMIM what is XLV type 2. Then we get this clinical and genetic characteristic of XLP type 2 in Japan, and it shows that some of them can have immunodeficiency like picture, some of them may need IVIG, and most of them have fluctuating counts. So what was labeled as ITP was actually something different. And the fourth case where the NGS really helped is, this is a 4-month-old child who came to me in Apollo Hospital, presented with anemia, massive abdominal distension, and little overweight child. Born to consanguineous marriage. Again, consanguinity in a rare disorder should raise the suspicion in your mind. Mother is a known case of thalassemia trait. This child was 7.5 kilo at 4 months, that was a little overweight, good height of 68, pallor was there, liver was 2 centimeter, and spleen was 5 to 6 centimeter in such a small child. There was no icterus, no lymph node, normal faces. And this is a CBC. Hemoglobin low, ANC is 2800, so that's normal. Platelet count is normal, and MCV is low, 65. Now maybe because he also may be thalassemia minor, so his hemoglobin and MCV may be lower, but that still doesn't explain the massive hepatosplenomegaly. Now we did his electrophoresis, HbF was 10%, but remember he was only 4 months. So HbF can remain high till 6 months after the birth in a normal child. His A2 was 4.5%, which means he was a thalassemia carrier, and his hemoglobin A was 85, which means he is a thalassemia carrier because he's born to mother who is thalassemia carrier. That is solved. Ferritin was 12 nanogram, which means he had an iron deficiency on the top of thalassemia minor, which is seen in many children, but that still doesn't explain the splenomegaly and hepatomegaly. We started him on oral iron, vitamin D, folate, B12. Hemoglobin improved to 8.2 but never became normal. Abdominal distension reduced, the spleen became little lesser to 5 centimeter. So we thought whether he is an alpha chain triplication, which in a thalassemia minor can behave like a thalassemia intermedia. So we did the study from the NIH in KM hospital, that also came normal. Alright, so I said we must do a bone marrow to rule out a Gaucher's or Niemann-Pick, which is just an associated condition. The parents refused that. We said maybe the liver is involved and the spleen is involved because of primary hepatic fibrosis. Patient didn't want liver biopsy. His primary immunodeficiency workup, again DNT workup was done, everything was normal. And on follow-up, his distension suddenly disappeared and the spleen regressed to less than 1 centimeter without any treatment. So for 1 year he was lost to follow-up because they used to stay in not in India but somewhere else. And he came back after 1 year with this type of picture, massive lymphadenopathy in the cervical region, all the lymph nodes. You can see the posterior auricular, submandibular, all, or he has got a huge lymph node which are possible. And again, his hemoglobin is 8.1, WBC is 19,000, LDH is little high, but really nothing else to suggest. So we said, okay, let's do his NGS. We are now stuck with somewhere. So his NGS showed that he is homozygous for autoimmune lymphoproliferative syndrome type 1A, and he's also heterozygous for beta thalassemia, which anyway we knew because we had done his electrophoresis. So this was a pathogenic variant showing you this is a defect in the fast ligand. Now for you, some of you know, every cell has to die. That's known as programmed cell death. If that doesn't happen, that cell will remain. And like an oldies who keep on doing kitch in the house, these old cells which have no work to do, they'll keep on leading to autoimmunity and collect in the lymphoid organs. So liver will become large, spleen will become large, huge lymph node. So that's what is known as autoimmune lymphoproliferative syndrome. All you need to give them steroid, the glands disappear, and then you can put them on sirolimus as an immunomodulator for 1 year or 2, and they are all okay after that. So ALS is an autoimmune lymphoproliferative syndrome which could diagnose only based on this type of studies, because otherwise you do what you call a double negative T cell, which was done in this child as a screening test, but it had come normal. So it's an error in the fast ligand which leads to this type of disorder where they have lymphoproliferation, organomegaly and cytomenias. Okay, so that's the boon, real boon to solve these 4 cases which would have never solved, especially the first case, TPH, the thrombopoietin gene abnormality. If transplanted that patient, he would have died or he would have definitely failed the transplant. NGS may need a review. As I said, in silico compares what you have found based on a database. If the database will keep on adding newer mutation as the world is advancing. So what is not known today may be known tomorrow. So don't give up because you didn't find an answer today. So let's see this 4-month-old child who came to me with fever for which CBC was done. Hemoglobin was 7, normal MCV, normal MCH, normal MCHC and a normal RDW. So normocytic anemia. WBC is high, 22,000 and platelets are 1.8 lakh. All anemia workup including marrow was done, it was normal. He was given some symptomatic treatment. He started having fever, almost daily fever, and now has failure to thrive. He almost stopped growing. He kept on needing transfusion once in a while because hemoglobin would drop to 5. WBC count always remained high with a normal differential count and sometimes low platelet of around 70,000. So PUO stopped growing, failure to thrive, anemia, sometimes thrombocytopenia, all sorts of nonsense happening. Now patient was admitted for PUO workup. CRP was high, XHS was normal, all the cultures done were normal including bone marrow culture. His viral workup was done which was normal. A repeat bone marrow was done which was normal except it showed some few hemophagocytes and a ferritin of 900 and a fasting triglyceride of 156. We said maybe are we dealing with some mild HLH type? He had also some mildly raised SGPT, otherwise a normal LFT. TB workup, primary immunodeficiency workup were both normal and his CT chest and abdomen was done. The spleen was seen there. Now why am I saying spleen is always seen in a normal person? Because in a follow-up there's something going to happen. So we said, okay, this is look like some HLS, so let's treat him with steroid. So patient started on Dexa and the fever disappeared like a magic drug. So obviously he had some autoinflammatory disorder, if not HLH. After 3 months of tapering and stopping Dexa, the fever reappears. Every day fever, 101 to 102, he'll become irritable, the grandmother knows, she'll give crocin and the child will stop crying. All the tests for infection repeated normal, ferritin had risen to 1,400 because he needed repeated transfusion. Now we did an ultrasound to find out what is the reason and his spleen has disappeared. So he undergone an autosplenectomy. Now where do you have an autosplenectomy? In a sickle cell disease. So he said let's do his electrophoresis. He is a sickle trait, not sickle cell anemia. So sickle trait don't have splenectomy. So we did mothers. The mother also was sickle trait. So that was solved. But that still doesn't explain why his spleen disappeared on its own. So we said now something is missing. PUO, failure to thrive, little looking abnormal faces, having autosplenectomy, there is something we are missing, so let's send an NGS. We send the NGS. The NGS came as one mutation for congenital dyserythroid anemia, which he didn't have because marrow was normal, and he had heterozygous for sickle cell anemia, which we knew because his sickle cell already electrophoresis had shown he is a trait like his mother. So we are back to square one. So we can, okay, follow up, daily fever, transfusion dependency. So far what we have, transfusion dependent anemia, autosplenectomy, autoinflammatory condition, abnormal phases. So I requested Dr. Manisha from NI, I said, let's do a whole genome sequencing. We are missing something. So she said, okay, she collected the sample, but she sent it for whole exome again to the same lab. I won't name the lab because it's not fair. And this time the lab says he's got a pathogenic variant in what is known as homozygous for hemoxygenase 1 deficiency. And we did the study in both the parents, they were also positive. He also had a sickle cell anemia heterozygous because we knew he had. So I asked the lab, I said, I sent you first the NGS and it was normal, and this time you're saying NGS is showing abnormal. He says, sir, we don't report all VUS. Because that time, 2 years back, this homogeneous was not known as a cause of autoinflammatory disorder in children, but now it is known, so we have labeled it as pathogenic. The point I'm making is, if you have in doubt and if you have not found, review. Review may mean review of your old NGS, where all these laboratories keep the sample for years together, or send a repeat sample and you will be rewarded by diagnosing this type of case. Okay. Are all VUS, which means they are of unknown significance? So let's take this child. Pallor notice early life associated with poor appetite, poor weight gain and poor activity. When the pallor increases, the parents are very classical that he becomes pale, we know he becomes irritable, doesn't want to eat, doesn't want to play, and he doesn't put on weight for the next few months. There was no reason for him to have anemia like bleeding worms pica. He had needed transfusion twice at the age of 2 years and 5 years. So that was something which is very surprising, but no nutritional anemia would need this type of transfusion. He was pale, except that he had nothing on physical examination. And this is a CBC with which he came. Hemoglobin 5.6, MCV grossly low 58, RDW grossly high. MCH, MCSC also suggests that is iron deficiency. WBC platelet counts are normal. Several CBCs were done in the past which are showing similar picture of an iron deficiency. His serum iron was 25, transferrin saturation was just 5.5%. His ferritin was just 3 nanogram per ml. So we said, okay, this is a refractory iron deficient anemia, maybe celiac, maybe malabsorption, maybe pulmonary hemosiderosis. So we work out stool for occult blood negative, done many times. X-ray chest for hemosiderosis normal. Ciliar workup was done 3 times by different pediatrician and hematologist normal. He was treated with umpteen number of oral ions several times but no response. Once in a while some smart pediatrician gave him IV ion and there was some response. With this picture when he came to me, I said, no, this is some genetic disorder, what we call IRIDA or iron refractory iron deficient anemia. So we said he was advised marrow and hence he came to Hinduja. I said, you don't need a marrow, what you need is a genetic test to find out whether what I am suspecting is IRIDA. So we sent his whole genome sequencing and it shows he's homozygous for iron refractory iron deficient anemia mutations. Now we have sent both the parents mutation, this is very recently, we are awaiting, but this was labeled as VUS because this mutation is not known in the database to lead to. Remember, the same disease mutation may be different in Indians, may be different in Western country. All the databases are based on what they find in the Western country. So you should add this mutation in a site that's known as Clever, where you can add the clinical scenario and the site to your institute. They will record it. And when they find 2, 3, 4 more records from other parts of the world, they will add that as a pathogenic mutation. So all VUS are not VUS. Some of them are true reason, but they will only evolve over the time. Okay, so what is the IRIDA? You have hepcidin, which is an anti-iron protein or hormone. So you have high hepcidin, iron is not absorbed, iron is not transported from the liver or from the sites of storage to the bone marrow, and that's why the bone marrow behaves like an iron deficiency. And this is a mutation in this what is known as the matriptase 2 site on the TMPRS86 gene, which leads to increased hepcidin unnecessarily, and that leads to a poor iron response. Now, do you always need NGS? That's the question. This is an answer which everyone has to understand, that if you do unrequired NGS, it's only burden to the poor families. So 5-year-old male born to child presented with anemia since 1 year of age. So 5-year-old child since 1 year is anemic and he has been treated with hematinics without any response. Hospitalized 4 times for recurrent respiratory infections, so repeated infections. He was treated diagnosed and treated as iron deficient anemia, but yet would not respond and he needed twice transfusion. Affluent class and yet consanguineous marriage. Some of the South Indian families have this consanguinity even in the most affluent class. I was surprised to hear that. There was no bleeding, worm spica or bone pain for his anemia. He was not that well grown. 13 kilo at 5 years is low. 107 centimeter at 5 years is low. He was pale and had just palpable liver and spleen. His hemoglobin was 6.5. WBC differential were normal. MCV was 59 and RDW was 21, which means he was like iron deficiency. Platelets were normal. Micro hypo NISO ovelo on smear and all the other workup including electrophoresis were normal, and we did his serum ferritin was 250. That was high. Now he doesn't have infection, he's behaving like iron deficiency, his ferritin is high. What is happening? So these are the children who need marrow. And when you do a bone marrow, especially when you are high ferritin, hepatosplenomegaly, in a consanguineous marriage needing transfusion, ask them to stain the bone marrow for iron, because your primary diagnosis is iron deficiency, and that comes the answer that 50% of the nuclear red cells are sideroblastic. So he is a congenital sideroblastic anemia. Diagnosis is made on bone marrow. Now, do you need an NGS? Parents were doubting the diagnosis. So they said no, we want it, and it showed that he is homozygous for the sideroblastic anemia gene. So sometimes you may not need NGS unless the parents want to insist. So this is a bone marrow diagnosis, and the treatment is simple. You just put them on a high dose of pyridoxine and everything disappears. And this child will need lifelong pyridoxine and they will be okay. Okay, NGS is not always a boon. So like we do in hypoplastic anemia, I do in hypoplastic anemia after that thrombopoietin mutation, I do in every patient of hypoplastic anemia. Most of the time you find that there is no pathogenic variation, so we are happy. But sometimes you can see, like this child, they said it is a pathogenic variant of a bone marrow failure type 2, but it says it also comes as mental retardation, bone marrow failure, learning disability, neuropathy, microcephaly. None of this child with hypoplastic anemia which I had was having any of these clinical symptoms. So obviously even this mutation is there, it is not the cause of his bone marrow failure. Okay, another child, bone marrow failure syndrome is found to be hereditary folate malabsorption. Again, it is supposed to lead to diarrhea, immunodeficiency, infection, neurological deficit. None of them this child had. So again, this mutation is not the cause of his bone marrow failure. And we had a child who had alpha thalassemia single mutation, but that's not the cause of his bone marrow failure syndrome. And lastly, we had a child with preterm having abnormal faces and a bone marrow failure syndrome, and he was double heterozygote for Diamond, Schwarzman and Fanconi's. Obviously, stress cytokine was done, it was normal, and he didn't have any pancreatic insufficiency. So none of these mutations are actually the cause of his bone marrow failure. So remember, when you do it, you have to interpret based on the clinical syndrome and not just go by what the laboratory will give you as the report. And lastly, if you do this NGS, I think it will be a defeat of my coming here and giving you this lecture. This child was a 5-day full-term newborn, birth weight of 3 kg. Both parents are known to be sickle trait. The parents want to know whether the child is having trait or disease or nothing. So someone did an NGS and it showed his autosomal recessive sickle trait. All I need is a sickling test to say is sickle, and then do electrophoresis. It showed hemoglobin S is less than 50% is a trait. 14,000 rupees for something that could be done by a test which costs actually 500 rupees in a small laboratory. So this is something which please do not do. And suppose if this was a girl child and was also showing BRCA positive, what will happen to their parents? They behave like Angelina Jolie, or they sit on that and worry about the girl child going into problems. All right, so we should not do this. Last case before I stop my presentation is clinical skills are irreplaceable. Genetic diagnosis is one of the arrows in your collection of arrows to fight your enemy. It is not the Brahmashastra or a Brahma brand that you can use every time. Let's look at this simple life but not for all type of case. 10-year-old girl, recurrent skin purpura since last 6 months. No mucosal bleed, no joint bleed or swelling, no family history of bleeding. Father works in Indian Navy, and so the thoughts were okay, it's got recurrent purpura, maybe ITP. So investigation was done. CBC was bang normal, platelet of 2.6 lakh. PTA, PTT was done because platelets were normal, that was also normal. Thrombin time, fibrinogen and factor 13 as the other coagulation or what you call bleeding profile was normal. platelet function studies were done, obviously because there is a superficial bleed, only skin bleed, that was normal. All screening tests were done 3 times at least before she came to me, were all normal, and someone had put on oral vitamin C as a placebo, obviously it didn't help. Now this is the type of purpura this girl had. So if you see very classic presentation, purpura which are linear, not round like in a platelet disorder. Purpuras on the sides which are accessible to you and not on the back or some area which are not accessible easily. And purpuras of different, what you call life, like some are old with scars, some are fresh, etc. And I was discussing with the mother as to what should we do next. I said, okay, I told the girl, you go and sit outside. And she came back after 5 minutes with another purpura. I said, no, this is definitely self-inflicted fictitious purpura. There is something wrong with the family. The mother will say, there is nothing wrong with me. I said, you have only 2 choices. Either a smart observation by you or someone to find out what's happening to this girl, or you admit under me in Hinduja hospital, we'll put her on video recording without her knowledge and we'll come to know what's happening. So she of course didn't want to admit, so she told her teacher to observe. So the teacher made us sit in a room saying, okay, I am coming in 5 minutes, you do this, finish this job I am giving you for some lesson. And from a slit in the door she was seeing, and she caught her pinching herself. And she immediately went and said, what are you doing? Then she expressed, she said, oh, I don't want to do yoga, my yoga teacher is very strict, my father I am missing because he's in Navy, for years he doesn't come, my mother is strict, and there was a psychological issue with the child. And then the mother says that she had fainting attacks on the roads. She was denial, in the mode of denial, because the father was not, the mother didn't want to say that because I am not able to take care of her psychological needs, that's why the child is suffering. So past history of fainting attacks, which were typically a convergent reaction, and now this fictitious purpura. So this child doesn't need an NGS, doesn't need anything else. This is simple clinical diagnosis. That's why I would end to say that clinical diagnosis is irreplaceable by any amount of laboratory tests, including an NGS. So this is fictitious purpura, and once you see one such case, you will never miss them in the diagnosis when they come next time to you, a similar case. So what have we learned today? It's an evolving science as far as the genetic diagnosis is concerned. Review results periodically as new evidence becomes available, like the child with hemoxygenase deficiency was known only after 2 years. If you have a VUS which is fitting into your clinical diagnosis, but it is labeled as VUS because such mutation is not available in the database, you should report it to this ClinVer database. ClinVer database, you go upload, you can't do it individually, your institute has to do, and they will acknowledge it and they will keep it. And when they find such 4 or 5, it will be lot sort of rehearse and research, and they may add that as the pathogenic variant for the future. Useful if used judiciously, waste if used indiscriminately, dangerous if used without indication, and clinical approach is still a gold standard. This type of genetic test will only help you come to a conclusion after you have exhausted all your available ways of diagnosing a rare disorder. So children are small bundles of joy, and they come in all sizes and shapes. These are many children who have treated. Some of them are leukemic, some of them are hematological disorders, some want to become doctor, some want to examine you, they send you all types of messages, they write a big beautiful poem when they are discharged, and so on and so forth. And you cannot learn anything without your teacher. So the very famous is Bin Guru Gnan Kahan Se Pau. Dr. Karim Boy, who is the teacher of teachers, the first board certified hematologist, oncologist of the country. I had the fortune to work under her at Wadia Hospital. She would literally take our hand and make us see the patient, see the smear on the bone marrow and smears on the microscope. And she was a wonderful teacher. She's no more. If she was alive, she would have been 99 or 100 years today. And Dr. Lokeshwar, who was my first teacher and guide. So I always say that you need to, if you want to come up in life, you need to have a very good father, father-in-law, or a godfather. So I had a very nice father, a very nice father-in-law, and also a very nice godfather. As Gandhiji said, to give pleasure to a single heart by a single act is better than 1,000 hands bowing in prayer. So you may not pray, but help some patient, help someone in your life, help any person who is in need, and that will be a much better way of going near the God than just merely praying in front of a stone idol. And the best way to find yourself is to lose yourself in the service of others. Thank you very much for your patience.
Thank you, sir, for such an eye-opening and brainstorming treat. It was a great pleasure. Now, Dr. Sachin Patil, sir, will do the citation for Dr. Nitin Shah. Awards for Best Paper and Poster will be awarded after the felicitation ceremony.
Thank you, madam. Respected Nitin Shah, sir. After completing your graduation and post-graduation from the prestigious LTMMC College in Mumbai, you choose to embark on a private practice in pediatrics. Despite the demands of busy practice, you maintain your academic interest, which lead you to pursue your passion in hemato-oncology and vaccinology. You were honored with the IAP Trainee Fellowship in Hematology, marking the beginning of your illustrious career in pediatric hemato-oncology. Over the years, you have become one of the most renowned pediatric hemato-oncologists in the country. Sir, you have conducted some of the pioneering research studies on various vaccines in India and are considered an authority in the field of vaccinology. Your in-depth knowledge of both vaccinology and hemato-oncology, combined with your pleasing persona and powerful oratory skill, has made you a highly sought-after speaker at the state and national conferences. You are a remarkable blend of academician, scientist, and practicing pediatrician, consistently promoting a practical approach to the science of vaccinology. Due to your expertise in various subspecialties and your dedication to the cause of Indian Academy of Pediatrics, many leadership positions naturally come to you, culminating in your role as the president of IAP. The series of books published during your tenure have been milestone in IAP's history. Your exceptional organizational skill were evident in the highly successful national conferences held in Mumbai in 2003 and 2007. Your extensive experience and a friendly demeanor make you a strong support for successive office bearer as well as for every member of IAP. We are truly fortunate to confer the late Dr. G.V. Kopikar oration upon you. You are the most successful president of IAP, a dedicated expert in hemato-oncology, an astute vaccinologist, an inclusive organizer, an impressive orator, and an ever-smiling friend to all. Thank you, sir. Citation is drafted by Dr. Rajendra Kulkarni, sir. Now I invite IAP Nasik office bearers and also Team Nashicon 2024 on the stage for felicitation of Dr. Shah, sir. I also invite Dr. Amol Pawar, sir, Secretary Maharashtra IAP, and Dr. Mohan Warke, sir, Treasurer Maharashtra IAP, to join us. Now I invite Dr. Nitin Mekarkar sir and Dr. Deepa Joshi madam to present the paper poster awards.
Thank you, Sachin. Respected seniors and dear friends, we had 40 paper presentation. We reached figure with the hard efforts taken by Dr. Ravindra Sonone sir, HOD Pediatrics, she is working very hard for this conference to make it successful, especially for workshop and the poster presentation. I request Dr. Deepa Joshi to kindly announce the winners of paper
Thank you all. Thank you, Nitin. We have a 40 posters and 22 papers. It was really a tedious job, but thanks to all the judges and senior pediatricians who helped us to come to the conclusion. Dr. Kashyap sir,
Calm your mind
Dr.
with
Tilas sir, Dr. Kasliwal sir, Dr. Girish Shakuntal sir, Dr. Ravindra Sonone, Dr. Sagar Sonone, Dr. Charushila Varke, and many other seniors have helped us to the best paper and best poster prize. At the same time, I am really proud to announce that our Nashicon founder, Dr. Milind Bharadia sir and Dr. Vaishalia Bharadia madam and their family, means Dr. Vishwesh and Ashish whole Bharadia family has announced a best paper and best poster prize in the form of cash. Thank you Bharadia family for this. And now I will be announcing the best papers. 3 prizes we are announcing. First, Dr. Shreya Gaude. Her paper is to study blood culture reports and sensitivity pattern in a neonate of NICU in tertiary care hospital, Dr. Vasantarao Pawar Medical College, Adgaon, Nashik. I request Dr. Nitin Shah, senior pediatrician and hemato-oncologist and vaccinology expert, to felicitate Dr. Shreya. Dr. Shreya is not there, so Dr. Prithvi is accepting in on the behalf of her. The second prize, Dr. Akunuri Karthik. His topic is hemoglobin indices and B12 deficiency in developmentally normal children below 5 years of age, MGM Medical College, Chhatrapati Sambhaji Nagar. Dr. Karthik. I request Dr. Sachin Chaudhary sir, President of Nashik IIP, to felicitate him. Third prize, Dr. Avanti Paranspe. Her article is to study relation between premature rupture of membrane and early onset neonatal sepsis, Dr. Vasantarao Pawar Medical College, Adgaon. I request Dr. Ravindra Sonone, organizing chairman and HOD of the department, to felicitate her. Coming to the poster presentation, first prize, Dr. Amol Shingne. The topic was Schaff-Yang syndrome, Dr. Vasantarao Pawar Medical College, Nashik. I request Dr. Nitin Shah sir to felicitate.
Second prize, Dr. Venkatesh CM from puff of smoke, subtle chugging train in Noonan syndrome. This is from HBT Medical College and RN Cooper Hospital. Barke madam, you can take on the behalf of him. I request Dr. Bharadia sir, founder of Nashicon, to felicitate. Dr. Charushila Varke ma'am is associate professor at Cooper Hospital and she is a guide of the student. She is taking on the behalf of him. Third prize, Dr. Lovina Singhani. The topic was the rare cause of non-spherocytic hemolytic anemia, SMBT Medical College. I request MAHA-AP Secretary Dr. Amol Pawar sir to felicitate her. Thank you so much. We have papers not only from Nashik but from Mumbai, Pune, Dhule, Aurangabad and also from out of state like Bangalore and Chandigarh. Thank you. I over to Patil sir.
I request all the delegates from Nasik IIB kindly come on the stage for the group photo. All the delegates should come.
I now announce winners for various Fit Head to Hit Hair challenges. Winners kindly proceed to the felicitation dais. Maximum plank hold challenge, male, more than 45 years category. Dr. Milind Bharadia, Dr. Mahesh Siddeshwar. Males,
Yes, important announcement. Winner for the sports event of Nashicon 2024, maximum plank hold challenge. For male category above 45 years, Dr. Milind Baradia sir, Dr. Mahesh Siddeshwar sir. For below 45, Dr. Amol Murkute, Dr. Sagar Bhalerao. Push-up challenge in 1 minute. Males above 45, Dr. Mahesh Siddeshwar. Below 45, Dr. Amol Murkute. Female, Dr. Rajashri Pathak, Dr. Shalaka Bagul. Requesting all winners kindly proceed to the felicitation dais for their felicitation. Also jumping jack activity, consolation prize, females below above 45, Dr. Sonal Patil. Below 45, Dr. Prachi Birari, Dr. Jagruti Vispute. Plank hold for females above 45, Dr. Rajashri Pathak, Dr. Shalaka Bagul. Below 45, Dr. Jagruti Vispute and Dr. Kalyani Patil. All the winners kindly proceed to felicitation dais as early as possible. We are starting next session. I will request all of you to kindly be seated. Request to all the delegates, kindly be seated. We are starting our next session.
I request everyone to kindly take their seats, please. We are already running late. A very good.
It's a request to everyone to please be seated. We are starting the next session. We have a lot of time to take photographs. Please.
I request everyone to please take their seats. A very good afternoon to everyone present here. It is rightly said, good time flies so fast, and I must say, it has left a very beautiful shadow on our minds with its wonderful lecture. But friends, we are not over yet. For all those knowledge-hungry souls, we have our last but enriching session waiting for you. Myself, Dr. Supriya Dange, and my colleague, Dr. Sneha Dhande, takes a pleasure to be the MOC of this session. Without wasting any more time, I would like to call upon the chairperson for the first session for this lecture, the very dignified pediatricians of Nashik, Dr. Jayant Randive, Dr. Sagar Sunavne, and Dr. Yogesh Patil on stage. Our first topic is about avoiding dysfunction. Avoiding dysfunction in children causes a great level of stress in parents, and this may cause stress in pediatricians too if you are not well learned about it. So to throw some light on the myths and the facts of the avoiding dysfunction, I would like to call the young and dynamic Dr. Nisha Krishnamurthy ma'am on stage.
Thank you so much, and I am very grateful for the opportunity. Today I will just talk to you very briefly about, I'll talk to you very briefly about the avoiding dysfunction, which a topic in itself is a bit difficult because the bladder has not been something which we understand easily. Treating it is So the bladder is not an organ which is easy to understand. It is difficult to diagnose, and probably the most challenging part is treating it. So let's get right into it. So why bladder? Because in children, we expect that the children learn to be continent, maybe from infancy as they grow older by the age of around 4 years, and they have nighttime continence by around 5 to 7 years. And obviously we know that what urinary continence bowel continence. And what does continence involve? It involves that the child has learned to increase or has developed an increasing bladder capacity, has an improved coordination between bladder filling and bladder emptying, and of course change in the frequency of voiding. So this is a chart, this is just for reference, it's what is the capacity as per age, but this is something which every radiologist obviously has with them. Now just a brief overview of the function of the bladder. We all know that it is supplied by the nerves. The sympathetic nerves are responsible, or the sympathetic nervous system is responsible for holding or increasing the capacity of the bladder, and the parasympathetic nervous system is what allows the peeing, that is the voiding function. What is important is that we know that which are the receptors that are involved in keeping the bladder in a relaxed state and which are the receptors that are involved in the voiding function. So coming back to our topic, what exactly is voiding dysfunction? It means nothing other than the bladder dysfunction, which means an abnormalities in either the filling or the emptying of the bladder. Now there are many causes which can lead to problems in either the filling or the holding or the voiding. Now these are for academic interests. Of course, there can be issues in the spinal cord, there could be issues in the anatomical structure, or of course there could be functional motives. Now just as a brief overview, urinary incontinence in children is typically divided as whether it is continuous or intermittent. If it is continuous, we know that it's a pathological issue, and if it's intermittent, it could be functional, then further divided into whether it is a daytime issue or a nighttime issue. And of course, nocturnal enuresis, which is a nighttime incontinence, will then depend on whether there are symptoms which are present through the day as well, or it is just a nighttime incontinence. Now, what do you mean by daytime incontinence? What all is the factors involved in it? You can either have a bladder which is unable to hold on a large amount of urine, so it's weeing very regularly, or it is something in which the bladder is unable to pass urine often enough because it is holding a lot of urine and therefore it's a lazy bladder, or there could be those in which the bladder doesn't know whether to pee or not to pee and therefore a dysfunctional voiding. And of course the symptoms, now why it becomes difficult is that in evaluating a child with bladder dysfunction, we need to understand, because a lot of what we know has to come from within the history itself. Whether the child has difficulty initiating passing urine, the child is unable to hold urine, the child goes multiple times to the bathroom, has got a lot of symptoms of pain and discomfort, or the child practices these holding maneuvers many a time subconsciously without even realizing, or whether they soil themselves. Many a times it so happens that the parents are most discomforted when the child soils himself, because that is what is most obvious, but they may not realize the importance unless we specifically ask for most other complaints. So when we evaluate any child with a bladder problem, we first need to understand a very detailed history as to what exactly are the symptoms the child is suffering from. Secondly, we need to get a very detailed understanding of what is the voiding history. How often does the baby void? How much does he void? What is the water intake? Are there additional symptoms of any bed wetting or daytime wetting, or there's any constipation? These things become a very important role because each has is a piece of the mystery that we need to put together. There are certain other conditions that we also need to be aware of. Of course, the urinary tract infection, vesicoureteric reflux, all of this are important because they themselves either can be a cause or the effect of the incontinence. So just to come to a case of an 8-year-old boy who has increased frequency of urine. Now when the parent comes to us saying that my child is passing a lot of urine, first we need to understand whether it is just that he goes to the bathroom many times, or does he go to the bathroom and pass small amounts of urine or large amounts of urine. Therefore we need to understand with a voiding diary whether the child, how many times does he go to the bathroom, how often does he void, and how much does he void each time. So typically an 8-year-old child is expected to have a bladder capacity, if we use the formula, of around 8 plus 1 into 30. And we see that in all this, the boy is practically voiding much lesser than what we expect him to be able to hold each time. And he's voided about 11 times. And we've also noticed that he's got a complaint of incontinence. So all put together, this could be this looks like a bladder which is unable to hold a large amount of urine, therefore needing to evacuate very frequently. And there have been those episodes in which he's unable to hold the urine, so much so that he's actually wet himself. So this is under the broader heading of an overactive bladder, where then there's this contractions of the bladder muscles that are going on even during the filling phase, wherein the child is unable to hold, or the bladder is not compliant enough to hold the urine. And this hallmark symptom is the urgency, where the child has to absolutely rush to the bathroom to pee. Some of them may have maneuvers because they try to protect themselves from embarrassing themselves by soiling in their clothes. Associated, they may have complaints of fecal incontinence or constipation as well. Now, how do we treat? Typically, these children need to be taught about the importance of an adequate water intake, which means around 50 to 70 ml per kg per day for the child. They may need additional pharmacotherapy with anticholinergics as bladder relaxants, allowing them to hold more urine at a time. And of course, when you're giving such drugs, we need to be able to also monitor them for side effects. There are certain other drugs, just to complete the list, we could use tolterodine, sulfanescin, mirabegron, but this is if the usually what we use and most commonly used oxybutynin is not doing its job. Considering a second case of another 10-year-old boy who was brought for recurrent urinary tract infections, when we asked him, he said he's got soiling of clothes and that he has to press his abdomen to be able to evacuate. And he voids just about 3 or maybe 4 times in the whole day, which is very less because we expect that a child would void anywhere up to 7 times in a day, or 3 to 7 times a day. And the uroflow is showing that he's got this interrupted pattern and a large volume of urine that he passes per void. And the ultrasound is showing a significant post-void residue. So when we put all this together, it definitely looks like this bladder is behaving very lazy and it's being able to hold a large amount of urine, which typically occurs because of voiding postponement. Children decide not to wee and then they land up holding a lot of urine. And then there comes a point beyond which the bladder, after all, as a muscle, is unable to hold on to any more urine and then just involuntarily voids. This results in incontinence. So in these children, of course, we have to kind of encourage them to drink enough adequate amounts of water. We have to encourage them to not have constipation, and that to go at regular intervals to the bathroom to pass urine, as well as they may even need double voiding. Double voiding is once they pass urine and then they pass urine again so that they effectively empty the bladder. Some of them in which just this much is not doing the job will have to be taught about clean intermittent catheterization, because we need to be able to prevent them and keep them infection free, because the biggest disadvantage or the biggest trouble these children will have will be, of course, frequent urinary tract infections. Coming to a third case, if we talk about another similarly 8-year-old boy who has come with repeated urinary infections, and when we asked him, he says he's got lower abdominal pain, he avoids voiding, he's got some maneuvers that he does, and a lot of urgency, and sometimes there is incontinence as well. So when we got an ultrasound done, that shows a thickening of the bladder wall, which means that the bladder muscle, like in any other muscle, has been overworked for some reason. A uroflowmetry is showing a pattern in which he passes urine, stops, passes, stops. Such a pattern is called the staccato pattern. And the MCU is showing a very dilated urethra as well as some significant post-void residue. This is typically what we call dysfunctional voiding, wherein there is a dysfunction in that the bladder and the sphincters together are not able to understand whether they want to keep the urine or they want to discard the urine, because the detrusor is contracting but the sphincter is not relaxing enough. When this happens, and both of this happen at the same time, the urine comes out in fits and starts. It's also possible that these children may have associated constipation, which obviously has to be looked into. A very serious form of this is called the Hinman-Allen syndrome. Now, typically in these cases, they would come to us because of a urinary tract infection, of course, which needs looking into. It has to be managed. They may need prophylaxis for a while. The constipation has to be looked into because no treatment of bladder is ever complete without addressing the bowel issues as well. They have to be taught to void at regular intervals, and they have to be actively taught exercises to relax the pelvic floor, and they may also benefit from certain drugs like the alpha blockers so as to be able to relax the sphincter. So just as an overview and for an easy way to remember what are the bladder issues that we usually face, we can either have an overactive bladder, we have an underactive bladder, or we have a dysfunctional bladder. Obviously, these things are much easier said than done. It is easy to label the bladder and try to put it under these pigeonholes that they will each time behave as this, but let me tell you, it's not as simple as that. However, if we get a detailed history and we get a sort of some additional support from our investigations, it definitely helps. So no topic of bladder dysfunction is ever complete if we don't talk about nocturnal enuresis, which I'm sure most of you must be seeing as part of your pediatric practice. Nocturnal enuresis can be those in which children have just not learned to get nighttime continence and they've always been wetting in their bed, which means it's a primary nocturnal enuresis, versus those who have developed a fair degree of continence but however have lost that after a period of 6 months of having achieved it, probably because of some secondary causes, maybe infection, maybe some psychological stress, etc. And some children may not only have a nighttime incontinence, but they go on to actually have daytime symptoms as well. And it is important for us to figure those symptoms because unless you fix the daytime issues, you're very unlikely to be able to achieve successful improvement in the nighttime symptoms. Now, these monosymptomatic events are the ones that we discussed before. Most of these complaints can occur during the day and some children are aware, some aren't. But what we must understand is for a successful treatment of nocturnal enuresis, we need to know whether there are certain other factors which come in the way of that. For example, if there is a maturational delay, if there are some genetic issues, or if there is some other problems like sleep apnea or they've got diabetes mellitus, these are the kind of problems wherein unless we address those, we're unlikely to get a satisfactory resolution of the nocturnal enuresis. So just to give you an example, a 7-year-old girl who's got the complaints of wetting her bed almost every night, she doesn't have so much of a daytime urgency or other symptoms during the day. And she only wets the diaper, but as she's growing older, obviously it's become a bit of an embarrassment for her. If we look at her voiding diary, we see that that's where I've just highlighted it, towards the evening after 6 o'clock, her water intake is much on the higher side. Obviously, she's taking in a lot of water which she is not able to clear before going to sleep, and hence she's wetting her bed at night. There is another similar story which you may see in your patients in which they may not be drinking so much water towards the end of the day, but they pass large amounts of volume at night and their first morning void is a very large volume. So this typically happens because of nocturnal polyuria, which is thought to be because of a relative deficiency of the antidiuretic hormone. So the children are making a lot of urine and they also tend to be the ones who are deep sleepers. But of course, we're not going to wake up children who are not peeing, so we would not know the others are or are not deep sleepers. But then this combination is always seen. So in two types of children, one who's just drinking a lot of water in the evening, you might probably be able to solve your problem by rearranging the volume of water that they take during the day and concentrating more of it during the morning hours as compared to the evening. And in the second case, where they're making a lot of urine, we may be better off if we try giving drugs like desmopressin at the first attempt because they are polyuric and hence likely to respond to desmopressin at bedtime. However, I must say that desmopressin is some drug which will work for as long as you're giving it, but once you stop it, the chances of relapses are fairly high. So what would help is an alarm therapy, which is obviously difficult to do in these children. Because it's not comfortable that every night they have to strap the alarm on themselves. They have to be taught that when the moment you start peeing, the alarm rings, the child has to get up, has to be fully awake, has to go to the bathroom, complete the void, come back, change their clothes, ensure that their surroundings are cleaned and then go back. The alarm therapy will work only if this whole drama is done, because the whole point is that the child has to be made aware of the sensation of the bladder filling before he actually voids. So the alarm therapy requires a great deal of dedication from the child, the family and everyone else. But having said that, if that much hard work is put in, the outcomes are obviously better because the child has learned to sense the bladder fullness as against just being dragged to the bathroom and made to pee. So any therapy for the matter, may it be alarm therapy, may it be desmopressin or any other immune therapy, drug therapy that we give, we have to understand that there are no overnight answers. Whatever it is will take us some time, maybe upwards of 3 months. But if we are able to have the compliance and dedication to follow it through, likely that our chances of success will be much higher at the end of it. So what we have to understand when we are managing nocturnal enuresis, that it's not easy. Please set your goals with your parent and with the family and the child as to what is it that they're expecting in the form of improvement. Is it just that they have a sleepover or they're going to stay with their friends and they need to have one night where they're not going to pee, or they want a long-term solution, or what is it? Because unless we address that, then we may not match the expectations that the parents might have of us. So desmopressin as a drug, yes, very effective. There are dose ranges. You have in either in the tablet form or the melt that is available. It has to be taken 1 hour prior to going to sleep. And of course, we need to keep a track of how much water we're going to drink so we don't inadvertently land up with hyponatremia or some such. It works very well, and it's especially good for certain events. Suppose a child has to go for a sleepover or a slumber party or something, the desmopressin works very well. But it's always better to have started the therapy 2 weeks prior to such an event so that we know that by the time the child is gone for the party, they have obviously achieved a good enough control. Rarely, of course, there are drugs, but this is more to complete the list. I would not want to put any child on imipramin given the effects and more importantly, the side effects of it. Lastly, just to complete the list, let's talk about refractory enuresis, which means you have tried the alarm therapy, you have tried desmopressin, you may even have tried imipramin, but you're not getting where you want to be. That's probably one of the reasons could be that A, we have missed out on a different daytime issue which we have never addressed, and having said that, if you have not addressed that, you're unlikely to have success here. There may be certain other differentials which we have probably missed and we have just been put on blinders and only looking at the enuresis. And lastly, maybe there was non-compliance. I have told them that a certain tablet or medication is to be taken in a certain way. If it's not been done, we need to rule all of that out. And then maybe as an attempt to treat it, if we were to try combinations of the above mentioned therapies, we may be able to achieve success at the end of it. So that was kind of a brief overview into the topic, which is not, I know is not easy, but thank you for your patience. Thank you.
Thank you, madam, for your simplified elaboration about these functions. Like one is, you told us about overactive bladder, one is underactive bladder, and I will say one is functional obstruction.
Absolutely, absolutely.
And the third one is enuresis.
Right.
Very difficult to treat enuresis.
Yes.
The positive reinforcement does
Makes
help.
a big difference. Make a big
A calendar
difference.
method you can use like to mark and then to
It makes
give
a
him
big
best
difference.
wishes.
Yes.
Madam, just wanted to ask one question
Yes.
about urodynamics.
Right.
Are they required?
So yes, urodynamics definitely has a role to play, especially in certain children where we are suspecting, suppose we want to have a neurogenic bladder, we want to understand what is the status of the compliance, what is the status of the bladder filling pressures. Sometimes we have children with PUV, we have children with VUR who even after you've treated those conditions, we realize that the bladder is really not behaving. And sometimes in places where we need to, we're not getting a clear picture just on the history and we want to understand exactly what's the mechanics going on, urodynamics definitely, although invasive, has a ton of information that will help us. Uroflowmetry is a more easier and probably a shorter and simpler version to get most of that info, but if that's not satisfactory, then UDS is absolutely the way to go. But the only, just one last thing, the only way issue being that you can't do UDS in smaller children, so you'll have to wait for the appropriate age of 6 and above for that.
And one was about voiding diary. That was
Yes,
it.
voiding
And
diary
it
is
was
very,
it.
very important. Yes.
Thank you.
Thank you.
ma'am.
Thanks a lot.
Thank you, ma'am.
So these are available, although less available, but in Bombay at least I know that there are these chemists who do provide the alarm systems. The cost of which, I'm sorry, I don't remember the top of my head, but the alarm systems are available. No, it's not. And sometimes I think it's kind of worth investing in it because enuresis is not a problem that can be sorted with drugs. So it probably makes sense, or when you talk to your parents, you could probably reinforce them to invest in an alarm system because it's more likely to have a positive impact and a long-term solution to a problem which is extremely embarrassing to a child as they grow up. But the alarm system, of course, where you put in a sensor on the underpants, pull up the wire and put on the alarm sound near the ear, somewhere on the shoulder, you strap it on, and that has a system to turn on and off. So when the child just starts, as soon as there's initial few drops of urine, the alarm rings. The important thing, and the alarm system is going to be successful if the child gets up and turns it off. The whole point is that the child is awake because they are deep sleepers. We need them to get out of that, and not that the parent, because they can't tolerate the sound, is just shutting it and moving on. So that's the difficulty. But the whole setup comes in a package. There are certain companies that are even making it available. I'll send you the names. I can do that. Yeah. Thank you. Thanks so much.
Thank you for such an enriching session on voiding dysfunction, ma'am. I request our speakers and chairpersons to kindly proceed to the felicitation dais. Our next session is on basics of bone marrow transplant. Let's quench our thirst of knowledge regarding the minutes of BMT from the renowned speaker, Dr. Preeti Mehta, Senior Consultant Hematology Oncology BMT Unit at NHSRCC Children's Hospital, Mumbai. I now invite esteemed chairperson for the session, Dr. Nitin Birla, Dr. Prachi Birari, Dr. Sonali Pardi onto the dais. Over to you, ma'am.
Thank you so much. Which one? Yeah. So good afternoon, everybody. I know I'm standing between your lunch and scientific session, but I'll be there. I'll try to wind up as soon as possible. So I'll be talking about the basics of bone marrow transplantation, and I'm very happy to say that what the Western world has been doing, we've been quickly catching up with this in our country, and we are doing a lot of transplants over the past decade, which is benefiting a lot of children. When I started my journey at Wadia Children as a lecturer, I know for the aplastic anemias, we were just transfusing blood platelets and seeing them die over a few years. And now I will show you how things have evolved and how we are able to save so many more lives than what we were around a decade or 2 decades back. So my topic would run across the characteristics of stem cells, the sources of stem cells, the types of transplants that we can do, autologous and its indications, allogenic and its indications, the whole process of transplant and the complications. So when we know the hemopoietic stem cells, they reside in the niche of the bone marrow. Where's the pointer? So as you can see, they reside in the niche of the bone marrow, which we very clearly know. And that is the home of these hemopoietic stem cells, which then further differentiate into multipotent stem cells, and which then give rise to 2 series. One is the lymphoid series and the other is the myeloid series. And from the lymphoid series, we get the T cells, the B cells, and the NK cells. And from the myeloid series, we get not only the neutrophils, eosinophils, basophils, but our RBC series as well and our platelet series. So the myeloid progenitor cells are basically, this is the basis which we need to know, because when a child is engrafting, we know whether the myeloid series is functioning well or the lymphoid series is functioning well or not. Now, when we know these stem cells, they can divide and they renew over a long time, and they are not specialized. So they cannot do specific functions in the body. But they have the potential to become specialized cells like muscle cells, blood cells, brain cells. We have a very limited pool of hemopoietic stem cells in our bone marrow, which is around 1 lakh. And if we have abolished them, we can survive only for 2 to 4 weeks without them, unless we have given excellent supportive care to this child. So as I said, the stem cells can differentiate into any of the cells of the body, out of which it could be red blood cells or platelets. Now, as these hemopoietic stem cells, they home in the bone marrow, they home in the endosteal niche and the perivascular niche, and they have receptors on themselves, the CXCR4, the VCAM1, and these interact with the ligands on the mesenchymal cells of the bone marrow, like CXCL12 and VLA4. So if you want to break this nexus, you have to use GCSF and Plerixafor to mobilize these hemopoietic stem cells from their bone marrow out into the peripheral blood. What can we use as a source of stem cells? We can use the bone marrow as a source of stem cells. We can use peripheral blood. And third, we can use the umbilical cord cells as a source of stem cells. So in our country, most of the times we prefer peripheral blood and not the bone marrow as a source of stem cells.
When we collect the bone marrow, we usually use the posterior superior iliac spine as we normally do the bone marrow, and the maximum that we can collect from the donor is 20 ml per kg and not more than that. Whereas for peripheral stem cell collection, we just cannot say, okay, I take the donor, I put him on the apheresis machine and collect the cells. It's not going to work. I need to give GCSF to break the niche between the hemopoietic stem cells and the mesenchymal stem cells, so they get mobilized. So 4 days of GCSF, if required, even a dose of Plerixafor. Again on the 5th day, I give GCSF, and then we collect the stem cells from the peripheral blood by putting the patient on the apheresis machine. And this whole process takes around 4 to 6 hours to collect the hemopoietic stem cells from the donor. Now, cord blood is a very big fashion of getting the bone marrow stem cells in the Western world. For us, it's not a good option in our country for reasons because we have a lot of infection, and the engraftment with umbilical cord blood takes a very long time. The rate of GVHD is very less because the T cells are very less in the cord blood, but the engraftment takes practically a month. And with the amount of gram-negative infection and sepsis that we have in our country, we cannot wait for 4 weeks for the patient to engraft. So usually umbilical cords are not being used as a source of stem cells. Dr. Revti used to use them years back at Apollo Chennai, but she has also given up. So we don't prefer. In our country, peripheral blood stem cell is the most preferred source because engraftment happens within 2 weeks' time. And it's easier once the engraftment happens, we know that the cells will take over to fight off the infection, if any. So as I said, but the problem with peripheral blood is that there are a lot of T cells. So the rate of chronic GVHD may be a little higher. And when I started the fellowship in bone marrow transplant in UK, I was told that bone marrow transplant is like cooking, and it's absolutely like cooking. You exactly should know what ingredients to put and how much to put to get a good outcome. And so everyone cooks differently, be it US, be it UK, but we have to adapt to our own Indian system to cook better for our patients. Now, if we talk of transplants, it's either autologous, where the patient is receiving his own cells, or it's allogenic, where we are receiving the cells from another person. It could be a sibling, unrelated donor, it could be a parent or a relative, or it could be the umbilical cord. So we all know that the MHC complex is on chromosome 6, where the short arm, the P has the MHC A, B, and C loci, and the DR, DQ, and DPB1 are on the long arm of chromosome 6, and this defines each one of us individually. And if I need a transplant, I have to find somebody who matches my loci. So who is the best donor? A sibling is the best donor for any bone marrow transplant, but every child is not so lucky, and the chances are only 25%. Next is if you find a match-related donor. At times, in less than 1% of the population, the father or the mother is a complete match to the child, with complete HLA 10/10 match or a 12/12 match. But that also is only in 1% of cases. But then what are the other options? We can look for a matched unrelated donor. So our Indian registries, we have the DART3 and the DKMS, where we can look for unrelated donors. But unlike the West, our Indian population is not much geared to opting to become a donor. So the chances of finding a donor on mud or datri is very, very less compared to the Western world, where practically everybody is on the bone marrow donor registry. But there is nothing that a child does not have a donor. Every child has a haplodonor because each parent is a half match for the child. So a child not getting a transplant just because of not having a donor is no more. And believe me, in India, we are doing more half matches, more haplos compared to the Western world, where they prefer doing muds or cords or match sibling donors. So as I talked to you about the registries, but these registries, if you find a donor, you have to pay them 8 to 9 lakhs for the donor. So that is above the cost of our transplant cost, which is anyways very, very high. So if my cost is going to be 20, and if I have a donor, I'm going to be landing up paying 28, 29 lakhs for this bone marrow transplant. But haplo, as I said, is an option. Now, when we look at stem cell transplantation, there are two things which are important in a stem cell. One is the CD34 dose. And what does this stem cell CD34 do? It gives me RBCs, WBC, and platelet engraftment, T cells, B cells, and my whole immune system develops from there. But then along with that go the T cells. Now, the T cells are important because they prevent rejection. They prevent, they give a little bit of graft versus leukemia effect in a leukemic patient, but they also increase the risk of GVHD. So it's like knowing how much of CD34 to put, how much of T cells to put. Do I give any maneuvers to deplete my T cells? With every type of transplant, the amount of T cells that should go in varies. And so the big picture below is saying the proportion of T cells and CD34 cells that should go with every transplant. Now, what is autologous transplant? I am infusing the patient's own cells to the patient. And why do I need that? So in high-risk tumors like high-risk neuroblastomas, relapsed Hodgkin's lymphomas, progressive Hodgkin's lymphomas, anaplastic large cell lymphomas, and difficult to treat brain tumors, we use in the advanced stages is autologous transplants. And so what is done in this is that the peripheral, after the child has gone through the chemotherapy, surgery, radiation, we collect the cells, we subject the child to apheresis after giving GCSF, collect the patient's own peripheral blood stem cells, and then subject him to high-dose chemotherapy. And once we have subjected the child to high-dose chemotherapy, we re-infuse his stem cells to him and wait for the engraftment to occur. The advantage of autologous transplants in these solid tumors is that because it is the own self, they are accepted easily, so there is no GVHD, no other most of the complications except for infection or other complications if you've given busulfan, VOD or some other complications. Otherwise, it's an easier procedure than compared to an allogenic transplant. Now, what is an allogenic stem cell transplant? What are the indications? All leukemias which are relapsed in remission, or certain acute myeloid leukemias who have high risk cytogenetics, CMLs who have gone into blast crisis. So all these leukemias are indications for transplant. Apart from that, myelodysplastic syndromes, immunodeficiency states, definitely the option is only bone marrow transplant. Metabolic disorders, in our country they get diagnosed very, very late, but abroad adrenoleukodystrophies, the moment they are picked up, they are sent across for transplant, where the Lowy score is very, very less. So metabolic disorders, if diagnosed early, picked up early, osteopetrosis, all these conditions can be transplanted at a very early date compared to a late diagnosis. So congenital immune deficiencies, osteopetrosis, lysosomal storage disorders, mucopolysaccharidosis, lipidosis, and something like a Viscott-Aldrich syndrome. If we don't transplant, we don't have an option for further opportunity for this child. He will succumb to his treatment sooner or later. Now, the process of allogenic transplant is similar. We give high-dose chemotherapy. So we collect the stem cells from the donor, we process them in the lab, we cryopreserve them with DMSO, or at times we even give the fresh stem cells. If today is my day 0 of the recipient, in the morning the apheresis, the donor is subjected to apheresis, the stem cells are collected, they go to the lab, we do the cell count, we do the manipulation if required, and in the evening the child receives the cells. Or we can cryopreserve there, where we cryopreserve with DMSO, and then we can use them at a later date if we have planned not on the same day. And then we infuse the stem cells. So the process is basically a conditioning, stem cell infusion, neutropenic phase, engraftment phase, and post-engraftment period. What is conditioning? Conditioning is giving high-dose chemotherapy, where we completely ablate their marrow. We give such high-dose chemotherapy that the cells of the patient, the stem cells, the marrow is completely ablated. So the child is, and so to create space for the new cells, and this is usually done with radiation and chemotherapy. And then we infuse these stem cells. It's just like a platelet infusion. You need to give it over 20 minutes to 1 hour, depending on the volume that you have, and monitor the vitals at the time of the infusion. there are different procedures in which we do the transplant, which I'll come to you later. We pre-medicate them to prevent any adverse reactions. And as I said, the conditioning, there are different types of conditioning. We are using the same agents, but we are using them in different doses. And it's either myeloablative or it's reduced intensity conditioning. And depending on the type of, if I'm transplanting a leukemic child, I have to use a myeloablative conditioning. But if I am using an immunodeficiency, transplanting an immunodeficiency, I cannot use myeloablative conditioning. It has to be reduced intensity conditioning because it's not required. So, but what happens if I'm using reduced intensity conditioning, there is an increased chance of relapse, rejection, or mixed chimerism. So we have to be very careful as to what conditioning are we choosing, what are the doses we are choosing for every type. So every transplant is different. Every type of donor, if it's a matched sibling, if it's the same disease, if it's an acute myeloid leukemia, and there are two patients of acute, one has a complete matched sibling and one is a haplo, my conditioning will completely be different in the two cases. It's not that I can apply the same type to both of them. Now these cells are infused through the central venous line, anaphylaxis, volume overload, and a transient GVHD are possible. The DMSO, if it's a cryopreserved product, then that DMSO can give rise to renal failure. So we have to be very slow. We have to give a double maintenance fluids while we are transfusing the cells, continue with the double maintenance fluids. We cannot give more than a certain amount of DMSO at a time. So now once we've infused the cells, you wait. It's like growing a plant. You put in the seeds, now you're watering them, you're giving them sunlight, and you're waiting for the plant to grow. So we have to tide over this neutropenic phase, which lasts anywhere between 2 to 4 weeks. And that's why we prefer the peripheral blood, because we know in 2 weeks' time, we should have engraftment happening, and that will take over. So if the child has any infection, with the amount of infection that we have in our country, gram-negative sepsis, PBSC is what we normally prefer as a stem cell source, unless required to do a bone marrow. Again, there is a concept that if we do the bone marrow of the donor, of the child who is donating, the parents are like, ye bachcha to acha hai, usko tum bone marrow karoge, fir kya hoga uska? So that myth is still there in the minds of people, and it's very difficult to go beyond that myth, saying that nothing is going to happen to the child. Though we do give GCSF to donors, which is, in our country, there are no norms, no standards established, but abroad in UK, you cannot give GCSF to children less than 18. So that's why they do more of bone marrows and umbilical cords compared to our country. We are freely giving GCSF to our donors. Now this engraftment phase is when the cells start coming up. And believe me, every time the platelets or the white blood cells engraft, it's like we have cleared an exam. There is tremendous pleasure in the transplanter more than the patient, because you know that this child is now going to be okay as far as engraftment is concerned. So when do we call that the child is engrafted? When the ANC absolute neutrophil count is more than 500 on 3 consecutive days. And then we know that the child is engrafted in the myeloid series in the neutrophils. The platelets, when they are more than 20,000 for 7 days, in the first 7 days without a transfusion support, we know that the child is engrafted and now will make his own cells. So as I told you, the rate of engraftment is the fastest with PBSC and the slowest with cord blood. Now the post-engraftment phase, it lasts for months to years. And this is the phase when we are weaning off the immunosuppression. And when to wean depends again on the condition. In leukemics, we wean off the immunosuppression in 3 months. But in an aplastic, we will wean only after 9 months, 10 months. In a thalassaemic, we would wean after a year. So again, the strategy is different for each one of them. And how do they immune reconstitute? The first is the neutrophils, the NK cells, and the monocytes to come into the system. And then that is followed by the CD8 cells, the CD4 cells. And the B cells are the last one to come in. In an autologous transplant, they come in after 6 months. And in an allogenic transplant, they come in after a year. So basically, the child is still immunosuppressed for 1 year after transplant. And that's why we continue ACVR for 1 year after post-transplant, because they're still prone to infections. Now, what are the complications? Can I take 5 minutes more? Sorry? 1 minute. I'm sorry for the slow this. So the complications are the complications related to the chemotherapy and radiotherapy. VOD is a very significant complication, sinusoidal obstruction syndrome. TATMA, it's something like you see in HUS. So TATMA is another big complication. And then pulmonary complications. GVHD of the lungs, you know that the child is we are going to lose the child sooner or later. It's like trying to cure the child of one disease and giving another disease. Graft failure is a nightmare. And GVHD is also, the chronic GVHD is also a nightmare. Acute GVHD is not so much of a nightmare compared to a chronic GVHD. So these are the post-transplant infective complications that can happen. You have to tackle all the viruses, bacteria and fungi. And so to summarize, every child has a donor for a transplant. So no child should be refused a transplant. Timely referral benefits the children. And I'm more than happy to share these 3 children where the first one was an acute myeloid leukemia with FLT3 ITD, high-risk cytogenetics, with a mad sibling whom I transplanted, doing very well 5 months post-transplant. The second is a 17-year-old thalassemia major child who has also done engrafted, doing very well, sent home. The third one is a T-cell replete transplant, half-match haplo, severe aplastic anemia child, who is now doing pretty well, no problems, no GVHD. So there is a sense of satisfaction that aplastic anemia is also treatable, and the parents were so happy to see the normal hemoglobin and normal platelets after so many months of transfusions. Thank you.
Thank you so much, ma'am, for the wonderful session. Now I request our chairpersons to kindly accompany ma'am to the felicitation desk.
Ma'am, your take on transplant in sickle cell disease, like do we need to get the candidate as a transplant candidate right at the beginning of diagnosis, or can we have the conservative, like are there any criteria where?
Yeah, so fortunately in our country, sicklers are not very difficult to treat because they are well managed with hydroxyurea. They are not the severe sicklers. But if they are, like in UK, I saw a lot of sicklers who were from the African descent basically, and they had severe sickling crisis. So if you have neurological complications, or you have severe sickle cell who's coming with vaso-occlusive crisis at least three times in a year, not managed on hydroxyurea, who is having acute chest syndromes, repeated infections, and definitely you should transplant. Though I must tell you, to transplant a sickle cell is the most difficult thing to do, but then still they should be subjected to transplant.
Thank you, ma'am. One special announcement. We are hosting AdolesCon 2024 conference in Nashik from 27th to 29th September. Nashicon delegates will get 20% discount on present registration. That is, instead of 7,000, 5,600 rupees only for today. So our next topic is conjugation with right partner. I know, like me, everyone is confused at what it is about. So to get our doubts clear, today we have with us the very jolly, the very knowledgeable, the legend, Dr. Pramod Jog sir with us. And I invite the chairperson for the next lecture, Dr. Raghunath Hagmane, Dr. Vinod Shelar, and Dr. Yogesh Badane on stage.
सुरू करायचं ठीक आहे ओके ठीक आहे Hello. Okay, so good afternoon, friends. We have a talk on conjugating with the right partner, and as the compare said that there is a confusion about the title. Don't be confused, it is about the vaccines, and it is about the conjugating vaccines, and what is the right conjugating protein, that is the topic of discussion. But just to arouse the interest, the title has been given by Dr. Jog as conjugate with the right partner. Of course, it is important in real life also, but we will see some aspects of it when we discuss this topic. Anyway, so in this first introductory slide, you can see that Dr. Jog has been written as a member of IAP, and IAP is in red bold letters. That is because I will be speaking for intelligence wise average pediatricians. So that is the full form of IAP, remember. Okay. Some of the lectures were, very, high funda type, so that was for super intelligent pediatricians. So this will be very basic. Okay. And I was involved in the review of the papers which are submitted for WHO for the typhoid vaccine long back in 2018 and 19. At that time, this typhoid conjugate vaccine had recently, been submitted at that time to the WHO. Anyway. Okay. So why this typhoid vaccine is important, that is, one must remember that out of all the cases of typhoid which occur in the world, 30 to 40% cases occur in India. Okay. And XDR, that is extended drug resistance for typhoid, is increasing. I will tell you more about it. What is usual response, that is ampicillin, cotrimoxazole and chloramphenicol, which was given up to 1989. Okay. Later on, you know that these three basic drugs, there was resistance, and then ciprofloxacin came into picture. Afterwards, ciprofloxacin also went out of the picture, and then we had ceftriaxone. So these have been the different stories in relation to resistance to this typhoid. And then this particular Bharat Biotech, which manufactures typhoid conjugate vaccine, has been in the forefront of manufacture. That's why, we should be proud because it's an Indian company. That's why I have written that it's Mera Bharat Mahan. And then most of the other vaccines now, like rotavirus, pneumococcal, pentavalent, all they have been taken up by the government. So B&B stands for bread and butter. So some vaccines only now are in our kitty. They are typhoid vaccine, influenza vaccine, hepatitis A, chicken pox. Okay, so we should know a lot about these vaccines. Okay, now we should remember this particular mnemonic whenever we discuss any vaccine. So first is the need of the vaccine, as to why this vaccine is needed. What is the efficacy of the vaccine? How safe is the vaccine? How cost effective is the vaccine? How affordable is the vaccine? How feasible it is for the immunization schedule, and how ethical it is to give recommendations about this vaccine. Okay, all of us are aware of the typhoid Mary. Long back, right from our school days, we know that she was a waitress and she had infected many with typhoid. So that's the old part of the story. But typhoid vaccine actually came into existence in 1896 when the soldiers from the British Army, which were Indian soldiers, almost 283, 2,835 volunteers from the Indian Army were given that heat-killed phenol-preserved TAB vaccine. Some of you who were there in 1980s or maybe earlier than that, when you used to go for swimming, must have received that vaccine. That was very painful. After 1989, this vaccine was withdrawn because of the reactogenicity, and at the same time, newer vaccines had started coming into market. Some of you might remember the oral live vaccine which was there, which is not available now. So this particular typhoid vaccine, which had Salmonella typhi, paratyphi A and B, that's why it was called as TAB vaccine. But now it is no more available because of the reactogenicity. So what is the importance of knowing about typhoid? Because it's an endemic disease, it's all over, but it has an epidemic potential. Suddenly an epidemic might come up, and children are the major sufferers. Remember, children have the highest incidence of typhoid fever in India, and I am sure those of you who have passed out from BJ Medical College in Pune, they have seen so many school-going children, particularly those between 5 and 15, and at other places also. So it was thought to be a disease of older age. But the point is that 27% of the typhoid cases occur in children who are less than 4 years, okay? And the mortality is higher in younger children. Those who have age less than 9 years, they have the highest mortality rates. And remember that typhoid fever in children less than 2 presents with non-specific symptoms. There is only clinical suspicion. It may come as fever going on for a long duration. Some of them may come with respiratory infections. Some of them may come with urosepsis. So there are varied presentations, okay? And that is the reason for recommending the typhoid vaccines for children under the age of 2 years by WHO and our IAP ACVIP. That is the Advisory Committee on Vaccines and Immunization Practices. So I was trying to tell you about the Diwali which I could not celebrate. In 1989, I told you I had been to Shirampur where there was a epidemic of fever going on for a long time and nobody knew what is going on. People were giving chloramphenicol, but after that, people came to know that it is no more responding to chloramphenicol. At that time, ciprofloxacin came into picture. In 1990, it was Dombivli, where it was called a Dombivli fever for a long time, but it was again proved to be chloramphenicol resistant enteric fever. And after 2000, you all know that ciprofloxacin resistance has come up, and almost 80% in the pediatric age group are now resistant to fluoroquinolones. Now, antibiotic resistance is very important for typhoid, Salmonella typhi. So right now, MDR typhoid, what is MDR? Resistance up to chloramphenicol and ciprofloxacin, that is, less than 10%, but ciprofloxacin resistance, as I told you, is quite high. And fortunately, there is no resistance to the third generation cephalosporins in India. But you will be surprised to know that there is emergence of the extensively drug resistant XDR typhoid, and you will see that this particular resistance to all the recommended antibiotics, that means first line, I told you ampicillin, cotrimoxazole and chloramphenicol, plus the fluoroquinolones, plus the third generation cephalosporins, that is called as XDR. And in 2016, that is on from 9 December 2018, there were some 5,274 cases of XDR in Pakistan. You remember what happened in 2016 November? Most of you have forgotten. But remember in the same month, there was demonetization which was declared by Modi. So that resistance by many started there. But remember, I think most of you have forgotten. So remember that. So typhoid vaccination is one of the important ways. So when you give the vaccine, you are not worried about this XDR typhoid also. Okay. What is the situation of this XDR, extended drug resistant typhoid in India? Remember, it is found in sporadic areas, some areas of Delhi, some areas of Punjab and others, and there is some genetic basis for that. So with that, now let us come to typhoid vaccines. Now we know the one N from the Nescafe, that is the need, we are already now discussing. So it is definitely needed because I told you it has a lot of morbidity and the drug resistance is increasing. So if you immunize children in the childhood, they will not be exposed to typhoid. Okay. So typhoid vaccines are of two types, parenteral and oral. I told you oral one is not now available, and the parenteral has been in two forms. One is the polysaccharide, another is the conjugate vaccine. And the conjugate vaccine depends on what is the conjugating protein. Okay, so either it could be TT or it could be CRM197, and we'll see more about it. So this is the typhoid bacillus, Salmonella typhi. Now the terminology of Salmonella typhi also is changing, and it is now called as Serovar enterica. Okay, so you can see that in this particular picture, this Salmonella has flagellae, and those flagellae, they have that H antigen. The body antigen, central one, is O antigen, and the capsule has VI antigen, that is the VI capsular polysaccharide. Now what is the purpose of this particular VI polysaccharide antigen? Remember, it is like a bulletproof. Imagine a soldier and he is trying to fight in the army. So if somebody throws a bullet onto his body, that bulletproof jacket will not allow the bullet to kill him. Similarly, the Salmonella uses this VI capsular polysaccharide as a bulletproof jacket. Okay, and what happens is whenever you say eat or drink something which is contaminated with Salmonella, the Salmonella enters into the body and the body tries to produce antibodies, but these antibodies, they are not able to destroy the Salmonella. When you give vaccine, Salmonella typhi, which enters into the body in the form of the vaccine antigen, the antibodies are produced, and these antibodies destroy that VI bulletproof jacket, and that is why the salmonella is killed. So remember this VI antigen, though it is like a bulletproof and it protects the bacteria, the antibodies, they remove this coat so that the bacteria can be killed easily. So remember that capsular polysaccharide is very, very important. Now it is the story of a daycare center. I will just tell you what is the basis of this particular vaccine. Okay. So remember or imagine that there is a daycare center. मराठीत आपण पाळणाघर म्हणतो तसं. Okay. So in this daycare center, there is a caretaker. I have made that letter C in red color. So that lady who runs that daycare center, she is unable to control all the children under the age of 2 because they are very naughty. They are, fighting with each other. They are pissing anywhere and beating other children. So, the caretaker is very, very, very harassed. So she says, let me take some partner with me. Okay. So she brings another partner, that is P. Okay. So why C and P are in red? Because the capsular polysaccharide initially was used to prepare or manufacture the vaccine. So the vaccine was against the capsular polysaccharide. Polysaccharide means a carbohydrate, and carbohydrate antigens are very poor immunogens. They are not good immunogens. That means the immunity produced by the capsular polysaccharide carbohydrates is not good. When you combine carbohydrates with proteins, the combination or the conjugation, which is the topic of today's talk, that conjugation gives additional properties to this particular vaccine. What happens is that when you combine carbohydrate polysaccharide with some other protein, the conjugate becomes such that when you inject it, the immune memory, the immune response becomes very, very good. Why it becomes very good is shown in this particular picture. You may find it difficult to see from a distance, but just see that in the center there is a T cell. Okay, just look at the T cell. So whenever you give a conjugated vaccine, the system first stimulates the T cell and finally the T cells end up in producing B cells, which are the forerunners of antibodies. So the vaccine becomes a T dependent vaccine. But when you give only the carbohydrate polysaccharide vaccine, they directly stimulate the B cells without stimulating the T cells, and that is why the B cell stimulation only produces antibodies without memories and without a good immunological response. But when you combine it with the protein, the complex, the conjugate of carbohydrate and protein together makes the vaccine very, very good, and the immune response available is very, very robust. And you can give these conjugated vaccines to children under the age of 2 years. Polysaccharide vaccines cannot be given to children under the age of 2 years. So remember, there are some basic differences which I will tell you in a table. So why to conjugate a vaccine? See, on the first table, I have shown that this polysaccharide, VIPS means the VI polysaccharide vaccine. So it stimulates only the B cells. So the antibody titer is low. The quality of the antibodies is also low. That is called as avidity. I will explain it to you again. The cell mediated immunity is absent, and the duration of response is short-lived, the memory is poor, booster response is poor, and it is useful only for children above 2 years. While typhoid conjugate vaccine, TCV, that is the second column, where it stimulates both the cells, B and T cells, and it is a T cell dependent B cell stimulation. The antibody titer is high, the quality of the antibodies, which is called as avidity, that is also high, the cell mediated immunity is present, the duration of response is long-lived, the memory is strong, the booster response is strong, and the effective age is above 6 months. So these are the important advantages of a conjugate vaccine. So why to conjugate that is the answer in this slide. So the VI conjugate vaccines have a better efficacy. Okay. So single dose of typhoid conjugate vaccine has almost 81 to 88% efficacy in children, and polysaccharide vaccines have hardly 31 to 57% efficacy. Now, that is the reason why IAP has recommended this vaccine between 6 to 9 months of age. Why in the younger age? I told you, because the disease is seen even under the age of 2 years. And along with MMR and other vaccines which are given at 9 months, this typhoid conjugate vaccine can very well be given. Okay? And WHO also has recommended this particular vaccine. Now let us see, this is the story of the marriage of Vidya with Tatya. This is only for you to understand the topic. Why Vidya? Because Vidya has those two initial alphabets V and I, that is the VI capsular polysaccharide. And she is to be married with Tatya because it has two, T and T. Okay, let us take that T is a teacher Tatya, okay? And Vidya is, you know, the one who has recently passed MBBS, and now she is going to get married to Tatya. Now why I have put up this, because when you marry, rather when a girl marries a boy, there are certain things which are seen. So you have to see the purity of Vidya and Tatya. The Tatya is, you know, a very good person, Pakka Puneri from Pune, you know, and that's why everybody feels that he is a good person, okay? A pure source of conjugating protein. So the purity is important. Number two, the source of polysaccharide is important, okay? If you take the source of VI antigen from a typhoid bacillus, it's a very, very good source, okay? Then the height of Vidya and height of TT, that should also be matching, okay? That's why this VI 25 micrograms and TT 25 micrograms in the proportion of 1:1 will be a good match. This is called as an intermediate length, okay? So the Vidya's height has also matched. And the way of conjugation, how they conjugate with each other. Of course, I cannot elaborate it more in this talk, but just remember there are methods of conjugation of VI with TT. So remember that this particular combination has some important advantages, and as I will be telling you, these are the advantages. So the purity of the components, the source of the polysaccharide, the length of the polysaccharide, and there are some processes by which conjugation is done. There is a conjugation method. They are the ones which are important when you conjugate. Why I gave you the example is because when you combine this VI with TT, I told you it's a teacher Tatya. See, let us take an example of Vidya who has just passed MBBS and her father says, no, you are directly going to start a practice. She says, no, I want to, you know, earn better so that I will marry someone who is already a teacher. So she becomes T dependent. Remember in life also, when we pass out our MBBS or MD, if we directly enter into the practice, we become direct businessmen. B means business, that is B cell, direct stimulation of the B cells. That is VI, carbohydrate stimulation. But if we also get an attachment with some medical college in Nasik, then we are teachers plus businessmen. So that T dependent practice always is better. So Vidya is wise enough to marry TT, teacher Tatya, so that she alone is a businessman, but with teacher, together the combination or the conjugation has made it T dependent. So the T cells are stimulated, following which B cells are stimulated. Okay, this is only for you to remember. So all these are important things. Let us see the meaning of some of these words which are often used in connection with these vaccines. One of them is immunogenicity, second is avidity, geometric mean concentration, efficacy, effectiveness, and non-inferiority. Just try to understand with an example. You know, just take an example of a boy and a girl who are staying in a society, and every day they are looking to each other from the first floor window, okay? So when they look at each other, some chemical reaction takes place between the two, and this is attraction, immunogenicity. Antibodies are produced. This is one, that is immunogenicity. Now, how strong is the love? How strong are the antibodies to remove that particular bacillus of salmonella? That is avidity. That means in the military, if there are 1,000 soldiers, only 9 out of these 1,000 or 9 or 10 are good, they are fighting. Other 990 are either sleeping or drinking, okay? So they are of no use. Likewise, if there are 1,000 antibodies, only few are functional. So avidity indicates functional antibodies. So avidity of typhoid conjugate vaccine, as I told you, conjugation increases the avidity, okay? Geometric mean concentration is a difficult concept, but just remember, it is the logarithm of the various values which is taken together. In childhood, we used to remember about the arithmetic mean. That means sum total of all and take the average. This is not the arithmetic mean, it is the geometric mean, but also indicates the efficacy of a vaccine. Now, the people from both the sides, the boy and the girl, they come to know, that means the father and the mother, that both of them have, you know, some, you know, attraction for each other. There has been some seroconversion. So let us now decide some date when both of us, you know, both these boys and both the boy and the girl could be engaged. So they decide that on 15th of August, we will have the engagement ceremony, okay? So all the people from both the sides, the maternal uncle, aunt, grandparents, they assemble together. These are the standard people. This is like a clinical trial in a medical college, where Dr. Jog is the principal investigator. He has very good 10-20 students. Now all the clinical condition is controlled, the room is air conditioned, children are healthy. So whenever a vaccine is tested under very, very ideal conditions, that indicates efficacy, okay? Usually in all the countries, efficacy is more or less same, and it is very good. So people say that, oh, the efficacy is 90%, 100%, that is what people say. But when marriage actually occurs, okay, that means initially at the time of engagement on 15th August, The boy and the girl say that, oh, I will live with you for 100 years and there is no problem. So efficacy is 100%. But when marriage takes place on 15th of September after a month, and when the girl comes home, then the blood pressure of the father-in-law starts increasing. Then the fights between daughter-in-law and the sister-in-law and others, they start. The husband starts coming home late. So that is effectiveness, real world effectiveness. The vaccine has been brought into the market, and now the efficacy which was supposed to be 100% has gone down to 80, 70, 60, 50. Okay. So this is the meaning of the word effectiveness. This is very true for some vaccines like rotavirus vaccine, where in countries like US and UK, the efficacy is 100%, but when it comes to India, because of other enteroviruses, bacteria, malnutrition and others, the efficacy goes down to 60 or 50% also. This is only for you to understand. And now when a new typhoid vaccine comes in the market, then the new vaccine has to prove what is called as non-inferiority. What does it mean? The boy, after marrying on 15th of September, on 15th of March 2025, that is 6 months later, says that I no more want to stay with this girl. I am going to give a divorce and I am going to marry someone else. The father gets a shock. He says, what is this? This will not do. You must prove that the new girl whom you are going to marry is non-inferior to the first one with whom you are married. So first prove that she is better or equal to, then only you bring her. Okay, so that is when a new vaccine will come in the market against typhoid, it will have to prove that it is as good as or as efficacious as the one which is available in the market. So these are the various terms which are used in immunology. This is only for you to understand. Now, this vaccine, that is typhoid conjugate vaccine with TT, manufactured by Bharat Biotech as type bar TCV, has undergone extensive clinical trials. Means in various centers all over the world, this vaccine has been tried in thousands and lakhs of children, and there has been a 7-year follow-up for safety and immunogenicity. So these two parameters are always checked. I told you first was the need, second was efficacy, third was safety. So efficacy and safety are always tested in any clinical trial. Okay. So there has been single dose of typhoid conjugate vaccine giving lot of immunogenicity, almost to the tune of 95%, with single dose also. Okay. And with booster there is almost 4-fold rise in the antibodies. And as I told you, the avidity index, that means the strength of love, how strongly the boy and the girl, they love each other, how strong are these antibodies in protecting against typhoid. That is the avidity index, which is also very, very great. Okay. So we have seen about the need, efficacy. Now we'll see little bit about the safety. This is a very safe vaccine and it is very well studied about the safety, and most of the reactions are very, very mild. And there has been a safety study for children between 9 months and 14 years in Navi Mumbai under the guidance of some of our senior colleagues, where almost 1,13,000 children were vaccinated, and only pain at the injection site was one of the minor side effects, and the systemic side effect was fever. And as I was trying to tell you, there have been studies in Nepal and Bangladesh and Pakistan and Malawi and Ghana and so many places where the studies have been conducted, and this particular vaccine also has been tested in what is called as a human challenge study. In Oxford, in UK, there were two groups. One group which was given the solution containing salmonella to people who were vaccinated, and to a group which was not vaccinated. So those who were vaccinated did not get the disease, and the efficacy was 87.1%. This is one of the only vaccines which has been tried in the real life situation. Okay. And Lancet also has given a lot of information and some of these articles related to the efficacy and the effectiveness of the type bar TCV as the vaccine. I told you that when you give this vaccine between 6 and 9 months, you have to also prove that at the age of 9 months it doesn't have any interference with meningococcal conjugate vaccine or MMR, because these two vaccines are also given at 9 months and there has been no interference with the antibody levels of either of these vaccines. So this is safe and immunogenic not only in children but also in the elderly population. And we have to remember, what you should do is, the recommended age is between 6 to 9 months, but in practice what I do, that at 6 months usually children come to us. So I give the first shot of flu, then at 7 months I give the second shot of flu, and then I call them for typhoid vaccination at 8 months. Because if you directly call them after 6 months at 9 months for MMR, then usually there is a dropout and you lose the practice. So what I do is you give one by one. So 6-month completion flu, 7-month completion second flu, 8-month completion typhoid conjugate vaccine, 9-month completion MMR. So like that, you avoid the dropout from your practice. Okay. So I told you that this particular vaccine, which is a vaccine with conjugation with tetanus toxoid, is different than other vaccines available in the market in different ways. And particularly this vaccine can be given even up to the age of 65 years. Okay. Remember that the impact of this particular vaccine has been very wide all over the world and in almost 54 of the Gavi eligible countries. These are the countries which are giving typhoid conjugate vaccine. Now the question is, when you give the first dose between 6 and 9 months, do we really need the second dose? Why this question is asked? Because typhoid is a inoculum disease. That means when you drink any say dirty water or eat food which is contaminated with salmonella, the load of the bacteria is important. So if you have tremendous load of bacteria, that is the inoculum, then the child or the adult is likely to get the disease, and that is why you need to have high levels of antibodies. Okay. And it's a bacterium. Remember, bacterial vaccines are usually not very good immunogens for a long time. But see, hepatitis A, chicken pox, you give even one shot, the vaccine gives protection lifelong. But being a bacterial vaccine, you have to give a second dose, though the recommendation is as of now only single dose. The immunogenicity in different children is also different. So if you immunize 100 children, some of them may develop 50%, some of them may develop 70%, some of them may develop 90%. Okay. And we have seen in practice that typhoid vaccine failures also occur. And this type bar TCV is showing 4-fold rise after the second dose. That is the logic of recommending the second dose. So we need to have a statistically significant reliable data in future so that we can recommend the second dose. As of now, some of our experts, they do recommend the second dose, and we can also give it. The second dose is to be given 1 year after the first dose. Okay. So remember that typhoid fever is a public health problem, and increasing XDR is being noticed, and vaccination is the best way to prevent typhoid, in addition to wash. What is wash? Water and sanitation and hand washing. So these are very important. So if you have not yet taken your lunch, or if you have taken it, see that you wash the hands before you eat the food, because it is very important. And then you should pray Triambakeshwar that I will rather continue to give this vaccine, and let the government get the intelligence of adding this vaccine in the immunization schedule. Though many of us may not like it, because it will take away one more vaccine from our bread and butter, but doesn't matter. For public health, it is very important. Thank you.
Thank you, sir, for this fortifying session, making TCV so easy in such a funny way. I request our speaker and chairperson to kindly proceed to the felicitation dais. Our next session is on approach to primary immunodeficiency disorders in children. Despite major advances in PIDs, molecular characterizations over the last 20 years, many patients remain undiagnosed till severe consequences. To make it simple, from early diagnosis to treating the same with ease, I take the pleasure to invite on stage Dr. Mukesh Desai, sir, who has great achievements in the sectors of inborn errors of metabolism and pediatric hemato-oncology. I also invite chairperson for the session, Dr. Chandrakant Survase, Dr. Sushil Parak, Dr. Nitin Surana onto the dais. Over to you, sir.
Good afternoon, everybody. It's been a very eventful day for all of us, and in the next few minutes I'll try to show you, or maybe discuss with you, a very simplistic approach to primary immune deficiency, which we now call inborn error of immunity. This is the team which we have at Vardhan Children's Hospital. The Department of Inborn Error of Immunity was started by Dr. Zeenat Karimboy. We now have 3 full-time staff, Dr. Vijaya Gauri, Dr. Vaishnavi and Dr. Akshaya. And it's all team effort which I'm going to share and discuss with you. When we started off in 2007, you can see there were hardly less than 100 inborn error of immunity diagnosed. And if you really see the graph which is going upwards, you can see there are tremendous strides which has taken place, and you are seeing large number of patients. We now have more than 480 inborn errors of immunity. So the field has really exploded. Now friends, you all know that it is very vital to make a correct diagnosis, because if you have made a correct diagnosis, you will know a correct way of treating this patient. So let me share with you the story of 2 patients. One is a doctor who at the age of 43 was referred to me for neutropenia with absolute neutrophil count of 100. Now, this gentleman has found to be having neutropenia at the age of 25. He has seen a hematologist who did a bone marrow and diagnosed him as myelodysplastic syndrome. His hemoglobin was normal, his platelets were normal. So it was a unilineage cytopenia. That was the diagnosis which was given. His cytogenetics was normal. He was given GCSF, he responded beautifully and was doing very well. Then he, like a typical doctor, he stopped taking treatment and went to another doctor. And that doctor again investigated, again did a marrow with the same diagnosis, unilineage cytopenia. Right? So when he came to me and I was taking the history, he said, I get stomatitis since ages, I remember, since very early in life. So I thought maybe the neutropenia is not since last 10 years, it is maybe even older than that. And while I was exploring that this could be a congenital neutropenia, I asked him, have you undergone any surgery for heart or anything? So he told me he's undergone an ASD surgery. And that was the clue which told me that he probably has a glucose 6-phosphatase deficiency which presents with congenital neutropenia and have a heart condition. They also have renal abnormality, cryptorchidism and other things. So that told us that probably this is a G6 glucose 6-phosphatase 3 deficiency. The importance of making this diagnosis was that you give him an anti-diabetic drug, empagliflozin or whatever that name is, I find it very difficult to remember, and his neutrophils came to 4,800. So I think friends, it is very important to make a correct diagnosis. A same story, this is a boy who is now 16-year-old. He had cryptorchidism at birth, he had a mitral regurg and a tricuspid regurg at birth, and he was referred to me for a neutropenia. Now he is at Vadia for last 15 years. When you examine him, you will find he's got delayed puberty and he's got very prominent subcutaneous vein. And a history of cryptorchidism and a heart problem. Once again, we thought this is a glucose 6-phosphatase 3 deficiency. We made that diagnosis molecularly and proved and put him on anti-diabetic, with which his neutrophil count became absolutely normal. So this is the power of making a correct diagnosis. Now we started off very early. Where have we reached? This can be told by the story of this particular child. You can see this child was diagnosed as a hyper IgM. He came to us with CM with pneumonia. He was on ventilator and he was subsequently treated. He came out, we confirmed the diagnosis and we sent him for a bone marrow transplantation, which was done at Vardhan Children's Hospital, and this child was cured of his disease. Look at the workload which are now. These are more than 853 confirmed cases of primary immune deficiency since we have started doing the exome sequencing, which I am sure Nitin must have told you has come into clinical practice since last about a decade or so, or maybe even less than that, and it's become really cheap for us to investigate them. Now this is just to show you the sequence in which we investigate our patient. We first recognize a pattern. What type of infection? Is the patient prone to multiple type of infection? Or does he have a limited repertoire of infection? Is he showing a hyper response to an infection? Then we try and identify whether the immune deficiency is hemopoietic or it is extra hemopoietic. Then we do the clinical evaluation, do lab workup, do a workup to find out whether this is one gene with one disease or multiple gene presenting with one phenotype or one gene having multiple phenotypes. And we try and make a molecular diagnosis because we know there are many pathways today which we can interact and intervene by use of drugs. One of the drugs is I can talk about the JAK inhibitor, by which we can modulate the immune system and provide some relief. So some treatment is available for our patients which is possible today in the today's setup. Now friends, I'll take you through what every pediatrician or every physician should know about primary immune deficiency disorder. I think the first step about suspecting a primary immune deficiency is to think of primary immune deficiency. The second step is also to think of primary immune deficiency, and the third step is also to think of primary immune deficiency. In fact, in France, people believe that every child who lands up into the PICU is probably a child who has got an underlying inborn error of immunity. And we may not go that far, but I am sure anybody who responds abnormally to any challenge, infectious or otherwise, needs to be evaluated. So you need to have a very low threshold for investigating or suspecting immune deficiency. Now this is what everybody should know, that child who comes to you before the age of 5 months has either a T cell defect or a phagocytic defect. Patients who have got a hypogammaglobulinemia or agammaglobulinemia will come to you after 5 months of age. I think this is very important, because the maternally transmitted immunoglobulin protects the child in the first 5 to 6 months. We should also know that hyper IgM syndrome can come even before 5 months of age. I think it is important for us to appreciate in the first two patients which I showed you, one doctor who had come at the age of 42, that age should not be a bar for you to suspect an inherited inborn error of immunity. So you must suspect inherited inborn error of immunity at any age. So this is just to show you that the first 6 months child is protected. So the B cell defect come later on. Don't diagnose IgA deficiency before 4 years of age, because IgA takes 4 years to come to normal levels. Please remember, if when you are taking a history, if you file a male preponderance of involvement in the family, you must suspect that this could be an X-linked disorder, because most of the immune deficiency genes, the most important genes, are on the X chromosome. Nature has given a biological advantage to female, and that's why you find this history. Don't forget the X factor, it's very important. So please take a very detailed family history, draw a family chart. I think that is very important, the extended family, because not only it is important for you to know what is the pattern of inheritance, but it would be also important for you to know that which are the patients who, when they go for transplantation, you would select them. Now, human mind is supremely designed to recognize patterns. So when our ancestors, they were lying on the floor and staying on the caves and looking at the sky, they started recognizing patterns in the stars. So that's why we have all these zodiac signs and other things. So we should also recognize the pattern in immune deficiency. So whether this is largely an infectious presentation, or is there immune dysregulation with autoimmunity, multiple autoimmunity, or is there malignancy or an EBV driven lymphoproliferative disorder, or any combination of this. Now you all know that autoinflammatory disorder also is become part of immune deficiency. So if you have infection or what looks like infection but you can't isolate an organism, suspect an autoinflammatory disorder. Now genetically, Mendelian susceptibility to mycobacterial disease is more commonly seen as per our experience in our country, and we recognize that when we analyze our data, a large number of hypogammaglobulinemia were missed in our country, though that is the most commonly available test all over in the country. Clinically, when you are examining a patient, please look at the presence or absence of tonsils. Absence of tonsil can tell you that it could be an XLA or an hypogammaglobulinemia. Don't forget to look at the BCG scar. If there is a BCG adenitis or if there is a BCGosis, you would suspect an immune deficiency. When you're looking at the X-ray for a pneumonia, please don't forget to look at the thymus, especially in an infant. I mean, this might be sound very naive, but if you look at the X-ray, don't forget to look at the thymus. If the thymus is absent, it can just tell you that it is an inborn error of immunity you're dealing with. Please remember, rare diseases are not so rare. Please also remember the rare disease have treatment which is available. It's important for us to make thus an early diagnosis. And you must remember, rare disease come with common presentations. And that's why it is important to pick up rare disease among common presentations of rare disease. Now you can all suspect an inborn error of immunity and suspect that on simple investigation, like a CBC. Please focus on the lymphocyte. If your absolute lymphocyte count is low for the age, and you should have normal values for the age which are published in the Indian Journal, and you can suspect a severe combined immune deficiency, which I think is very important to diagnose early before the child gets infection, and because transplant can cure them. A neutrophil count, if it is low, or if both of them is very low, could have different connotation. I think it's very important to look at the simple CBC. Knowing the organism is very important to suspect an underlying immune deficiency, and I think this is something, try and isolate an organism. If there is infection, try and isolate the organism, which will provide a very important clue to underlying immune deficiency. And I can share you the story of this boy who was referred to us as a chronic granulomatous disease for bone marrow transplantation, but could not go in spite of money arranged because he didn't have a match donor available. And when we re-evaluated this child, we found that his NBT was normal, and then we started wondering what is his diagnosis. And his child had a history of BCGosis, as you can see over here. And this child would come to us with lymph nodes, liver, spleen enlarged. So one day we decided to biopsy the lymph node and send it for culture. And the culture grew an organism which gave us a clue not only to this underlying immune deficiency, but probably also to his molecular defect. The culture grew non-typhi salmonella. So non-typhi salmonella, like tuberculosis, is an intracellular organism, and it is seen in the commonest defect of IL-12-23 interferon gamma loop defect, what is known as MSMD, in IL-12 receptor beta 1, which is what this child turned out to be. So knowing the organism can provide a very important clue. So if you isolate a nocardia, you have to rule out a CGD. If you isolate an aspergillus in a non-neutropenic setting, it is CGD unless proved otherwise. So these are the importance of knowing what organism you're dealing with. As far as the treatment is concerned, if there is a history or a family history of a combined immune deficiency or an immune deficiency in the family, please don't give them live vaccination unless you have ruled out immune deficiency in the newborn. If you have to donate blood or give blood to these children, and if you have suspicion of inborn error of immunity, please irradiate any blood product before you give to this child, because it would result in graft versus host disease. Make an early referral and use a CMV negative, which is very difficult to get. But I think this two important things, no live vaccination and don't give non-irradiated blood or blood product to child in whom you are suspecting an immune deficiency if they ever require blood or blood product transfusion. So in summary, what a pediatrician should know, that inborn error of immunity is not uncommon. It needs a high index of suspicion, may present at any age group. Diagnostic facilities are now very readily available to all of you. You know that genetic tests are even cheaper than doing the workup for immune deficiency. You can get it done for 11,000 rupees. So very often now we get referrals with already a exome done, and then the patient comes to us, now we can't make a diagnosis, please have a look at the child. They are amenable to treatment. That is something which I want to put to you so that you can appreciate is important. Those stories which people used to tell us that, oh, you make this esoteric diagnosis, then what will happen to the child? Anyway, is going to die. Those stories no longer holds true. You can transplant them. You can target a pathway. You have targeted therapy. You can immunomodulate, which can make a big difference to the life of these children. And you can provide genetic counseling. So I think this, so that a subsequent child who is in the family doesn't have the same disease. So if we do a family study of a patient who has a genetic defect which is identified in the family, both of them don't carry the same defect, In that situation also we recommend antenatal diagnosis, because you know that gonosomal mutation is a possibility which you cannot rule out. So let me share with you, I already told you what I want you to remember. So this is all those 7-8 slides which I showed you, which I want you to remember. Now I'll tell you the story of how we got into the picture and what principles we follow at Vardhan Children's Hospital to make the diagnosis of inborn error of immunity. So this is a child which we saw with infections. You can see perianal infection, perforated palate, you can see an axillary infection. But what is striking over here is an absence of pus. In spite of such a large necrotic lesion, the child had absence of pus. And this child had a WBC count which was 90,000. And I'm sure people who have worked in Vadia will tell you, you're dealing with a leukocyte adhesion deficiency. But those days, we were not aware of this. And on rounds, Dr. Karim Boy, who was my mentor and who started this department, she made a very wonderful observation which has remained with me till date and will remain with me forever. She said, you have neutrophils, but they can't go to the site of infection. And that was putting the entire pathophysiological process of leukocyte adhesion deficiency in that one sentence. And that told me that in future, if you don't know the disease, but if you have a patient story, put the pathophysiological process in place, you will ultimately reach the diagnosis. This is the first principle which we follow. Here is the story of another child at Vardhan Children's Hospital. In the very beginning of our, when we started in immune deficiency, patient had a pneumonia treated, developed an IV site necrotic lesion like this, and we are wondering why should it develop, so we biopsied it, and the biopsy showed a fungus, Basidiobulus fungus. And once again we asked this question, why should this child develop an infection with a fungus like this at this IV site? And so we investigated him. It turned out to be a case of chronic granulomatous disease. So this is the second principle we follow. We go beyond the immediate diagnosis. If somebody comes to us with pneumonia, we ask why should this child develop pneumonia? Somebody comes to us with a liver abscess, we ask why should he have a liver abscess? Somebody comes to us with autoimmunity, we ask why should there be so much of autoimmunity and immune dysregulation? And these are two very important principles which we follow. So friends, I haven't yet defined for you what is inborn error of immunity. Well, it can be defined in a negative sense. The absence of immunity makes you susceptible to infection, autoimmunity and malignancies. So this is how we define, but it is now extended. We know that D negative HUS also because of defect in complement regulatory pathway. We take HUS which is because of defect in NK cell pathway. We know that very early onset IBD is an immune deficiency disorder, and we also know that Crohn's disease and autoinflammatory disorders are part of now inborn error of immunity. There is an important other lesson which we have learned is that if somebody comes to you with a severe infection, then the genetics of infectious disease is more the norm than exception, which tells me that you are probably dealing with an underlying immune defect. Another principle which Dr. Karim Boy taught us all the time was that she would say, oh, your patient has come like this, but your patient don't read your books and your journals and come to you. So keep your mind open whenever a patient presents to you. And we have added one more thing, that not everything about all the diseases is yet discovered. So maybe sometimes when you are looking at a patient, you are looking at something which has not yet been described. And this has happened to us in so many situations. So I think these are some very important lessons we have learned. Autoimmunity is a very important component of inborn error of immunity, and you can see various type of autoimmunity which are associated with various immune defects. Vasculitis, autoinflammatory disorder, a classical example is DADA2 because of ADA2 deficiency. The importance of that is that it is amenable to treatment. Vasculitis is amenable to treatment with bone marrow transplantation, and it can reverse the vasculitic process. That is the importance of making a correct diagnosis. Today we know that interferonopathies can also be treated with JAK inhibitors, and it's important to make a diagnosis of that. And patients who have mTOR pathway affection, what we call fancy names if you want to use, you can say mTORopathies or X6 kinesopathies, or you can see tregopathies because the T regulatory pathways are affected. in that situation you will see that there are treatments which are available to us. Well, what are the new concepts in inborn error of immunity? There are tremendous change happening. We feel that inborn error of immunity are very rare disorder, but the new concept is that they may be one of the commonest disorder you may be coming across in your clinical practice. And I think this is very important to understand that instead of rare disease, it may be the commonest disease. If you just go beyond the immediate diagnosis for all your patients, you will realize they are the commonest disease you are diagnosing. They may be more sporadic. There may be very few family history. Even a single episode of life-threatening infection could be a manifestation of inborn error of immunity. Subsequently, at the phenotypic level, you may not find a patient or a child coming with multiple infections. You may find coming with fewer infections, fewer episodes, and it may also be non-hemopoietic in origin. And at the genotypic level, you may find that they may be more autosomal dominant, they may have partial penetrant, and because of that, they may come and present at any age group. So friends, today, conventionally, I can tell you with a lot of confidence that inborn error of immunity, instead of being a rare disease, is probably one of the commonest disease which you come across. If you start looking at them, then you will pick up a lot of inborn error of immunity. I want to share with you one very important thing which I already told you. The simple test gives you the diagnosis. So this is a child who came to us with a BCGiosis, and his diagnosis was in his absolute lymphocyte count. His absolute lymphocyte was only 1700 or so, and normally in a newborn it should be more than 4000. Child is a lymphoid organ, and you could make a diagnosis by just looking at the lymphocyte count. This is a story of an 80-year-old doctor's father who had recurrent nocardia infection of the brain. And I was asked by the physician, what is the treatment for this? I said, have you asked yourself why is he getting recurrent nocardiosis? And when he showed me the CBC, he had an absolute lymphocyte count of only 200. The diagnosis was there for last 6 years, with lymphopenia being there for more than 6 years. So I think people should start looking at the lymphocyte count more closely. Now here is another story of a child who was referred to us at the age of 2 years by a hematologist. This child had a mastoid infection or ear infection at the age of 2 years. The child had a liver abscess with a hepatocutaneous fistula, and the child has again developed a mastoiditis. When you see this story of a liver abscess or a lung abscess or an osteomyelitis, the first thing we say, oh, this is CGD. You have to document an NBT. So we said this is likely to be a CGD. But the child was already worked up, and the child had no diagnosis. So we said, let's have a look at the peripheral smear, because the neutrophils were a little low. So when we saw the peripheral smear, there was 0 neutrophils. So once again telling you that you may have lymphocyte subset analysis, extended lymphocyte subset analysis, you may do an NBT, DHR, flow-based tests, genetics, NGS, but it's more important to pay attention to simple tests. The diagnosis was only in the peripheral smear. He had a 0 neutrophil. This was the case of severe congenital neutropenia. And I'll tell you, he had eosinophils which are present, so that eosinophils in the Coulter counter was reflected as neutrophils. So we were not sure whether the eosinophil can be present in severe congenital neutropenia. So we looked up Nelson, and the Bible says that the first sentence that in severe congenital neutropenia, the neutrophils are low, but eosinophils are present. So just to tell you once again and re-emphasize the power of making a diagnosis. Now this is a girl who had come to us with tuberculosis once, had a post-varicella vaccine vaccinia, and she had come to us with this kind of lymphedema and leukopenia. And when we made a final molecular diagnosis of GATA2 deficiency, the clue was there in the CBC. You see that she had an absolute monocyte count which was low. So if you find any tuberculosis patient and they have monocytopenia, suspect the possibility of a GATA2 deficiency. When you are looking at your total LFTs, when you are paying attention on the albumin, don't forget to look at the globulin. A low globulin in a child was an important clue to tell us that his diarrhea was because of a hypogammaglobulinemia, and that was the clue to diagnosis, which we got on a simple LFT. So pay attention to this small things. Now you all know as pediatrician you are vaccinating all the children, and if you find that there is a BCG vaccine or BCG adenine or the BCG, rotavirus is a live virus. In a SCID child, it can cause severe diarrhea. Then MMR related vaccine defect or fulminant MMR infection, fulminant measles, mumps, rubella infection can be because of defect in STAT2 deficiency or interferon alpha pathway defect. Even yellow fever vaccine will give rise to this thing. So no live vaccine when you're suspecting an inborn error of immunity. This is just to show you a child who was having a severe disseminated BCGosis because of BCG. A child of SCID came to us with diarrhea because of rotavirus vaccine and vaccinia, which is a very important part of post-varicella vaccine in the child. If you give transfusion, you can get a transfusion-associated graft-versus-host disease in patient of severe combined immune deficiency. Well, lastly, before I end, I just want to tell you the principle of genetics of infection in principle of genetics of infectious disease being more the norm than exception was tested when the COVID-19 virus came. You all know that 95% of patients with COVID-19 recover. There's only 1% who land up into the PICU or land up onto ventilator and die because of that. The big question which was asked is that why would this child die of COVID-19 infection? And a consortium of immunologists did whole genome sequence for every child who landed up in the PICU, and they found defect in interferon alpha pathway. And this defect in there are more than 8 genes which deal with interferon alpha production, which was being recognized. And I think this just once again confirmed that if there is any infection which comes to you with a very severe fulminant infection, even a single episode could be a manifestation of life-threatening infection. And I think with this, I would like to end by telling you that in that group, they also found 10% of patients who had antibody to interferon alpha, neutralizing antibody, telling you that you can have an auto-antibody against some of the cytokines which can manifest with disease to you. So friends, I'd like to end this by telling you that immune deficiencies or inborn error of immunity are not any more rare. They are very, very common. If you will look for them, you will find a lot of them. Please go beyond the immediate diagnosis to pick up this diagnosis and investigate them liberally. Don't try to save your patient money, because making an early diagnosis will make a difference to the outcome. It would be also very important to make a referral to a specialist center, because there are now lots of molecules available by which we can target the immune system, we can modulate the immune system and achieve a very interesting amelioration of the patient condition. So with this, I would like to stop at this and take any question if there are any. Thank you very much for giving me a vision here.
So I'd like to ask a question.
Yeah.
So most often in the general pediatrics, we see children with recurrent allergies. How do we differentiate an allergic disorder from an immune deficiency?
So allergy can also be a manifestation of an immune deficiency, right? So for example, you have hyper IgE syndrome, where you can have manifestation with cutaneous, a lot of allergic manifestation, and have immunodeficiency also, right? Now what you are talking about, the respiratory allergies. The respiratory allergies, generally children outgrow over a period of time. If they have real allergy, then it might still be worth looking for an underlying immune defect, especially if they are associated with infection, or they are associated with unusual organisms, or if they are associated with any form of autoimmunity or immune dysregulation which come across. So as I told you, not everything is known. We keep our mind open to all possibilities and investigate the patient fully. One very important lesson which I learned very late in my life, I used to try and save my patients money, Then I learned that if you don't make a correct diagnosis, there is no point in saving patient money. So I stopped saving patient money. In fact, if you come to Wadia children, where the poorest of poor patient care, you see their workup, You'll be surprised at the level of workup which is done for these children, because we philosophically don't believe that we should leave them without a diagnosis. There are very important pathways which can be targeted. Say for example, I'm not really great on the allergy. I don't think I've given you a satisfactory answer, but this is the rough answer I'm giving you. But say for a slow virus infection, JC virus. Now you can target by using a nivolumab, which is a PD-1 inhibitor, which you use for malignancy. And you can emulate, you can have a complete disappearance of the JC virus infection. So you can imagine what pathways you can really go about and target. We had a patient of X-Men disease who had lot of molluscum contagiosum, and we put him on magnesium, which we got on Amazon, found out, and we gave him that formulation. With giving him magnesium, his molluscum completely disappeared. So there are a lot of these things which we can target, provided we know and understand the pathophysiological process, and for that we need to investigate this patient.
Thank you, sir, for fueling our knowledge with this great session. I request our speaker and chairperson to proceed to the felicitation dais. Our next session is on molecular diagnostics and pediatric infectious diseases. By allowing detection of pathogen not or difficult to cultivate, molecular methods have revolutionized diagnosis in pediatric infectious diseases. Let's boost our knowledge regarding the same from Dr. Dhanya Dharmapalan ma'am, who has done her PG diploma in infectious disease from Oxford, UK. Ma'am is on editorial board for various pediatric textbooks and is a member of IDSA ESBID. Now I invite our chairperson for the session, Dr. Sadhna Patil, Dr. Tripti Mahatme, Dr. Shalaka Bagul, onto the dais. Over to you, ma'am. Dr. Dhanya Dharmapalan, ma'am.
Good afternoon. So, while we are living in a digital world where speed and accuracy both are crucial to us, how can we lag behind in the investigation of a microbe that causes infection in humans? And why not, especially when the microbes itself have become high-tech and going to the space and infecting our astronauts? So today, my talk is on molecular diagnostics in pediatric IED. I thank the organizers for inviting me. So to begin with, I'll not talk much about technical aspects, but just one slide on what we mean by PCR. So because that's the basic of microbiological technology. So nucleic acid is extracted from the sample, and the single nucleic acid is amplified through polymerase chain reaction into millions of copies. So what happens in this is basically 3 steps where the DNA template is heated up to separate the DNA strands, and then primers are added which will bind to the specific target regions of the template, and then the last step of synthesizing where polymerase is added and it extends the 3 end of the primer to form new DNA strands, and this cycle is repeated to form exactly same copies of the target DNA. So let's just leave aside the technical aspect, and I'm an ID consultant, and we just talk about how it applies to us in clinical practice. So the basic use of molecular technology is basically to diagnose infection and it to help us guide treatment. So let's see the simple case, because I think flu is very much there in Mumbai. I'm sure it's there in Navi Mumbai. And you might have hospitalizations. For example, this one-year-old was hospitalized since 3 days with high fever, poor oral intake, has flu-like symptoms, a lot of coryza and cough. And in the city, you have heard that there is flu outbreak going on. Now the question is, do you test? So there are clear guidelines by CDC about testing. So it's not that you need to test every child, but in case if you look at the algorithm and if the patient is admitted to the hospital and then do look at the underlying condition, if the child is immune compromised or in a has risk for severe progression of the disease, definitely test. But at the same time, please note that you are allowed to start empirical oseltamivir in this situation, but you should not delay the starting for want of report. Now, I work in a place like Apollo where you get the report within 3 hours, but that's not possible outside. So you don't wait for the next day for the report in such a patient when it is fitting exactly like flu-like syndrome in the background of flu outbreak. But then why not give oseltamivir to every child who presents with fever during flu outbreak? It is not needed, and one must remember that even back in 2009, 5.5% resistance was detected in children to oseltamivir. So we have the responsibility to use the antiviral also judiciously. Now, suppose you want to investigate, you have decided you want to send a flu PCR. The question is, of the available tests, would you only send influenza or would you send the multiplex viral respiratory panel? So whether it is targeted versus multiplex PCR. Now in this case, since there was a high background of epidemic outbreak, and then we just, since it fitted with flu, we went for a targeted one. But sometimes if there is co-circulation of other viruses and you're not really sure whether it's flu, you can go for a viral respiratory panel. So this nasopharyngeal swab or throat swab specimen, I don't have to talk about because everybody knows, even the common man knows post-COVID pandemic. But it's basically useful only for viruses and only atypical bacteria. I want to stress on that. I'll come to that. But if there is delay in transporting to the lab, then you can keep at room temperature the swab for up to 4 hours, refrigerate for up to 3 days, and you can even keep it frozen for up to 30 days. And you must have seen the medical representatives of the different companies come up with these panels, and you have a whole set of viruses and atypical bacteria. This is from BioFire that I have shown you, but there are many diagnostic companies with different panel. So within an hour or so, you kind of know which virus your patient is suffering from. But in general, we must remember that of this, it is usually the SARS coronavirus or influenza or parainfluenza or RSV, which are actually true pathogens, and you can actually ignore the rest. As you can see from this paper, which say that rhinovirus, Boca, etc., you can just ignore, as well as if you see adeno here. Now, we had a huge outbreak of adenovirus last year, and I'm sure it happened in Nashik also, right? Did you see adenovirus? Many cases, okay. So this is a similar clinical scenario, 10-year-old, high fever going on for a week, open mouth breathing, you even had exudates on the throat, and an adenovirus outbreak ongoing, and TLC high, CRP high. So what we found is, because the CRP was done and it was very high, we all know at the same time adenovirus causes high inflammatory elevations, but here is a situation where there's a tendency then to start an antibiotic. So we would send a panel in those hospitalized adenovirus patients, and when we would detect adenovirus and explain to the parents that this is the cause of infection, it is not a bacterial infection, and your child would settle down, we would give symptomatic treatment. Counseling does help to avoid antibiotics even if the CRP is high. But sometimes it can be tricky in very sick patients. So now in this report you can see there is also human rhinovirus detected, but as I said, you can just ignore that. Then this is another case report where you can see adenovirus. This is from another company. And you can also see H influenza detected. So what would you do? Would you treat? Do you think it is a co-infection? So this is what I want to drive home today, that if it is an upper respiratory tract specimen, please do not be carried away by bacteria being detected from the throat. So atypical bacteria is okay, but not, you don't actually treat. You have to clinically correlate, because children are known to be colonizers of Streptococcus pneumoniae and H. influenza. So I repeat, do not treat bacteria except atypical just because it came positive from an upper respiratory tract specimen. Okay, you need to kind of correlate clinically. And this is the poster we presented in ESPID in Copenhagen this year, where we just, we retrospectively looked at our own cases of adenovirus positive, where we had a mean CRP of 54, and we had given antibiotics only for 8, out of which 2 were irrational, but 2 because they were sick, and 2 had otitis media, and 1 had a patch. So it is possible to do antimicrobial stewardship based on, I mean, molecular test does support you and give you the confidence to go by. And this is an algorithm we published in IJPP. What do you do when you have a co-circulation of, several viruses which can cause influenza-like illness? It could be COVID, it could be adeno, it could be flu. So again, in our algorithm, you'll see we have done the stratification based on whether it's an OPD patient with mild symptoms. You don't even have to test. But if it is a child with comorbidity, then definitely you can check and even start oseltamivir during a flu season. And of course, when there is pneumonia and desaturation, or the patient is in shock, the algorithm goes differently, where you need to be more aggressive. So, the take-home message, that whom to test, whom to treat. Now, coming to lower respiratory multiplex panel, basically this is the pneumonia panel, bacterial pneumonia, if you want to find out which bacteria. But the problem is that the sample required is actually the sputum, or the endotracheal tube aspiration, or the BAL sample, and the other two become very invasive for children. And so its application is more to do with, ventilated, intubated children, rather than difficult in an OPD setting, even in IPD setting. And there are limitations of the panel, because there is low scope for specimen quality check. You don't know whether you are testing a saliva or you are testing a sputum. There is higher scope when you do gram staining, but lower scope when you are doing a molecular test. You can't differentiate colonizers from true pathogen, like what we discussed, Streptococcus pneumoniae, H. influenza, or there is a chronic tracheostomy. There will be a lot of colonization. You can't differentiate with the true pathogen. And of course, when bacteria is outside the molecular panel, you might just miss it if you don't do the culture. For example, Stenotrophomonas is an important pathogen for ventilator-associated pneumonia. Now coming to the CSF panel, again you have a nice panel, and CSF, it is extremely useful, agreed, but at the same time, remember, it is still not the one-stop solution. You don't have viruses which cause low viremia, you don't have Japanese encephalitis, you have to do IgM antibody, ELISA capture antibody in the CSF. So regarding the transport, CSF has to be transported as early as possible, but you can keep it refrigerated up to 7 days. So these are just example of some reports of our patients, like this person was detected with varicella on the CSF without any clinical signs of the illness. So that there the molecular test becomes really beneficial, because you never suspected varicella in the first place, it comes positive. And similarly, mumps can also cause encephalitis without clinical manifestation of mumps, but these are unusual, certainly. And then you have a sepsis panel, which has a whole lot of, it's like you have a menu of gram positive, negative, yeast and even antimicrobial resistance mechanisms which can be done from the isolate of a blood culture colony. But then how do you manage with that report? So like we all know that AMR is how AMR happens is the bacteria, they produce beta lactamases. So you have serine and metallo beta lactamases. Now of these, fortunately we have CARBA-X gene expert which can detect few of these mechanisms like all of the class B, WIM, IMP, NDM as well as KPC. So how does it apply to us is in India we have more of NDM and OXA48 mechanism of resistance in our gram-negative bacteria. Now this is a case, a 2-year-old who was admitted in our hospital and the blood culture grew Klebsiella pneumoniae. So what do you do in that situation is you do a CARBA expert, you ask the lab, it's not very expensive, and they give you a report like this, NDM detected. Then you know what to give. NDM, it's best, first line is ceftazidime, avibactam and astronome combination. If the same child had OXA48 detected, it would be ceftazidime, avibactam alone. So it helps to guide the treatment in such septic children. Now this is another case of 15 days admitted in our NICU, started on meropenem plus vancomycin, and you get a call from the lab that the blood culture is growing gram-negative bacilli. The identity will be available only next day. So the question is, do you escalate? Are you, because you're worried about whether you want to cover for CRE. So you asked for the CARBA gene expert, but none is detected. But I want to caution you that you should also do these steps. First of all, you know it's gram-negative bacilli, so you can immediately knock off vancomycin, it's not needed. The second thing is you ask the lab if that bacteria is lactose fermenter or non-lactose fermenter. This is very important. If the lab says it is non-lactose fermenter, then you can't go by the report because there will be additional mechanisms of resistance. So you again need to clinically correlate. If the patient is deteriorating, you might have to escalate the antibiotics in such a situation. But if it is not, like the previous case we saw, Klebsiella pneumoniae, you can directly go as by, whatever the report is telling you. So which are those non-lactose fermenters? These are the non-lactose fermenters, Pseudomonas, Acinetobacter, Baumannii, Stenotrophomonas and Burkholderia. Now this one was non-lactose fermenter and turned out to be Burkholderia. So it really helps you to take quick actions in the field, these molecular tests. But there can be genotypic and phenotypic discrepancy because and also mechanism of resistance may not be detected by the panel. So therefore, cultures continue to be gold standard. Molecular tests cannot replace cultures. Tuberculosis, I don't even have to mention. We all know that what a game changer molecular tests have been. And we all know about expert MTB assay. And you quickly, within hours, you know whether the TB is there, whether there is rifampicin resistance. And you have expert ultra, which has greater sensitivity. And you know the resistance report within 80 minutes, even prior, this is shorter period than expert MTB rif assay. And then you have XDR assay, which gives resistance to iron-H rifampicin, aminoglycosides, fluoroquinolone, citronamide. Then you have line probe assay for rifampicin and iron-H resistance. You have MTB-DR plus for fluoroquinolones and aminoglycosides. You have whole genome sequencing in tuberculosis. For the newer drugs like bedaquiline, delamanid, and linezolid, etc. Also, you can find out the transmission network in the community from where the child got TB from whom. And then there are advanced molecular scissors or tools called as CRISPR, which can actually detect MTB directly from the body fluids, and very small volume is required, quicker than GeneXpert, and it's a very promising tool for children. So this was one of our cases. Just to give an example, a child with pericardial abscess, you can see that it is MDR rifampicin resistance was detected. So we went ahead with a line probe assay because it was smear positive, and then you had the resistance detected for fluoroquinolones and aminoglycosides, saying that this is an XDR TB patient. But when the culture reports came, we found that aminoglycosides were sensitive. So again, to reiterate that there can be genotypic, phenotypic discrepancy, and you go by finally by what the culture tells you. And we have written about this in detail with Dr. Sushant, and we have kind of written more about molecular tests. Those who are interested to know more about TB, how you can use it, please, you can go to the paper published in Pathogens. Now, regarding tropical fever panel, I get many queries about this panel. My take about this is, it gives you these identification of these pathogens if a febrile child comes to your OPD. But I'm not personally a big fan of this because you have very good point of care tests. For NS1 for dengue, rapid malarial antigen for malaria, salmonella anyways culture picks it up in 48 hours. So as such, you're left behind with West Nile virus, you don't see the West Nile virus, and chikungunya, rickettsia, leptospirosis, again epidemiology helps you. So I'm not a big fan, but this is another panel that I must mention that is being promoted, promoted in molecular technology field. Now, new generation sequencing, I regret that I missed the oration, but I won't, but I will talk about it from ID point of view. So you must be already familiar with these terms, whole genomic sequencing, metagenomic, and targeted. I won't go into it because I don't know if it has been covered in the afternoon. But basically, it requires from the DNA extraction, there's a library preparation of, multiple of DNA fragments are sequenced at a massive platform in a NGS sequencing instrument. And you have like a plethora, about more than 1,000 different pathogens that can be detected by NGS, including bacteria, fungi, virus, and parasites, results in few days. And you can store the sample from the plasma sample even up to 6 months in cold storage. So the specimen can be either plasma, CSF, or a tissue. And is it exciting to tell you? It is not that it's kind of again a one-stop solution. It's just like finding a knee in a stack of hay. And the question is there really the needle inside the hay, or are you going to mistake a hay for a needle? So these things are absolute possible for NGS. But the recent European guidelines for treating brain abscess, deep-seated infections where you can't aspirate the abscess, they do mention, but on conditional basis because of these buts and ifs for next generation sequencing. So then where is it indicated? Only if there is clear identifiable focus of infection, because just because it is a PO, you need to still be sure you're still considering infection and it's not malignancy, it's not rheumatological cause. And say you have a deep-seated abscess in the brain and your imaging is shouting out, this is an abscess, and you don't know the cause of it and you can't aspirate because it's going to be very tough. In such situations, NGS does help. Or you have culture negative infective endocarditis, you have done repeated cultures, it has come negative, and you're going to give prolonged antimicrobial course. Only in these situations, basically, next generation sequencing helps. And there are limitations. False negative results, doesn't discriminate commensal and colonizing organisms, does not provide susceptibility data, which is important in this era of AMR. And then we looked at how there is discrepancy of genotypic and phenotypic resistance. And there are tests which will detect only those pathogens which have DNA, but might not be able to detect HIV, hepatitis C, Zika, or corona, which have RNA. So there are a lot of issues with NGS also. Now, monitoring treatment, again, I don't have to really talk about it. We all know that CMV viral load can help you in monitoring treatment. You give IV ganciclovir. If the log value goes up, you are dealing with resistant CMV infection. After 2 weeks, if you retest, and then you can go for alternative antiviral. So there are applications based on quantitative viral loads, whether it is CMV, adenovirus, or EBV. Epidemiological investigations, again, everybody is aware of what happened during the COVID pandemic. The molecular tests have helped us to know what variant, what is the evolution, what was the transmission across the world. Various global repositories work together to make us understand better the novel coronavirus. And we also did a small our part when there was acute pharyngitis outbreak in Navi Mumbai. We did a whole genome sequencing of the isolated Streptococcus pyogenes, which became India's first genomic data for group A Streptococcus. And we found that there were few isolates which harbored the ERM gene, that is resistance for macrolides. But our isolates are 100% sensitive to penicillin. So amoxicillin remains the first line for pharyngitis. And recently, we had an outbreak last year of hand-foot-mouth disease, where we would not understand why there was extension to other parts apart from hand-foot-mouth. We had lesions in the axilla, severe lesions on the trunk, and it was molecular tests that helped us to find that it was CVA6, which was responsible in Navi Mumbai, whereas in rest of the parts of India, it is CVA16. Coxsackie A6 is known to have unusual manifestations, and also why our children got repeat recurrences in the same season. We found that was because of co-circulation of two viruses, A6 and A16 Coxsackie, with probable less cross immunity with each other. So these questions, we have published the research papers, and one was published just last week with the help of support from ICMR and NIV Pune. So this is my last slide, that what are the practice points then for molecular diagnosis. So as I explained, first of all, you need to consider, is the patient right? I mean, do you really need to test your patient? Does that patient fit into the syndromes or the pattern which Dr. Mukesh Desai sir talked about? You should look at patterns. And if you want to test, are you taking the right specimen? Are you taking the, are you by error taking the upper respiratory sample to detect the lower respiratory pathogen? So that is one. Second is, you need to be cautious of possibility of pathogen outside the panel. We looked at how, the molecular test doesn't detect Japanese encephalitis, for example, in meningitis panel. And they are not replacing culture. So that is a big take-home message, but it supports greatly. So culture still continues to be gold standard. And if you must optimize the molecular test. The patient has spent so much. So let you optimize so that you cut down on unneeded antibiotics when you have used the latest technology to find out what pathogen it is. And unfortunately, we cannot escape from that last line, which is present in every radiology, every pathology report, and also it will be for the molecular reports. Kindly correlate clinically. Thank you so much.
For vancomycin resistant Staphylococcus aureus, apart from linezolid, do we have options available here in India? And second question is, what is the therapy for colistin resistant Acinetobacter baumannii complex?
Okay, so vancomycin resistance linezolid, we do have daptomycin available. So that's the answer. Then regarding ceftaroline, which
Ceftaroline,
has come in the market, I think you can import it. I heard of people saying that is useful, but I mean, it is available, but I haven't yet used it. It might become available. It's FDA approved, should come. And the second question was, sorry? Colistin resistant Acinetobacter baumannii, and that's tough because you don't have cefderichol and other, I mean, you might have to import them. You have to just go by the culture, susceptibility data and work around it. That's tough. I mean, there are patients dying due to colistin resistant Acinetobacter. If it is tigecycline is the next tigecycline or monocycline, that would be better. Tigecycline is not very good for bacteremia. It is more of minocycline, which is better for bacteremia. Tigecycline could be for localized infections.
Thank you, ma'am, for the wonderful session.
Thank you.
I request our chairpersons to kindly accompany ma'am to the felicitation area. Allergic diseases are amongst the most prevalent diseases worldwide, and the burden of these diseases continues to rise. An accurate diagnosis in some patient requires the use of appropriate test. But nowadays, this test has not remained for some patients, but being ordered every here and there without knowing where the test is actually needed and how to interpret the results. So to know the merits, demerits, and the importance of this test, I would like to call upon the expertise of this field who have given a tremendous contribution in the field of allergies, the very knowledgeable Dr. Vikram Patra sir on stage. I would like to invite the chairperson for the next lecture, Dr. Nitin Birla sir, Dr. Abhiraj Pawar sir, and Dr. Amol Murkute sir on the stage.
Good afternoon, everyone. Thank you, organizers, for giving me the opportunity. And thank you to Dr. Amol Pawar for suggesting the topic. Actually, I was confused on what topic I should talk. So he suggested me to go for a topic which will be useful for pediatric practice. So basically, we know that our practice was still more of infections. But in near future, our infections are going to go down and allergies are going to increase. So, is it important? And is it an easy job for a busy pediatrician? And we know all of us are very busy in our day-to-day OPD. So, is it easy? So, I say yes, definitely. And one may wonder, and even all may think, then कुछ भी बोल रहे हैं. So, but my target is that at least some may get the answer how to approach. So why do we need to diagnose? Let us go through the Indian scenario from this study. The rate of asthma in India is 33.6%. And if you ask me the total allergy prevalence, 1 in every 5 person is having some or the other kind of allergies. And this prevalence is increasing. And as I mentioned, it is prevalent. Not only that, it is progressive also. Now I differ from our pulmonologist friends that control is as good as cure, but the disease is progressive. We may come out of the childhood condition, but our kids may grow up as an allergic adult. So once we know the diagnosis, our next plan will be having avoidance, having pharmacotherapy accordingly, and then going for specific desensitization therapy. And what if we don't diagnose at the time, the disease is progress, and all of us know about this atopic march. So a child who presents to us with atopic eczema in the infancy, later on can present to us with food allergies, and later on asthma and allergic rhinitis. And mind well, the child can outgrow asthma by say 7 to 10 years of age, but allergic rhinitis is going to prevail for lifelong. And allergic rhinitis is not a disease itself, it hampers quality of life very much. And moreover, if we don't treat below 4 years of age, remodeling of airways takes place, and we know that there is correlation of pediatric asthma with COPD in future. And as a pediatrician, we will not be there for him, but definitely he may curse later on that my pediatrician didn't diagnose at the right time. So coming to the diagnosis of allergy, to establish IgE mediated, basically whenever we talk about allergy, mostly it is IgE. For that, good clinical history is important, followed by physical examination. And we have to think clinically only. I'm not going to come out with many tests, but definitely I'll go through. But main is to have a good allergy questionnaires, a specific allergy questions needs to be asked. And then our tests are going to just support our diagnosis. Without having history, just thinking you should not jump for investigations. And we all know various allergy symptoms. We'll go through some cases. A common case, 15-year-old girl complains of abdominal pain and vomiting after taking a glass of milk repeatedly. But she tolerates curd, buttermilk, and even milk-based sweets. So what is the diagnosis here? Anyone? CMPA, anything else? Now purposely I put this case, not every patient is allergic. Now this is, remember, food allergies are more common in younger age group. And most of the food allergies, if I take into account the milk protein allergy, they outgrow. Even IgE mediated food milk allergy, they outgrow by adolescent. But this is 15-year-old child and who has presented with milk. The one important point I'll highlight here, she tolerates curd, buttermilk and milk, other sweets. In IgE mediated or milk allergy, they will not tolerate a single drop of milk or milk products. Okay? So this is milk intolerance. They may tolerate little bit of milk, but if it exceeds something, they will have particularly GI symptoms only. Whereas when we talk about allergies, we'll have multi-system involvement. Besides GI, they can have wheezing episodes, they can have atopic eczema, even in IgE mediated, they can have urticaria. Now I'll skip this slide, as I mentioned in brief. Now, why I mentioned this case, because many of the lab people may come out with and tell you about this panel, the food intolerance test, the IgG based test. This should never be recommended or asked for, because this is IgG. And again, is it going to show us anything? No, IgG just tells you that the child has tolerated the food item. So never order IgG mediated. Then what to do, we'll discuss. And falsely they claim that it is doctor recommended, you can see. Now when we think of allergy, now during our seasons, we all are frustrated with the parents' same question, why my child is getting recurrent respiratory symptoms? And when we get these questions, we should think of. Let us go briefly. This case, 5-year-old child, day 1, day 2, fever of approximately 101, having cold and sore throat. By day 3, day 6, cold becomes little thick, and by day 7, day 10, it becomes again thin and disappears. What is this? This is typical of a viral illness. But in our child going to early school, nursery or playgroup, they can have this kind of symptoms. Always ask. You have consulted them, after 3 weeks they come and they say, Sardi khokla thikas nahi zala. Maybe they want to save on the consultation fees. So, but remember, ask and go into the deeper aspect. Whether the symptoms were coming down and again increased, or it is same. So if they say, and then you tell them, if it is not coming down, we'll go for investigation. Immediately their answer will change. No, doctor, thoda sa kami zhala hota. That kami zhala hota means, again the child has got some repeated infection, and to the tune of 7 to 12 episodes, even 50% more, 18 episodes in a year is also common in younger age group going to day school. Now then, this is what we get, as I mentioned, 7 to 12 episodes in a year. So this is expected, and this is URTI. This is, never think of allergies. what I am showing here, in between the symptoms are absolutely normal. The child is fine. Even for a week, even for 15 days, if the child has no symptoms, don't think of allergy. But ask questions, how was the child in between? On running, on laughing, or on crying, on exposure to anything, any irritant, is the child coughing? Then, yes, you should start thinking of allergies in such case. Now, coming to a case, mother of Aryan asks, the child has got recurrent cough since last 1 year. And as an infant, infrequently the child used to have cold and which used to vent chest. Simple, sardi छातीत गेली. आपण म्हणतो ना तसंच. Then every episode started with a cold and sneezing. And then Aryan often had earache and multiple course of antibiotics for the ear infections. Then as a doctor, you ask about, is Aryan a mouth breather and snorer, because otitis is associated with adenoid hypertrophy. Now, you have to come out with the diagnosis. The child is having adenoidal hypertrophy with wheezing. Then you say that Aryan has asthma. काय होणार? लगेच पेशंट दुसऱ्या क्लिनिकला. Asthmaचं नाव ऐकता ऐकता ते पळतात. Then similarly, the mother, nobody told me that. See at the exclamatory marks, how many exclamatory marks I have put. So my previous doctor called it allergic bronchitis. Maybe he was clever. He didn't use the word asthma. And some doctor also mentioned asthmatic bronchitis. Our radiologist friends also, they write pneumonitis, like. So prove that. Don't hesitate in saying the diagnosis, because remember, पुढे जाऊन तो blame करेल आपल्याला diagnosis नाही केला म्हणून. Make it an objective diagnosis. Asthma कसं होऊ शकतो? Now, how many of us we use spirometry? Is it very common? Commonly used? It is very out of reach to us. So what we have, we don't have spirometry so easily available. And oscillometry is further. We as an allergist, we use oscillometry even in younger age group. But all of us should use this PFR, the breathometer, what we get from the Cipla or any other company. Hardly 500 rupees. And all wheezers, a child who is more than 6 years of age, ask them to keep this thing. And you show the bronchodilator reversibility. You ask them to blow with that proper technique and give nebulization and again check. If there is reversibility, they will get convinced that the child has got some reversible obstruction, airway obstruction. This is the normal formula, but we have chart, and but it has to be at the personal best. It is 100 plus 50 for each 100 centimeter height. Now coming to the basic of allergy, we know IgE, it is sensitization and production of IgE. IgE binds to the mast cells, and on re-exposure to allergens, there will be degranulation, histamine is released, and histamine causes all the allergic symptoms. So investigation, coming to investigation. Dr. हेच तर महत्वाचं आहे. Investigations. So investigations, we have screening test, blood eosinophils, nasal eosinophils, serum total IgE, immunocap Fediatop, and then definitive specific tests are serum specific IgE, skin prick test, patch test, intradermal test, and component result diagnosis. What are these actually? These are to come out with the diagnosis as well as to know what allergy the child is having. Now we know all these tests, majority of these tests can be done by our pediatric friends only. And this is the domain of an allergist. So we'll not discuss the detail of those things, but what we can do in our day-to-day practice is total eosinophils. We all know we go for CBC. If eosinophils are more than 4%, then you think of. And this is very commonly used, like Montelukast. This is one of the abused investigations. Why I'm saying so? We were knowing that total IgE is equivalent to allergy, but IgE is not only for allergens, it is also for parasites. So whatever IgE levels we are measuring, that is having IgE against allergens, but also against the parasites. Or may not be allergy, only parasites in our country. So you may get a false high value. So that's why it is of no use. Then what should be done? Then the newer test, I suggest everyone should start writing this test, immunocap Fediatop screening. Now, as I mentioned, IgE is IgE against allergen and IgE against parasites. So immunocap is IgE against allergens only, but not to what allergens, right? It is the pool of allergens against what IgE is mentioned. Now, this is not very costly. If you are going for IG from a standard lab, Metropolis type of thing, around 1,000 rupees. And there is the allergy screening test for more than 5 years and less than 5 years. They have, the cost will be approximately 1,200, 1,300 only. So by giving only 200, 300 extra, we are coming out with this. And what pool of allergens they are including? As I mentioned, less than 5 years, food allergies are common. So they have included the food allergens in the infant Fediatop. And in the adult one, they have included aero allergens particularly, because we are going to deal with asthma and so if you are thinking of food allergy, just this is the best test for screening. Now this is a flow chart made by me. So if you are thinking of clinical history, always go for IG plus Fediatop. If total IG is increased as well as Fediatop is increased, you know this total IG is because of allergy, and think of underlying allergy. Do further evaluation to know what allergen and start allergy treatment. But if total IG is normal and Fediatop is normal, revisit the history. Still there is a possibility of allergy, and if history is not correlating, discard. Don't think of allergy in this patient. But if total IG is increased and Fediatop is normal, can this happen in some allergies? Yes, because that is just a pool of few allergens, immunocap. But most common allergens are included. So still it is a possibility, if history suggests you, go for further evaluation and start treatment as per allergy protocol. Then comes the skin prick test. Now, what is further evaluation? Further evaluation is to come out with the what allergen it is involved. So if what allergen is involved, what is the use? As I mentioned, you can have avoidance measures. And if the allergen cannot be avoided, you can go for desensitization therapy. Then, but whenever it is, this is basically done by allergist, but whenever you are sending a patient for skin prick test, always remember the child should be off antihistamine. Now this is we place allergens, and we introduce with a lancet the allergen into the epidermis, and we get the wheels, proper wheel size, and whatever allergen it is possible, we will get this kind of wheels, and then the diagnosis. And this is considered to be the gold standard for diagnosing allergy. But and this is for prick. Now many times they say, "Mala banana ची allergy, केळी खाल्ल्याने मला कफ होतो." So this is to show that केळीने काही allergy नाही आहे तुम्हाला. But basically, they're wrong. Myth is there. Many of the parents, they stop all these things. So, but coming to back to the pediatrician, आम्ही काय करायचं? We have serum specific IgE. Now, serum specific IgE is in vitro measurement of particular allergen. Now, if you are thinking of it is a case of milk allergy, you don't go for any panel. You just order serum specific IgE for against milk by immunocap method. So you'll get the value. So immunocap is the preferred method. But remember, never orders, again the lab people will come to you, comprehensive allergy panel, non-veg panel, veg panel. Don't go by history. The cost from range from 8,000 to 16,000. And just when you go for a specific IG, it will be approximately 1,200 rupees. So if you are thinking of 2 or 3, send only 2 or 3. But again, the history is very important. So serum skin test and this thing, serum skin prick test is cheaper. Serum IG is little costlier, but easy for kids. Serum skin prick test is difficult to perform in younger kids, but we have done for a 6-month-old child also. So to summarize, suspect allergy, detailed clinical history, symptomology, causal relation is very important. 2 दिवसामागे काहीतरी खाल्ला होता, आज today urticaria presented with urticaria. Never. Urticaria will present within 2 or max 4 hours. So never think of urticaria or causative unless uselessly we blame on something. Screening test can be done by all. It's not an allergist domain. Pediatrician domain is allergy pharmacotherapy, and avoidance measures can be started by pediatricians only. And timely referral to allergist for confirmation and allergen specific for desensitization if you are planning. If allergen cannot be avoided, then we have to refer to allergist. Thank you.
Thank you, sir, for such an informative session. I request our chairperson to kindly accompany sir to the felicitation dais. Our next session is on common pediatric surgical emergencies
May I call upon our speaker, the wonderful, down-to-earth man, Dr. Satish Kapadnas, sir, to drive us into the heart of the matter with pointers for early diagnosis and early referral. I also invite our esteemed chairpersons, Dr. Babular Agrawal, sir, Dr. Atul Bonde, sir, and Dr. Swati Wag, ma'am, onto the dais. Over to you, sir.
So, this is the last lecture of the conference. So, I must say, how's the Josh? अरे नाशिक करानी तो बोला. So, good afternoon, friends, colleagues, and respected seniors. I would like to thank organizing committee, scientific committee, for giving me this opportunity to present this topic. I am going to present today common pediatric surgical emergencies. I am going to cover the practical points. Now, I am not going to go in details of the operative part. So, आणि स्लाइड कसं करायचं हेच का होत नाही. So when the child is brought by parents to a doctor, to a pediatrician in agony, what the surgical things you have to the things in surgical problems you should look for? We are going to see that. So first is balanoprostatitis. So what is balanoprostatitis? Infection and inflammation of the prepuce. Patient presents with redness of the prepuce, dysuria, pus discharge. Patient complains of difficulty in micturition. So what treatment you give? You generally give hot seeds bath. This is very important, hot seeds bath. It is often not advised to the child. Then you have to give oral antibiotics, anti-inflammatory and antihistaminic. Local application of betnovate and T-bag should be given. And once the infection and inflammation settles, then you can reassess and reassess for circumcision. Then paraphimosis. This is very commonly seen problem in our pediatric practice. It is a forceful retraction of the preputial skin beyond the glans in a patient with pre-existing phimosis. So generally these patients have pre-existing phimosis. There is a constriction ring which goes beyond the coronal sulcus and it acts as a ligature. And there is a, because there is a compression there is a venous congestion, edema. So there is a pain and swelling of the prepuce. The glans is swollen and congested. So it is a emergency kind of situation. Treatment is, you have to do multiple puncture. Sorry. So this area you have to go for a multiple puncture. This is the phimosis part. This is the ring. So this edema has to come down to reduce this ring. So you have to do, with the help of needle, you can just do multiple puncture of this mucosal edema. You have to squeeze out the edema fluid and you can reposit this ring ahead again and advise the hot seeds bath, antibiotic, anti-inflammatory, and again reassess the patient for circumcision. So you cannot leave these patients alone. Just reduce करून टाकला आणि सोडून दिला. We can't do that. You have to reassess again, and if the circumcision is indicated, then you have to go for circumcision. Then acute scrotum. Now what is acute scrotum? Severe pain and redness in the scrotum is called as acute scrotum. Differential diagnosis first and foremost is torsion testis. Second is torsion of appendix testis. Third, epididymitis or orchitis. Hematocele trauma. Idiopathic scrotal edema. The most important thing here is torsion. Rest other things are not emergency. Torsion is an emergency thing. So any patient presents with red scrotum in your OPD, you should go for UHG Doppler of the scrotum. This is the must investigation. Most of the times the parents send a WhatsApp photograph on Sunday and they ask you what should be done. Then you advise some anti-inflammatory and ask them to come on Monday. And by the time the patient comes on Monday, it goes to USG to do the USG. And by the time afternoon the USG is done, evening they meet you. And by the time the testis is gone. And we do surgery at night. So what I'm trying to tell you that whenever even the parents they ask your opinion on WhatsApp, you have to tell them that do urgent UHG. Urgent UHG Doppler is must. They कुठून करतील, that is their problem. But medico-legally, it is very important. You can show in court of law that I have advised, in emergency also, I have advised USG Doppler. So this point I want to stress in the torsion, that treatment of torsion is golden period and all this, they are different things. They are later on. But first thing is that urgent USG Doppler is very important. Another thing, in torsion, you generally get a high riding testis, it is swollen, red, the scrotum is red. Most of the time, there are two types of torsion. One is intravaginal torsion, other is extravaginal torsion. In extravaginal torsion, you get a classical signs of torsion, that high riding testis and everything. But in intravaginal torsion, you are not going to get all classical signs. That there is only redness of the scrotum and the testis is still down. It is not high riding. So again, it is because it is intravaginal torsion, you are going to delay the USG. So nothing doing in any red scrotum, dictum is USG Doppler of the scrotum. Even in our pediatric surgical conferences, most of the consultants are in favor of direct surgery for acute scrotum. Even USG is not. You can directly go for surgery. If it is torsion, you just detort it. If there is no torsion, then it is okay. But saving the testis is most important thing. So again, I told you that high riding testis, different transverse slide, tender with any movement is a classical for extravaginal torsion. You have to keep in mind the intravaginal torsion, which is often missed. So 6 hours is a golden time, golden period. We can say 6 to 12 hours is a golden period. Above 12 hours, there is a generally progressive loss of, because of the ischemia, there is a complete loss of spermatogenesis and theoretical risk of forming anti-sperm antibodies. Now, acute abdomen. Now, again, this is something which is very common. The patient comes with acute abdomen. Most common is appendicitis, then intussusception, ovarian torsion, testicular torsion. GI conditions, most commonly gastroenteritis, Meckel's diverticulum, congenital band. Pancreatitis is more common than psoas abscess and cholecystitis. HUS, HSP are very rare. In renal stone is very common. UTI and pyelonephritis can cause lower abdominal pain, that is suprapubic pain or a flank pain. Pneumonia, again, the subdiaphragmatic empyema, there can cause upper abdominal pain. Metabolic diabetic ketoacidosis, lead poisoning and sickle cell crisis are very rare. So acute appendicitis, it is most common diagnosis you should suspect in any pain in abdomen. Because I have seen in my 10 years of practice that it is often misdiagnosed. It is often not diagnosed. Acute appendicitis. So most important clinical feature is pain, vomiting and later on fever. Loose motion come after 2 to 3 days. It is not immediately. So why it is often missed? It is because most of the appendix, they are pelvic appendix. There are no abdominal signs. So the patient presents with loose motions and fever. Abdomen is absolutely soft. USG may not detect it because it is in pelvis. So I have had 2 patients where USG was suggestive of right side adnexal mass. So one was 3-year kid and another was 8-year kid. So I was wondering why there is a right adnexal mass with some cystic collection there. So in these cases, the history is very important. So I just dig out in the history, and the history was very classical. There was a pain in abdomen. So appendicitis, the first thing to happen is a pain in abdomen. Pain, fever and vomiting. The patient had pain, fever and vomiting, and I traced the previous reports and there was a count which was 20,000, 25,000. So I put in a laparoscope and I saw that there was a pelvic appendix going into by the side of the ovary, and it was forming the collection. And the patient was referred to Mumbai for adnexal mass. Both the patients were referred to Mumbai for adnexal mass. So it is such a common diagnosis, but see what can happen. The patient from Malegaon was directly referred to Tata Memorial Hospital. So that's why I'm stressing more on this, because this is commonest things. You have to think common things first. You have to think common diagnosis first, then go to rare syndromes and diagnosis. So, and investigations, USG is the most sensitive investigation for appendicitis, ovarian torsion. But in doubt, whenever you have a doubt of pelvic appendix, retrocecal appendix, subhepatic appendix, these appendix are not going to give any abdominal signs. Only there will be symptoms. There will be pain, there will be vomiting, there will be fever, but abdomen will be totally soft. So whenever you're in doubt, you have to go for CT abdomen and pelvis. So it is not only abdomen, it is abdomen and pelvis you should order, so that you can come to know. And the picture is, it is seen here. This is USG picture. So CT has a very good sensitivity and specificity for diagnosing appendix and appendicular collection. Most of the time the appendix is sloughed up, there is only collection there. So again, it is with history, if it is correlating, then you should go for surgery. Now, ovarian torsion, the history is again, it is very important. Timing in relation to menses is especially for para-ovarian cyst with torsion. So this pain with constipation, I am going to stress this more, because female patient with pain and tenesmus, there is a constipation. There is a very famous corporator in Mumbai, Shiv Sena corporator's daughter had this symptom, pain with constipation. She had a pain with constipation 2 to 3 days, since 2 to 3 days. She went to local general practitioner, he gave some medicine. There were no abdominal, obviously it's a pelvic organ. Abdominal signs, symptoms are not going to come. So there was only suspicion that why she is having such a pain and tenesmus. PR was normal. So one diagnosis was appendicitis, another diagnosis was ovarian torsion. The CT was done and there was ovarian torsion. But we could not save the ovary as the golden period was gone. But treatment of testicular torsion and ovarian torsion is totally different. I will come to that. So management of acute abdomen, or most common again appendicitis, is intravenous hydration, intravenous antibiotic, broad spectrum antibiotics. Again, laparoscopy is a gold standard for treatment of appendicitis. Even the cases which I told you about the right adnexal mass, the laparoscopy diagnosed it as it was not a right adnexal mass. It was a simple appendicular collection, appendicular perforation with collection. So laparoscopy is gold standard for treatment of appendicitis, and laparoscopy is again gold standard for ovarian torsion. Now the treatment of ovarian torsion is changed. It is not oophorectomy. You have to just open the capsule, drain the toxic tissue, and keep the wall of the ovary as it is. The studies have shown, and we have one study from KEM, about 12 cases, there is a formation of follicles later on. So there is the treatment of ovarian torsion, even the golden period is gone, is not removal of the ovary. It is just remove the toxic material and keep the wall as it is, it will form follicles later on. So intussusception. So this is very common in infancy, especially in infancy. Pain in abdomen, vomiting, blood in stool. Diagnosis is by USG abdomen. Treatment is gold standard. USG guided hydrostatic reduction of intussusception is a gold standard treatment. Other treatments are now outdated. Surgery is done in failed hydrostatic reduction or intestinal obstruction or peritonitis. Makers diverticulitis, when you open the patient or put on a laparoscope for removal of appendix, you may find the Makers diverticulum. Then obstructed hernia. Obstructed hernia, the hernia should be operated at any age. The dictum is hernia, it should be operated at diagnosis, whether it's 1 year child or 12-year child or 5-year child. Why? Because there are chances of obstruction. And obstructed hernia, especially in infancy, can cause testicular gangrene because the vascular supply to the testis is very delicate. So infantile inguinal hernia, again they should be operated as early as possible. Umbilical hernia should only be operated if there is obstruction, otherwise you can wait for 2 to 3 years. Again, midgut volvulus. This is very important. Midgut volvulus in infancy, any child with bilious vomiting with scaphoid abdomen, you should suspect malrotation with volvulus, at least malrotation, and get USG abdomen done. CT is generally done in older children because USG may not pick up the SMA-SMV relationship. So USG is gold standard, and surgery as early as possible, because if you don't do surgery and there's a volvulus, the whole midgut is going to go gangrenous. Foreign body, generally cough and sudden onset of distress. There is a noisy breathing, auscultation, you may get decreased air entry on the affected side. Emphysema, because if there's a partial obstruction, obviously ball wall mechanism, the air gets trapped, doesn't come out, so there is a hyperinflation. And when there is a complete blockage of the bronchus, the distal air gets absorbed, the fresh air doesn't go inside, and that side lung gets collapsed. So, and the X-ray may be normal in case of tracheal foreign bodies. Whenever you in doubt, virtual bronchoscopy is a fantastic investigation. You can order, if you are in doubt, there is no clear cut, there is a history, but the X-ray is normal, there is a doubtful air entry, you can always go for this very good investigation, which is available everywhere in the Nashik, so or any other places also. So virtual bronchoscopy. So this is a short video of how we remove with the latest technique of video bronchoscopy with the optical forceps. This is the groundnut piece is grabbed with the optical forceps and removed. Foreign body in GI tract, again, only the point which I want to stress is cricopharyngeal foreign bodies has to be removed. The narrowest part of the alimentary tract is cricopharynx. So foreign body or coin trapped in the cricopharynx should be removed. Once it passes the cricopharyngeal area, it is going to pass whole alimentary canal. So no need to remove the coin in the stomach. Please note. No need to rush in the operation theatre and remove the coin gela, kada. No. There is no need to remove the coin in the stomach. Button batteries you have to remove because they can cause corrosion. Again, button batteries in the stomach and the small intestine we generally observe. We don't remove them. I don't remove them. Those which are trapped in the esophagus, you can remove them, but others you can observe because once it crosses the gastroduodenal junction, no scope goes beyond the gastroduodenal junction. There you have to wait and watch. Sharp foreign bodies, if they are small, you can wait and watch. If they are bigger, then you have to remove them. Trauma, in pediatric trauma, it is generally a conservative treatment. Liver trauma, splenic trauma, generally it is a conservative treatment if the patient is stable. Surgery is only indicated if the patient is unstable. Bowel injuries in trauma, generally they manifest after 2 to 3 days. They are not seen in initial 1 to 2 days. So if they are there, then you have to go for a laparotomy. Chest, the management is nowadays totally conservative. ICD is inserted only for hemo or pneumothorax. Otherwise, it is totally conservative. CLW use of joint is again controversial. Any injury around the eyebrow or lip, you can use joint. Taking care of the joint should not go in the eye, in eye or nose or inside the oral cavity on the lips. But if the child is very jada naughty rahega, so you have to just take the sutures because I have seen patients coming with joint lagaya but wapas khul gaya. So it is controversial. You can use it, but again you have to explain that if it opens up, then you have to take the sutures. Bleeding PR, commonest is anal fissure. The treatment is conservative. You have to treat the constipation. I generally advise to apply lignocaine and diltiazem ointment for 2 months and stool softener. Rectal polyp treatment is surgical only. You have to go for rectal polypectomy for solitary polyp. If there are multiple polyps, then you may have to go for a colonoscopy and remove. Hemorrhoids are not common, but treatment is conservative. Nobody advises surgery for hemorrhoids. Trauma, again, which type of trauma is there, you have to go. Neonatal emergencies, these are all neonatal emergencies, but only emergency which requires urgent surgery is gastroschisis because the bowel is outside. The duration of bowel exposure to outside is very important. If it is, the duration is more, then the bowel edema will be more. And when you repose it, it is hard to close the abdomen. So gastroschisis is the only surgical neonatal emergency which you have to rush the neonate to operation theatre. Otherwise, CDH, you know that it is a medical emergency, it is not a surgical emergency. Esophageal atresia, tracheoesophageal fistula, you put a Reploglu suction, continuously suction the saliva, do 2D echo and USG KUB, rule out the vectoral group of anomalies, and you can take the patient after 24 hours of birth for surgery. Duodenal atresia is same evaluation and you can operate after 24 hours. Hirschsprung anorectal malformation, no hurry, you can wait for 12 hours. You can give rectal washouts for Hirschsprung and invertogram for anorectal malformation, do subsequent treatment. Sacrococcygeal teratoma is again, if it is ruptured, then it is taken immediately. Otherwise, it is not taken. Take home message, I want to highlight these messages. USG scrotum in all red scrotum. Make it a dictum that if the USG is normal in red scrotum, you are relieved. You are relieved medico-legally also and other parts also, other things also relieved. Then you can treat whatever idiopathic scrotal edema, epididymoarthritis, you can treat that. Most common specific cause of abdominal pain is still appendicitis. We operate more appendicitis than any other surgical condition. Second is intussusception. But surgery for appendicitis is more common than any other diagnosis. Newborn with bleeding PR. Any newborn. In MCH days, we used to, it was bombarding in our mind. Newborn with bleeding PR, if there is a phone call received, immediately tell them that jaldi leke aao. Then do one USG abdomen, rule out malrotation, then you are relieved. Once there is no malrotation, volvulus, then you are relieved, then you can do evaluation of other causes like hemorrhagic disease and all. Gold standard treatment of intussusception is USG guided hydroreduction. Thank you.
Thank you, sir, for such a great session. I request our chairperson to kindly accompany sir to the felicitation dais. As we are towards the end of our conference, I now hand over to Dr. Pawan Devre sir for valedictory function.
Yes. Thank you, Sneha. So, ladies and gentlemen, I thank you all for your generous time and attention. As we reach at the conclusion of this Nashicon 2024 and Maharashtra IIP midterm CMA, to start this valedictory function, I request the office bearers of Nashik IIP, President Dr. Sachin Chaudhary sir, to come on the stage, Secretary Dr. Sachin Patil, Nashicon Organizing Chairman Dr. Ravindra Sonone sir, Founder President of Nashicon Dr. Milind Bharadia sir, Treasurer Dr. Prachi Birari, Joint Secretary Dr. Sonali Pardi to come on the stage. So to start with this valedictory function, yes, I would like to first thank all our pharma sponsors without whom this conference would not have been successful. I would like to call the representatives as I call on their names. Sanshio Pharma. I expect a big round of applause as I take their name. Sanshio Pharma, Zeal, Astrum Healthcare. Please come on the stage. Please come on the stage for the felicitation. This is a token of gratitude from our side for your support. Astrum Healthcare, Ankur Hospital, Zydus Vaccine, Athesis Life Care, Hegde and Hegde Pharmaceutical LLP, Acumentis Healthcare, Excel Meditech, Panesia Biotech, Adon Pharma, British Life Sciences, Nexipox Vaccine, Signutra, Maitri Biotech, Relion Pharma, Gujarat Turs Lab, Pentaglobulin, JP Publisher, Jai Ganesh Pearls, Oxtracare Biotech, Alchem Pharma, Sun Pharma, Indoco Pharma, Alembic and Mackay and Anuradha Collections. Thank you once again for all your generous support.
Calm your mind with chakra based meditation music.
If at all any pharma partners whose name I have not taken